Okay, Assalamu alaikum, Bismillahir Rahmanir Rahim. This is Dr. Professor Mohammad Wase. I'm one of the host and organizer of this first OIC International Conference of Neuroscience. And before we move to the third session, which is going to be happening maybe 3 minutes from now, I'll just give you a recap of what we did yesterday. So there were two sessions yesterday. Session one was related to burden of neurological diseases in some of the OIC member countries. So we have a presentation from Dr. Habibur Rahman related to Afghanistan, Dr. Shahriar Nafisi from Iran. I did present from Pakistan, and Dr. Hamidun Basri from Malaysia, and Dr. Sharaf Nurostuk from Turkey. And this was a very important enlightening session. We learned that how neurological training and care differs from like region to region. For example, Afghanistan, they have only 2 trained neurologists in the whole country, which is about 40 million. And there's no training program. There's not much availability of medications and care, stroke care, and those kind of things as compared to Iran and Turkey, which are very developed in terms of number of neurologists. Turkey has like close to 5,000 neurologists, and Iran has about 2,000 neurologists. Malaysia and Pakistan, they are kind of in the middle. So neurological care kind of changes from part of the one part of the world to the other part of the world, where it's very variable. I think most important part of that most of the countries which have very good neurology training and neurological care program, they are willing to work with the other countries where it's pretty undeveloped. So that was an important message we learned, that they are willing to come out of their country and help, especially some of the Asian countries, Central Asian countries or African countries, where neurological care is very little or minimal. The second session was related to stroke care. And that was also a very important session because it's a very important aspect of our part of the world. So the presentation was related to Dr. Sohail Al-Rukn, was supposed to present stroke care in UAE. He was not able to make. Dr. Maria from Dubai, she discussed points related to stroke care in UAE. Dr. Fahad Abdullah, who has been part of the African Academy of Neurology, and he has been a director of the World Stroke Organization. He presented his data related to stroke care in Egypt. Amal Hashmi presented stroke care in Oman. Yohanna Kosuma presented stroke care in Indonesia, and Hussam Al-Jahani presented stroke care in Saudi Arabia, and Attila Özkan Özdemir presented stroke care in Turkey. So that was also very important, enlightening session, and we learned that how much we can learn from each other. Like the interaction during the sessions was very effective, and we did learn a lot about each country's healthcare system and stroke care system. And the very important that message was that how can we work together or collaborate in terms of improving stroke care in our part of the world. So that was the recap of yesterday. Now, today we have 3 sessions, and the first, and I think one of the most important session of this conference, which we are going to start, is improving neurological training and care in Africa. And OIC, as you know, that it's 57 countries, about 1.9 billion population, and OIC has a very strong presence in Africa. So a lot of African countries are part of OIC, and a lot of these countries are either middle income countries or low income countries, and they suffer from care issues and training issues in Africa. Now OIC is very much committed to improve neurological care and neurological training and education in Africa, and this is a part of this OIC international conference, that we want to start a training and neurological care upgradation and education in Africa. And that's what the target of OIC is right now. So I think this session is going to be very important for future OIC goals and future OIC prospects, that how can we work together with these countries and OIC to improve this care. So today in this session, we have 5 speakers, and these are all 5 great speakers from Africa. And fortunately, all of them are my friends. So The first speaker is Dr. Riyad Guidar. I will introduce him to you in just 1 minute. And the second speaker is Dr. Mustafa Aloy Fares. He's from Morocco. Osama Yassin is from Egypt. He runs the MENA Sino Group. And Augustina Fali is from Ghana. She is the African Academy of Neurology president. And Dr. Saidi Oshek Saidi, he is based in Sudan. And he is also a famous neurologist. He has worked with us in very different groups related to neurological care in Africa. So these are 5 different countries of Africa. But these the guys who will be talking to you, they are not just one country. They just represent the whole African, and not only the whole African, but even World Federation of Neurology and Global Neurology. So the first speaker today is Professor Dr. Riyad Guidar, who is a friend of us. He has been to Pakistan, and he has been part of the African Academy of Neurology. He has been the president of Tunisian Neurology Society, and he has been the trustee of World Federation of Neurology, very active across the globe for neurological training and neurological research and neurological care, and very active in the African region. So he will be talking about improving neurological training, care, awareness, Africa, and advocacy in Africa. Dr. Professor Riyad Guidar.
Thank you so much, Mohammed Osai. Thank you for this kind introduction. It's my pleasure to begin this session while speaking on research. While it's, I would say, come usually at the end, but that's no problem. And you have here Tina, which is the running president of AFAN. She can give more details on aspects that perhaps I didn't develop too lot. It's also a pleasure to be with you. I visited Pakistan and was impressed by your facilities there in Karachi when I visited, and your clinical trial center. So we hope that what you said about collaboration and installing activities together will be a reality. Do you see my slides?
No. Did you share your screen yet or no?
I'll see if it is okay or not. Is it okay now?
It's okay now. You can just put it on the slide share mode.
Yes. Now it's gone?
Yeah.
Okay. So as it's the first talk, I will have some minutes just to put on things. One of the most important things, and I think that Tina will emphasize this, is the lack of neurology relatively to the world in Africa. You see these rates and you see these colors. It's simply a situation that cannot be continue like this. Africa is having the less number of neurological workforce in the for the regions of the world. And when you are on this kind of situation, speaking about research is sometimes unadapted to the situation. And you see that the gap has to be solved with some nations who are on the level C or the level D, which means that there are few or neurologists or even no neurologists in the country. And you see that if you see something which is important, this is a paper made by Fouad Abdallah with Al-Shakir and other colleagues of the number of medical schools. And you see that there are countries that you have one medical school, or even countries that you have not, that are not listed with no medical school. And this is something that also will impact the neurology care, training, and research. As you said, I'm fighting in several parts to this, and I'm now just have been co-opted trustee of the World Federation of Neurology. And the aim of the World Federation of Neurology is promoting global neurology education and training. And of course, there's also research with grant research. And presentation of all this research work on the WCN meeting. As I said, neurology training is a huge lack in our country, and I think that my colleague, my friend Mustafa and Tina and the others will speak a lot about this. I will not go on all these details in order to go more to research. Here you see that there's a problem on the training, but there's a problem of the taking care for the region, with the lack of the human resource, the number of neurologists in the country, the average year of training that you see in some countries is less than 4 years, which is now a problem with the lack of some of the possibility of examination. And really speaking about research in this context will be somewhat difficult. This is the African Academy of Neurology with Tina in it now and Fouad Abdallah in it, which are on this session. This was in Dakar, Senegal, the founding meeting. I think, Tina, that you'd speak about this. And some initiatives that aim to train neurologists through all Africa, like here, an initiative to train 200 neurologists. That's one, you remember it, it was in Tunisia in 2017 with the European Academy of Neurology, a memorandum of understanding there in order to put on trainings and exchanges. That's some activities. And we go, for an example, for this study in identifying key challenge facing healthcare system in Africa and potential solutions. You see that research doesn't exist on this table. The thinking to research is not real something that is considered as a key solution to solve the issues in health in Africa. And there's some disease that you have like dementia where there is no real research but small things. That was as an example. But I will go, this was, I will say, a very dark presentation. Things are not really all like this. And there's, in this relatively dark situation, there's a lot of sun, I will say, shining on it. You see, this paper is neurology in ancient Egypt in Africa. It's just saying that neurology began 5,000 years ago in this lecture. And I just give an example. They made a possibility of anesthetizing people, and they used it especially for animals, and they know the real doses to make anesthesia for people. I was not aware about this. That was what we heard in a museum visit. This is, for example, what happened in Tunisia 50 years ago when people thought that there is no research. That was what Ben Hamida has done on myopathy. I will give just a small example. When he came back to Tunisia, he saw Duchenne-like girl dystrophy, and people thought that he didn't know, even examine, and he turned back that this is severe childhood muscular dystrophy, which was not Duchenne but was similar to Duchenne and was due to the sarcoglycan issue. Osantokun, the new generation, I put it on, doesn't know people like Osantokun. These are people who are fundamental for the research of neurology in Africa, and he made a lot of neuroepidemiology and other terms of epilepsy research, and he was real instrumental on putting on research, for example, in Western Africa, in English-speaking countries. But you have also Michel Dumas. He made a lot of work, and he is still alive, and he was granted a prize on the WFN. That's the photo. And he did a lot of research in Senegal about infectious diseases and other tropical diseases, and put on a neuroepidemiology tropical institute in Limoges. one of the most expensive drug, which is for MSA, is now available in Egypt. It's simply $2 million, one shot drug for MSA, and it's available. So things are evolving. I wanted to put this to say that things are not on the classical figure that people think about Africa and research in Africa. And a lot of things are doing now on neurodegenerative diseases like Parkinson's disease, dementia, amyotrophic lateral sclerosis, and HIV-related neurocognitive impact. And this is to say that we in Africa for the research are on a transition period. We have the diseases due to the infection diseases, the environment diseases, but also non-transmissible diseases who are now taking the lead, with the population becoming more and more old and having hypertension, diabetes, and that. So on the research field, we are on a transition period, and we have to take account this. This is to say that from Africa, for example, you have two people on, I have the honor, and Joseph Kibasho from Kenya is also a member on the WHO guidelines on research on dementia. Stroke is also a matter of research, and Hani Arif and Fuad Abdallah from Egypt, for example, are from the leaders, and you have now leaders from several parts of Africa who are working on stroke and stroke research. The Parkinson, for example, is also a view of research. I give an example. There's a consortium now that is made with England about Parkinson's disease, and including countries like Nigeria, like Egypt, Tunisia, South Africa on this field. But look to this table. It gives some of the problem. One, the problem is that we should have research, for example, for dementia and PD, on the testing that we should do. This test, for example, the neuropsychological and the neurocognitive one, are done in developed countries. They are not adapted to the several ethnies that we have in Africa, and that are not adapted to the different language and the level of the population. And this is a target, adapting research to the continent and to the specificities of the continent, and within the continent, the specificities of the regions. Another time of the research is the availability of drugs. I will speak about later on the clinical trials. It's obvious that not all the drugs that are put on clinical trials on the Western world will work on the same way in the African continent. And this is something that should be outlined to the deciders, that we should conduct the trials in our country. I will speak again about. One other thing is, I spoke about the network on Parkinson. The other network, this is in French-speaking part of Africa, a network on lateral sclerosis amyotrophy, and with paper that has been published, research paper for people from the continent, and especially the French-speaking part. This is the Tropals projects. We are part of it, and Togo is on it, Mali is on it, a lot of countries are on it, and Mauritania, and we have results on the specificities of lateral amyotrophy. I will say one word. The duration of lateral amyotrophy is larger, is more important than in the Western world. The life expectancy with lateral amyotrophy is larger. That's one point, for example, saying that it's not mandatory. What is available on the Western country is true in Africa. That's also something on Parkinson's disease, but in Nigeria only, it's our countries that are making, I will say, research for a country. Because for sake of time, because I don't want to run more than 20 minutes, I will give this paper. We are trying also in Africa to go through new research subjects, which are the characteristics, for example, onset and evolution of neurological symptoms in patients with COVID. This has been published in Neurological Sciences, in 2020, in the first year of COVID. And we have shown that in our population, the early symptoms were not strictly equal that were what were published in the other countries. So one of the most important things Muhammad and Dina will speak about is the genetic specificities that are in this population, or even in the population of the Asian part. This, what is true in Occidental part is not mandatory true. We have a lot of inbreeding, a lot of consanguineous marriage, a lot of recessive diseases. I spoke about Parkinson. The Parkinson in North Africa, for example, 40% of the patients have LARC2 mutation. If you see this mutation, for example, in Europe, it's less than 2%. While it's 40% for a disease which is common like Parkinson's disease. So we have specificities, and the therapeutic response to drugs is not the same with this mutation than the response to from the other mutation. And not only we are speaking about genetics, about biology, about things, but also teleneurology is developing all these ways of communication, and research in teleneurology is developing with this COVID situation. That's to say bravo to our friend from Cape Town, Laura Stacker, with the first Institute of Neuroscience. It's not the first Institute of Neurology. There's a lot of other Institute of Neurology, but it's entitled Neuroscience Institute, and hope that this will go leverage of neurology. Institution helping on neurosciences are, for example, a Society of Neuroscience of Africa. We have AFAN, but also there are specific societies, and the society are important to give people a lot of sustain in neurology and publishing the results. You see, that is a note on hash index countries. You have the first is South Africa, the second Tunisia, Morocco, Kenya, Nigeria, Tanzania, Algeria, Cameroon, and hold on. This response is very important. If you don't publish, you perish. And publishing our result is something that is not a tradition. And my hope is that from this region, or there you see that we are speaking about help and work together to publish results. A lot of results are not published, and it is not easy to publish it like it is. Neuroscience research in Africa, the current status, that is correlating between the number of neuroscience research. That's a work that has been done in only one country, which is Cameroon, with showing that what are the fields where are people, and you see that the most important part is clinical neurology. We have to go further in more, I would say, neurosciences, and more in biological and genetics and cognitive neurology. This is to say that the published articles are just part of the iceberg. This the other part is why we don't publish it all this, because the process is not easy for people who are working every day on the neurology ground, with countries with 1 or 2 neurologists, or 1 neurologist for 100 and 200 or even 1 million persons. When you see the 2 decades of neuroscience publication trends in Africa, you see that research is not equal and neuroscience publication is not equal. You see these huge dots in some countries, and country where you have no dot. The blue dot is the one showing the most important areas of publication. And you see that there's a lot of publication more in the north and in the south of the continent, but also a huge dot in Nigeria, as it expects. A dot which is increasing in Kenya, in Ethiopia, in Tanzania. This east part of Africa is also going more and more on publication. And this is the co-authorships. I will go rapidly, Mohammed. I know that I'm on, have reached nearly the end of my time. And you see that the work is more done with Europe and North America. Mohammed, where's the IUC, where the collaboration between our countries? It is still not at the level it has to be. And this is something also that you see. The collaboration with me, is, as you see, is especially done with the northern part of the continent and the eastern part, and no collaboration really with the western part of the continent. And this is the citation in journals and and impact factors. And you see that parts of Africa, especially, for example, South Africa, are really absent for this. This should be something that we should work on it as AFAN, as WFN, as colleagues on the ICU. The research technique, as you see, we have nearly nothing on the transgenic model, for example. We have publication on medicinal plants in a lot of countries, but the things are going like the transgenic model are nearly absent in the world continent. An important point, Tina and Mohammed, and all the guests who are listening to this presentation, the financing and the funding of research. 36% is coming from USA for our continent. And this is the most important part of financing research in Africa. UK, 25%. France, who has so many countries, France speaking, only less than 10% financing of research. And country like Chile, China is not specified on this point. And the majority of countries are on 1% and of funding research. The countries within Africa, the majority cannot afford to fund research. And you see that the funding from international partners is really absent or very minimum. Limited number of neurologists, public health education stigma, this all, and as I said, the funding, the structures are a problem for having research on neurology and neuroscience. But don't be, as I said, on the dark side of the African research. There are also work on artificial intelligence for healthcare in Africa, facial analysis technology for detection or Down syndrome in the Democratic Republic of Congo. Just example showing that the use of the new technologies is going on, even not at a large scale, but is going on. But the last point of my presentation within 2 minutes is how Africa could become a new center for clinical trials. It has to be. It has a large naive population, a genetic diversity, and the facilities are improving. See, you have, for example, 800 nearly trials in United States, while you have 43 for other regions and on Africa, and a center who are able to do this. And this discrepancy is simply unacceptable due to the genetic specificities I spoke about. This is on MS. If I give another example, these are new data from clinicaltrials.gov. We have the clinical trials on drugs, but we should also improve the non-pharmaceutical trials, which are the non-pharmacological trial on art therapy, music therapy, and all these kinds of things that are more adapted to our population. And the physical rehabilitation, we should not say we cannot do it because we don't have drugs, we don't have pharmacy. We can make trials on non-pharmacological part of neurology. And with these children who are smiling, I will come to a conclusion and say that I hope that research in Africa for this young, for all this continent, which is the young continent with the large part of the population being less than 20 years, will have solution in neuroscience because there is no health without brain health. Thank you so much.
Thank you, Riyadh. I think that was a very comprehensive and extensive review of research in Africa. It was very impressive. I learned a lot. I was not aware of so many research work going on in Africa. I just have a few questions. What are the research capacity building activities or institutions in Africa? PhD program, clinical trials unit, registries, and for research capacity building at the junior level or junior faculty level or the students level. So what are the facilities and how they are working together?
Yes, I will answer it on a question. Africa, Muhammad, is 1 billion and hundreds of millions of inhabitants, and it's hundreds of ethnies. It's hundreds of different language. It's 44 countries. We cannot describe an extensive presentation on 20 minutes of it. So I made only the glimpse of it because, for example, when you see what's happening in South Africa, it's totally different of what's happening in Namibia or Angola, which are on the nearby. It's simply not the same situation. So there are differences that cannot give a total shot of the situation. But what are there is that there are countries and regions where you have extensive networks and you have capacities and you have capacity building and junior participation, which is nearly the northern part and the southern part of the continent. And you have parts of the continent who are building these capacities. For example, if you see what's happening on Senegal, for example, they're trying to have that Neurological Institute Center. It's ongoing. So the things are improving. You have not a continent program on neuroscience research. Even SONA doesn't have a continent program of this. These are national programs, sometimes regional programs, but not a whole continent. So I cannot give a total figure. What I can say is that the research in the continent is that for 1% of the budget of the country, on the majority of the countries, and in this 1%, the part which is going to neurosciences is just ridiculous. That's the situation because people have a lot of problems on infectious disease, a lot of problems on transmissible diseases, on vaccination programs, and on parasitic disorders. And coming to Alzheimer's or Parkinson or will not be their first target and their first priority. Did I answer your question, Mohammed?
Yep. Well, thank you. Do we have any questions or comments from the participants? If there are, please put it in the chat box. So we will be able to ask Professor Riyadh Guidar about your queries too. So in the interest of time, I think we move to the next presentation and we'll be having questions even after each talk, and we could ask all the participants to the questions. Mustafa is with us, Haris?
No, sir, Mustafa is not here yet.
Okay. So maybe we could move to Augustina. She is with us. I just give a brief introduction of Augustina, though she is very known and famous throughout Africa, but may not be famous in Asia. So we have a lot of participants from Asian countries, and most of the participants are our PhD students or doctors or neurologists or neuroscientists. So Dr. Augustina Charvefeli is a president of African Academy of Neurology. She is a very strong advocate for neurology, and she is a teacher. She is a clinical service provider, and she is based in Ghana. And I want Augustina to we call, she's also known as Tina, but her so everyone in Africa call her Tina. So please introduce yourself and your country a little bit in your presentation, and then with the topic which you are going to present. So go ahead, Tina.
Thank you very much. You did such an amazing job of introducing me. I have very little to add. I think the most important thing is that I am predominantly a clinician. Being a neurologist is almost my entire existence. And yes, I work in Ghana. We have a population of about 30 million people. And for this population, 10 years ago, there were only 2 neurologists. That was myself and Dr. Albert Akwalu. And now we have 7 fully trained neurologists. One is a foreign neurologist, and we have the same number, about 7 or 8, that are in training. So things are definitely looking up. I'm happy to follow with Dr. Guda's presentation, because there is a very strong link between neurology training and training of doctors and research. And there's almost a two-way relationship between these 2 states. So to start off, I will speak a little bit about the African continent. Dr. Guda has already told us it's a very large continent of greater than 1 billion population. And because it's so big, because it's so populous, it is impossible to have generalizations, because things that can be typical for one region may not at all be typical for another region. So as I've mentioned, the total population of the African continent is about 1.3 billion and growing. The top 5 most populous countries are Nigeria, Ethiopia, Egypt, the Democratic Republic of Congo, and South Africa. Africa is considered a generally young population, with the majority being under the age of 25. However, again, as already said by Professor Guida, we are experiencing a demographic transition. So we still are burdened with infectious disease, but with changes in lifestyle, with demographic changes, urbanization, we're starting to see a growing population of older adults. And hence, the kinds of diseases that we see are also different. So I'm speaking specifically about training and care in neurology. And before we can talk about neurology in particular, we have to talk about medical healthcare in general. And unfortunately, on the slide, we can see that we are still experiencing a problem of brain drain on the continent. So individuals who travel outside of the continent to gain their education often do not return, or if they do return, they find adapting to their local environment difficult, and then return again back to where they trained. So a little bit of information from the WHO. The WHO recommends a ratio of 1 to 5 neurologists per 100,000 population. Professor Guda is extraordinarily lucky. He comes from Tunisia, which is the only country on the African continent that meets this recommended ratio. The other countries, the second position is at only 0.64 neurologists per 100,000 population, which is woefully inadequate. And this is the top 2nd country. If we move on to the next slide, here we have the bottom 10, not including those that have no neurologists at all available. This brings us back to the question about research. So before we can demand or request from our ministries of health, our local healthcare providers, etc., we need to have data to prove that, yes, we need neurologists, we need pediatricians, we need any kind of specialty. And it is very hard to collect this data without the human resource attached to it. So if you don't have neurologists to appropriately diagnose a condition, then how are you going to collect data on epidemiology? So here on the slide, again, I've already mentioned how many of us there are. We are at 0.02 neurologists per 100,000 population. and that is woefully inadequate. I personally work in a hospital where I am the only neurologist, and that can be a very, very lonely situation to be in, because I'm sure everyone here is a neurologist or somehow related to neurology. Simple cases are few and far between. There is always the issue that you want to discuss with another colleague to get another opinion from, and it can be extraordinarily lonely. So this is some research that we had done on our members about where our members are coming from, which countries are better endowed with neurologists, where these neurologists are located in their countries, etc. So the survey was covered about 38 countries of the 54 countries we have in Africa. So that's still a large chunk of the African countries. Either we just have no information, or we have no information because there was no neurologist to respond to this survey. As you can see, here, for the practice setting of our neurologists, the majority are in urban areas, and even those, the majority are in the capital city, which leaves large swathes of the country, wherever they are, still without access to appropriate neurological care. And even where we have neurologists, again, the majority are within tertiary or teaching institutions, again, leaving those who need at least the first point of contact, a primary healthcare, often without anyone to see. So again, of those neurologists that we do have available, the subspecialties that are covered are the, with no offense intended to anyone who is from epileptology or vascular neurology. So it's relatively low hanging, popular parts of neurology. So we have at least 50% who claim to be epileptologists, specialists in neurodegeneration or movement disorders. Stroke is one of the other ones where we consider ourselves, I'm a subspecialist in stroke, infectious disease. And as you can all see, this doesn't cover a large part of neurology. And again, meaning that even if you do have access to a neurologist, that care may still be inappropriate. So I'd like to echo what Professor Guda also said about looking only on the dark side. But it is also true, we can't offer solutions if we don't identify what the problems are. So both obstacles and opportunities. The obstacles to getting more neurologists or encouraging more people to become neurologists is the general low doctor to population ratios that we have across the continent. Again, please note that this is, that the variability is high amongst the different countries, and even within a country, it can be very variable. So the human resource is the most important aspect. We have few specialization programs available on the continent, and neurophobia, I'll speak a little bit about it in a few slides, where people are just not put off, but so terrified of the idea of the nervous system that it doesn't encourage them to enter the field of neurology. And of course, the brain drain is not helpful in the least. So where are our opportunities? I find that the opportunities are plentiful if you know how to identify them and how to approach these opportunities. So catch them young. I do think we need to address the issue of neurophobia and start encouraging people to be interested in the nervous system, in neuroscience, in medical school from as early as possible. When we start teaching our students about anatomy, the anatomy of the nervous system, we should focus more attention on it. When we're doing histology of the nervous system, when we're talking about pathology of the nervous system, so that we interest them early and get them more involved in the nervous system, and then we can have more of them becoming neurologists. We need to demystify neurology. So again, it also partially comes from the issue of neurophobia. Yes, the nervous system is extraordinarily complex, and we know we don't know everything about it, but we need to present it. And most of us, as our roles, even if we're simply clinicians like I am, we still end up in a teaching position anyway to help our junior colleagues. We need to demystify neurology. We also have to, aside from international collaborations, we need to work more on South-South collaborations, intercontinental collaborations, collaborations between regions of similar characteristics. And of course, we need to strengthen the training programs that already do exist on the continent. So a little bit about neurophobia. There's a recent article on neurophobia in Africa. Just briefly, neurophobia, or a fear of the neurosciences and clinical neurology, is a phenomenon that has been identified and studied amongst medical trainees and practitioners for several decades. And this was done mostly in North America and Europe. In our environment, or the African continent and other low and middle income countries, this neurophobia is compounded by the fact that we have few neurologists and neurosciences involved in the training of neuroscience and neurology at the level of medical school. So you have someone who is not a neuroscientist, who perhaps themselves is covered with the neurophobia, teaching others and passing on that fear of the nervous system. So what are the approaches that we can adopt to improve neurological education and training? So first, it's to increase the proportion of neuroscientists and neurologists that are part of the core medical school curriculum. Like I said, catch them early. We need to encourage electives in neurology, incentivize specialization in general neurology. And here we need to work with our ministries of education, our ministries of health, our colleges of education. And we need to develop educational programs in specific subjects for those who are already trained as neurologists, but also package some of the aspects of neurology for non-neurologists and other primary healthcare providers. For example, programs on epilepsy can be targeted both at neurologists in training, but also at the general practitioner, at the primary healthcare provider, and even for medical school students. So again, programs on epilepsy, stroke, dementia, neuromuscular diseases, neuroimmunology. It's important that we cover as wide a scope as possible. Yes, it's true, the most common diseases are epilepsy, stroke, but it doesn't make it less necessary to cover the less common parts of neurology, because the individual who is the only one with this disease does not really care that his disease is a very, very rare one. He still deserves, or she still deserves, as much appropriate care as any other condition should. And I have stated on this slide, note representation. So I think part of the problem we have with getting people to see themselves as neurologists is that we, especially for the younger medical students, younger junior colleagues, they need to see someone who looks like them in the positions of, this is the specialist, this is the consultant, this is the president of the academy, so that they have something to aspire to pique their interest. And again, as part of the incentivization, so incentives don't need to be only financial, they're also moral, they're also in terms of interest. So it's not all bleak, of course. There are many training centers in neurology on the continent. So some are long established and have a solid core curriculum, such as in Cote d'Ivoire, in Egypt, Morocco, Senegal, South Africa, and Tunisia. And there are younger institutions that provide training in neurology in Benin, Burkina Faso, Cameroon, my own country, Ghana, Ethiopia, Kenya, Madagascar, Mali, Nigeria, Togo, and the most recent is in Zambia. Some countries have only partial training, where you do part of your training in the country and then you do the other part in a sister organization in another country. So for example, in Angola, they partner with Brazilian institutions and Portuguese institutions. In Mozambique, part of your training is done in Portugal. We also have on the continent WFN, that's the World Federation of Neurology, accredited training sites in Dakar, Senegal, Rabat, Morocco, Cairo, Egypt, and most recently in Cape Town, South Africa. And this does help, again, increase the number of positions available for training. But we can't focus only on the WFN accredited sites. We need to make use of the institutions that are already providing training and then build up the capacity of these places, share the acumen, share the curricula, and involve and breed other training sites. So the curriculum is extraordinarily important. And again, so that we don't forget, Africa is heterogeneous. So for parts of Africa, for example, for the West African region, there is the West African College of Physicians and Surgeons, where there's a unified curriculum for the subspecialties that is maintained across the different countries, both Francophone and Anglophone. It is true, though, that nonetheless, despite a core curriculum being the same, the curricula are often modeled by the language of the country. So for the Anglophone countries, the curriculum is modeled very much in the style of teaching is very much modeled on the British curriculum and style of education, and the Francophones on the French, of course. Key aspects that needs to be included in the curricula are the neurological subspecialties, but with focus that is appropriate for the region. So it includes tropical and geographical neurology, back to research. Again, we don't know what we need to emphasize until we have identified which parts need emphasizing, and that's research. So research methodologies are a very important part of the training that needs to be done so that we can have more research and more neurologists to provide care for the population. So answering the question from Professor Wasai about what is available for research, nearly every teaching institution, and there are multiple across the continent, does have as part of its existence research capabilities. Most of the problem, again, falls back to human resource. So not only funding to neuroscience is extraordinarily limited, but the human resource in neuroscience is limited. And these are the obstacles. But these are also the opportunities we have for increasing the human resource, and then having the research to demand of our national financial institutions why it is important to provide these services through the data we get from epidemiology. So we cannot do this by ourselves. We need partners for this, and our partners are on many, many different levels. So the local government, local healthcare providing services, our ministries of health, our local and regional WHO representatives, and of course our international partners, the World Federation of Neurology, organizations such as the ILAE, the MDS, the World Stroke Organization, and its subsidiary, the African Stroke Organization, and other disease-specific groups. But it needs to be directed from within the continent, within the region, so that we can determine the paths that are pertinent, appropriate, and needed for us. Because again, even within the continent, the needs are different, the abilities are different across the different parts. So the African Academy of Neurology plans and hopes to act as a blanket umbrella organization where we can collaborate with our international partners and also have our African subsidiaries of, for example, the International League Against Epilepsy, the Stroke Organization, and recently the Movement Disorders Africa chapter. So some of the educational programs that we have started and are working to continue to expand, the WFN-AFAN, that's the World Federation of Neurology, and the African Academy of Neurology e-learning days. This was launched in 2020, and the first topic that was covered was stroke, and it was spearheaded by Professor Fuad Abdallah. Last year, the topic was epilepsy, spearheaded by Professor Lawrence Tucker from South Africa, and we hope this year our topic is going to be in movement disorders. The programs are designed in such a way that we target both the neurologist and the non-neurologist. And it's important to do that again, because for as long as we're going to approach only the neurologists, we will be speaking to a very limited part of healthcare providers. And in order for us to become more plentiful, we need to get them from the general practitioners, get more interest in neurology from other parts of medicine. Another long-standing training possibility on the continent are the regional teaching courses run in collaboration with the EAN. They have been going on since 2007. Unfortunately, COVID has made life extraordinarily difficult, so we can't meet in person anymore. But we do hope this year we will be able to have a meeting in person. It's still just a hope. We don't know what COVID is going to do with our hopes. So it may end up being either hybrid or virtual, but we do hope for in person, because I'm sure, like all of you, Zoom fatigue is strong. So from the training, why is it so important that we train neurologists and non-neurologists in neurology? And that is so that the person living with a neurological disease, irrespective of where they are on the continent or on the planet, can still access appropriate care. So in order for the neurologist to have a job and the patients to know that they need to see a neurologist, we need public awareness campaigns and advocacy. This is extremely important, and it's also one of the things that are nearly mandatory parts of our practices. So again, we may say that we are predominantly clinicians or we are academicians, but advocacy is never far away from what we do, because it defines why we need to do the things we do. Eliminating stigma is one of the huge things that is important in the public awareness campaigns and in advocacy. So national disease days or international disease days, such as the upcoming next Monday, World Epilepsy Day, educating the public on when it's necessary to seek medical attention by drawing attention to what is normal versus abnormal. So specifically for Africa, with our demographic transitions, we often have a misconception of what is considered normal aging. So diseases such as Alzheimer's disease, Parkinson's disease, other neurodegenerative diseases are sometimes considered by the public, oh, it's just part of aging. And we need to educate people so that they know that you can seek help and help is available. It may not cure the problem, but improvement of quality of life is extremely important. We can't overemphasize the importance of brain health. Professor Guda already mentioned this. And this is where we have to start speaking, again, all of us on all our individual levels, with members of our policymakers in local government and national governments. Because without brain health, the government, whose most important and precious resource is human, without brain health, there are huge socioeconomic impacts of inadequate brain health on the population. So programs such as the World Brain Day should involve our governmental personnel so that they also become part of the awareness campaigns and the advocacy. What are the tools that are used and can be used if are not already being used for advocacy and public awareness? So support groups are very important. And this is sometimes difficult in our environment because we have issues of stigma, no one wanting to announce that they have a neurological or brain disease or a disease that involves mental health, which is a lot of our neurological diseases. But once they do see the benefit of having these support groups, they do then start to join them and benefit from being part of a support group. Social media nowadays is an extraordinarily important part of how we can reach the public easily with sound bites and bits of information so that we increase their public awareness. We can, of course, not ignore conventional media, radio, television, work with, let's say, football programs, for example. So Professor Amadou Gallo Diop from Senegal had a brilliant idea of how we could collaborate with, let's say, sport bars, which are very popular across the continent. And before or in between the breaks of any major sporting event, and for Africa, it's usually football, we can have these moments, short periods where we have these advocacy programs. We cannot do it alone. We need to collaborate with our religious leaders, political leaders, social media influencers. And with that, I think I have covered as much as we can in terms of what we can do, what we should do, what we are already doing, and huge scope for improvement. And all of it is so that that two-way link that we were talking about between research and training and appropriate care to our patients can be achieved. Thank you very much.
Thank you, Tina. Thank you for a very comprehensive talk covering almost everything. Now, I just have one simple question that Africa is 54 countries and about 1 billion population, maybe more than that. How many neurologists in whole Africa? How many training programs? And how many countries in Africa where there is no neurologist? So these could be like the target areas for intervention.
Okay, so an excellent question. I don't have the data off the top of my head, but at least 10 countries on the continent have no neurologist. But I did mention we don't have contacts in all of the countries. So some of the countries where they are perhaps politically unstable, etc., for a variety of reasons, unfortunately, those countries also tend not to have neurologists, but sometimes they do, but communication with them is hampered. So at least 10 countries don't have any neurologists at all. The majority of the middle belt, sub-Saharan, not including South Africa itself, have less than 15 per their population. It's because it's a huge continent and the differences, so even the population of the different countries is different. The population does not match necessarily geographical size. So there is that discrepancy. You asked also about the training programs that are available. So on the continent, not counting the World Federation accredited sites, because they are on sites that are already providing neurological training, there are at least 25. Yeah, 25. So the opportunities are plentiful. It's just these structures need to be strengthened and beefed up because some of them are fledgling, they're just starting. And again, if you have a country that, let's say, has only 10 neurologists, that means in training, so participating actively in academia will not be the whole 10. So the burden is huge. And so I think it has to be a stepwise and realistic process. where you're training the trainer, and with every generation, the number will increase.
Do you think there are more than 1,000 neurologists in whole Africa or no?
I think
In the
there
whole
are definitely more than 1,000. If we take
now,
North
how is the
Africa,
transport situation and the internet availability? What are the prospects of like tele-neurology training or transportation from like one country to another to get the training? Is it good, or they have to go to Europe
so
to
you're
come back to
absolutely right.
country?
The disparity in technology is also huge, because we have the very bottom of low income, and then we have low middle income, and some countries even fit in middle income. So those disparities are huge. In terms of connectivity, availability, again, the disparities are huge. So even within a city, you can have parts that have excellent connectivity and parts that don't have good connectivity. You can have connectivity that's excellent, but not stable. So telemedicine is definitely also one of the things that can be developed on the continent and is already developing on the continent. But even before we can say use telemedicine, we need to raise that awareness that here is a service, and you need to have trained the person who is going to be seeking that service. So for example, the primary healthcare provider sees a patient and identifies, hopefully correctly, that this is a neurological problem, and then they need to know that this is a neurological problem and then know where they can contact. So these things, they're definitely opportunities and are improving. But again, there can't be one blanket approach because of the disparity across the continent. So you asked also about transport between countries. That's another issue. It is sometimes easier to reach Europe or North America than to reach in neighboring countries. So whilst we do have some transport hubs on the continent, so in West Africa, in Egypt, Morocco, Kenya, for example, and then South Africa, in between the little countries are hard to reach and actually very costly.
Okay.
But it's not an obstacle. It can be
any questions from the participants related to improving neurological care in Africa?
Professor Wasim, we have one question from here. Dr.
Go ahead, Haris.
My question is, what is the pharmacovigilance system in African countries regarding collection of adverse drug reaction for medicines used in neurological disorders?
Okay, so I don't think most countries will have specific pharmacovigilance systems for neurological disorders, but practically every country has a something like the Food and Drugs Administration, where every medication that is imported into the country needs to be licensed, registered, etc. And those same institutions are the ones that participate in the pharmacovigilance. This becomes a challenge when there are some medications that are used that are privately imported because they are not readily available in the country. And then the reporting mechanism becomes a challenge because who are you going to report to? But each country does have, how well it works, again, the disparity is huge, but each country does have a pharmacovigilance authority.
There is my one suggestion for African countries. Now, the word is of internet. WHO has developed med safety mobile applications. So every citizen of who have the Android or iPhone system in his mobile, they can download from med safety mobile applications. So this is yes, this is the very easiest method for collecting adverse drug reactions of neurological disorders. The African countries, they can request to the WHO for installing of med safety mobile applications, and then they can collect ADRs from their own mobiles. Either they have the Android phone, either the iPhone. Thank you very much.
Thank you.
Any other questions?
That's it, sir. Professor
Okay, thank you. Augustina, thank you very much, and thanks for. We will be connecting to you again related to this OIC project for improving neurological care in Africa. So next speaker is Professor Dr. Osama Yassin. Osama is well known. He is an interventional stroke neurologist. He is currently the head of MENA Sino Stroke Organization, and he will be talking about how to improve neurological training and care in Africa. And this is a video recorded talk, and then he will be also available for discussion and question answer session. Dr. Osama Yassin.
Is the screen visible to all?
Yes.
Okay, we'll play.
No voice.
Stroke subspecialties is a concern of this training. Interventional neurology model. I think I have nothing to disclose related to this presentation. However, I will focus on stroke and interventional neurology training as a model for neurology subspecialty training, and why neurological training and why stroke subspecialties is a concern of this training. I think one of the most important answer for this question is a huge burden of the disease in the world as regarding neurological disorders. Globally, neurological disorders were the leading cause of deaths and the second leading cause of death worldwide. And the bulk of this burden, especially neurological disorder burden, is much higher in the low and the middle income countries. And overall, contributors to this deaths were stroke, especially stroke, and come in the first order by about 43% of this burden. And also regarding the cause of death, the leading neurological disorder, leading neurological causes of this were stroke in the first order by about 68%, then Alzheimer's diseases like dementias and other neurological infectious disease like meningitis. So the global burden in 2016 study showed that data suggested that the advance in the management of neurological disorders are not keeping up with the increasing burden of this disease. And also, when we come to the stroke by itself, I think the prevalence of stroke in our region, especially in the MENA region, is very high. And when compared to other parts of the world, and it is occurring more and more in a younger age population sectors. And this number represents a huge pool for a burden of this neurological disease facing the health workforce in these low and middle income countries. So in this presentation, I will discuss the magnitude of this problem and some strategies and the level of individual experience and on the level of organizational experience. Regarding the magnitude of the Let me start with this slide showing that there is a shout in the local press in different countries like Egypt, Tunisia, Saudi Arabia, and African countries, showing the insufficient number of the workforce medical fraternity to overcome the need for medical conditions. And also, this is data from the World Bank showing that any physician availability per 1,000 population in MENA region is about 1.3 per 1,000 population, and it's ranging from low number like in Djibouti to higher number like in Israel. And similar numbers and more frustrating numbers are also presented in sub-Saharan African countries. And this is a very interesting paper showing that the annual average exponential growth rate in the size of the health workforce that would be needed to eliminate the needs-based shortages by year 2030 is more accentuated in low and middle income countries, and they can reach up to more than 10% of the current situation. And when we come to be more specific as regarding neurologist availability, the WHO Atlas showed that the dedicated neurological workforce is needed to care for and manage the growing number of individuals with acute and chronic neurological disorder worldwide, and more accentuated in low and middle income countries. And when we come to the financing for neurological disorders, also WHO Atlas showed that only 24% of countries globally have a standalone neurological health policies, and this proportion is much lower for low and middle income countries, and even 12% of countries have a separate budget for neurological disorders. And this need to give more investment for prevention and increase the accessibility to surface and improve specialized management of neurological disorders in this category of patient. So I think we now have evidence problem regarding a low number of workforce and low interest from the administrative personnel in financing neurological services. Not only that, but also the long and tedious training programs of the neurology could make a repulsing factor for recruiting more physicians to have a neurological training. And this has been shown in this paper published in GNP. And even formal neurological residency training programs is lengthy, like in this paper from European countries showing that these training programs across Europe have showed many difference, and it also showed a lengthy training period, and part of the training was obligatory rotation in department, which couldn't be related to what is needed according to the burden of the neurological disease in each country. And huge burden of work also can make neurologists as a vulnerable group for burnout, and this could also make them more repulsing to go through extensive training program in their career. And this is shown in this paper published in Neurology. And to summarize the problem, I think we have a problem as regard workforce availability, less enthusiasm to go through training, huge workload exposing to burnout, the lack of service and the finances, and to drive the necessary changes, it is crucial to expand the health workforce. And these changes require planning and strategies to increase the number of quality and the quality of personnel who can deliver this necessary service. As regards stroke interventional neurology training in the region, I think in the middle MENA region, I think we have clear problem that no formal program of stroke training is available in most of the MENA regions. Also, few neurologists have enough breadth of training to manage stroke comprehensively, and also stroke specialists are needed irrespective of their background. And this is possible strategies that can improve neurology training in stroke and interventional neurology, either through shortening the time of the training via creating many training programs or delegating task or task sharing and shifting, and also to curriculum enrichment with stroke content into the neurology training programs, and making neurology training more appealing and more attractive through using simulators and virtual reality, and through working through organizational organizational group or groups of neurologists and making consensus. The first model, which is trying to shorten the time of the training, either through creating a mini training program or to make task delegation or task. There is a famous controversy published in Stroke, a journal between Professor Lou Kaplan and Professor Candy Lees about stroke is management by neurologists. I think this controversy created two models, either using fast track protagonist to be able to patch the gap in the stroke management deficiency personnel, and or using comprehensive track protagonist. This is creating a full-length training in stroke medicine, which at the end create the stroke specialist. However, I think a fast-track protagonist is a model which we are needing, we are in need in our region, which it could be either creating many track for conventional neurologists or creating many training track for other related subspecialties to delegate them in a specific part of stroke workflow. And I think this is very important model, which is a delegation, but we need to ask ourselves what could be delegated. I think when we come to the stroke management, we have two parts of this stroke management, either procedural business or non-procedural business. I think procedural business is related to the treatment and the intervention, and the non-procedural part is related to the cognitive ability to diagnose and detect, and the other part is to have a system quality improvement and procedures. I think one of these very interesting non-procedural models is created by Angel's Initiative through what is called the Advanced Stroke Life Support e-learning program, which is directed to the emergency medical teams, and through different modules, learning modules, increase the capabilities of this personnel to ameliorate the time metric of the stroke workflow. We actually used a similar a module by creating some training, a mini training program for the ER and internist specialists to learn them or to educate them more and more in the stroke medicine. And we showed that it's effective to improve the time metrics of the stroke management and the outcome. And similar data has been published by Nigerian. This concept of mini training or micro learning was shown to be effective in and the utilization of such a mini training program or mini fellowship created a fast track focused training for stroke neurologists and interventional neurologists through focusing in one or two part of the stroke workflow training or vascular neurology training program, like clinical or the therapeutic part of the training program. And actually one of these fantastic model that has been created by in cooperation with Medtronic was the Neurovascular Stroke Academy training pathway, which is composition of online module of learning and on-site module of hands-on in 5 European sites or centers, and for creating fast training program for neuroscience, derivative physician, neurology, neuroradiology, and neurosurgery to be able to do stroke interventions. And we are very fortunate to have similar experience and experiment in Lahore University Hospital with Dr. Omer Rashid, when we created a mini fellowship in cooperation with Mina Sino and Medtronic for interventional radiologists to be able to do acute ischemic stroke intervention. And we are very happy to have 2 candidates graduated from this initiative. And then from this enthusiasm, Professor Wasi and Dr. Omer created another module for stroke neurointervention training of neurologists as a mini fellowship with in cooperation with Pakistani Stroke Society and the Pakistani Neuroradiological Societies and the Mina Sino to train the neurologists in specific models like carotid stenting, mechanical thrombectomy techniques, and so on. And a similar experience has been adopted could be adopted in countries like Ethiopia, where there is no stroke neurologist, no neurointerventionalist, and the number of stroke neurologists is less than 5. So Dr. Tekli, he is one of the expert, American Ethiopian expert in interventional neurology, created a fellowship training program in neurointerventional surgery for neurologists, neurosurgeons, and radiologists, and he will start by the end of this year. And the other strategy is using simulation and fast-track training for non-technical skills and for technical skills. For non-technical skills, it was shown that it is very effective through some publication, and it can be used for improving the all procedural metrics, quality metrics, through making simulation for neurologists and for ER physician to ameliorate the stroke workflow steps. And also we are using similar modules through case-based deductive approach by using body interact software for training and frequently train the neurologist and neuroscience derivative specialist to expose them to the case-based problems and improving the time for the diagnosis, time for investigation, so on. And
specific patient
evidence problem regarding a low number of workforce
Professor Osama,
Yes.
there is no recording from 17 to 20 minutes. So there is voice missing for 3 minutes. Would you like to narrate or should I skip to 20 minutes?
Yes, it's possible if you have time. Yes.
Yeah, it's playing. So you can narrate until the voice because there's no voice clip between 17 to 20 minutes.
So let me share the rest of the slides, please.
So
you can stop this video, Haris, and Dr. Osama will share a screen from his computer.
okay, so he can complete the presentation from there.
Yeah, exactly.
Okay, sure.
First, I'm sorry for that technical problem. Do you see my slide here?
Yes, sir.
Okay, so I think we stopped here, this part.
We were on slide 37, 30.
Yes.
Yeah.
Yes. Okay. So I think this is what was saying that this is our experience in using case-based deductive approach in the training of the neuroscience derivative physician to learn them how to use their cognitive ability to decide, to diagnose, to detect the disease, and work in a faster way. And also, sometimes we use such software simulators for diagnostic skills and gaining diagnostic skills. Also, it's also non-procedural model of using a simulator, like using TCD simulators and echocardiography to improve the skills of the neurologist to use these tools in the clinical practice and during neurovascular training. And also, we frequently use these tools during the pandemic to through virtual or online training to maintain these training programs for our residents. And when we come to the usage of this simulator as a fast-track training for technical skills, and this is the most important part of interventional neurology, I think we have a meta-analysis published showing that this is a very strong tools with a potential beneficial effect of simulation to improve the accuracy and the time to complete the procedural task. And also some publication showed that its usage for stroke intervention and for endovascular training is a reposted tool. And when we come to these simulators, we have two types of these simulators. One of them is the hardware and the software, like in this one. And in this type of simulator, we are using software through a hardware machine to increase the skills of the trainees to in specific modules, like in using a radial approach or using stroke intervention, aneurysm coiling, or carotid stenting. And the other type is using cell-specific models, which is printed through a 3D printing machine from a patient-specific, real patient-specific anatomy to help these trainees to be customized on the anatomical situation, to navigate the microcatheters and to go through a dangerous situation safely. And we actually used these simulators and virtual reality in our MENA Neurovascular mini diploma, which started about 3 years ago, to 1 year before the pandemic, and it is consisted of 4 semesters, ending into 5 days. Each semester into 5 days intensive workshop and intensive courses, and each course ended by exam. and the candidate should submit a validated logbook and also some communication or publication. And we have we run this first wave, and we have graduation or graduates from different countries through the region, from all countries around the region, and we will start the second wave next year, inshallah. And also some effort, another strategy is to work through through groups, and these groups should have the ability to sensitize their members in effective way. And I think when I speak about the group, I mean the national level, at the national level, like stroke societies in different countries, or regional levels through some societies, which is prestigious societies, having members in different countries. And I think one of these potentials to youth sensitization ability is to create some guidelines, some consensus for the members. Like in MENA Sino, we created, we published a lot of a publication about stroke practice during pandemic, endovascular, neuroendovascular practice during the pandemic, and so on. And also in MENA Sino, we created a fellowship program, which is a multi-phasic or multi-level program or fellowship. The level 1 for the stroke medicine and stroke physicians, and it is run with in cooperation with international universities like Saint Michel in Canada. And the level 2 is specified for creating or training physician for stroke intervention, and it's a 1 year duration. And then the level 3 is for comprehensive neurointervention trainings. And I think we started the first wave from the first level last year, and we have 2 candidates will start their training program in Saint Michel, Canada, by the middle of this year. And also through working with other international societies like Society of Vascular Intervention and Neurology, we have some cooperation in Silk initiative. This is a global initiative to create a platform for interventional neurology worldwide. And in this initiative, we are using training modules. This is a platform for allowing the clinician to virtually scrub in to any operating room or cath lab from anywhere in the world, and to gain some experience through supervised training remotely. And I think at the end, to conclude, low middle income countries facing a huge challenges as regards neurological training, and specifically those for subspecialties like stroke medicine and interventional neurology. And the use of fast track training modules or delegating rules are effective tools to help those type of training. Simulators and virtual reality platform help recruiting enthusiasts to maintain training recruitment, and working through effective group insensitizations could help in increasing the volume of trained specialists. Thank you.
Thank you, Sama. I think that was a very comprehensive presentation, and thanks for being here. Osama has done a great job in the MENA Sino region, which is mostly all of the countries are basically OIC countries. And MENA Sino has done stroke conferences. A lot of education and teaching material is on the website. Osama has done a great job in stroke intervention. So I think people who are interested in stroke and stroke intervention, they should keep in contact with MENA Sino region and Osama if they want to continue stroke care. And we hope that this collaboration between OIC and MENA Sino will translate into a lot of improvement in stroke care in future. So thanks, Osama. Due to shortage of time, we will not take direct questions right now. But if the participants have questions, please write down your questions and we'll forward that to Dr. Osama for his response. And now I'm going to the next speaker for this session, who is well known in Africa. He's a friend, Dr. Saidi or Sheikh Saidi. He is based in Sudan, and we have worked together for projects related to refugees and care in Africa. So it's my pleasure to have Professor Dr. Oshek Saidi on board, and he will be talking about improving neurological care, neurological training and care in Africa. Professor Dr. Oshek Saidi.
Bismillah ar-Rahman ar-Rahim. I want to check whether you hear me clearly.
We can hear you and we can see you.
Okay. Jazakallah khair. Thanks very much to all the organizers of this unique conference. Thanks to my brother Muhammad Wasai to give me the opportunity to participate a little to this great effort. And I also learned a lot and enjoyed listening to the presenters. I think in 20 minutes, it will not be possible to give a comprehensive talk about the training in neurology and improving the services in Africa. But what I decided to do is to give you like a flavor of the issue. And I'm sure many of you did have come across this topic previously, but bringing it into just a few nutshell discussion of somebody who lived the milestones of this might be of help rather than going in the details of every program or every idea. So these are highlight talk rather than a clear scientific talk. It has many dimensions. So I'll give a brief history about training in neurology in Africa. I'll also talk about the development and improvement of the services in one way. Then I will give suggestions for the way forward. You know, Africa, quite huge resources, strategic position, a lot of poor management problems, and being exposed to so many colonizations, then civil wars and famine, and a lot of environmental and human-made conflicts as well. So it is burdened with so many things. And neurology is not unique to be prevented from the aftermath of all these calamities. So the World Federation of Neurology, when it was formed, Africa was not constituting a major part of the and contributing. There were, if I remember, there was only one African neurologist from South Africa. He was working in Germany in the early 50s. So then after, I will just highlight the African initiative and the change and what plans, and then AFAN, which I contributed to the inception of with the help of so many other people who my contribution was not as great as theirs, but I feel proud that I have been part of this history. So in 1957, as I said, was Dr. Bernard was the only one from Africa. Then a great man whom we lift our hats was Johan Arle, the president of the World Federation of Neurology, who brought the idea of the African initiative. And people did not say in Africa, said with Africa for Africa. And I always remember my brother Amadou Gallo Diop and Riyad Guaider and Alfred Njamshi and many others. And I do apologize if I forgot one's name, but you will see in the pictures, probably that will be more reflective than the short in my talk in a hurry. So they thought of training neurologists within Africa and improving the neurological primary care. Although I was an advocate for also including training allied service providers like nurses and technicians. And this was not in the initial goal, but now it is part of it. So this is Dr. Johan Arle, who also wrote the history of the World Federation of Neurology. So he is somebody who gave a lot of push for this. And a committee was formed in 2008 for what they call the World Federation Neurology Committee for Africa, and that took on the task, and many people were involved. I was not part of that team at 2008, as I was working in the UK at that time. But I did meet the great man Johan Arle and Stephen Sergey, who was the president of the American Academy at that time. So what people did, they handed all this to the second lot of great effort from Vladimir Hachinitsky, and we went on. Yeah. So I can see Riyad Gwede, Ramadou Galadiov, and others who did contribute. Another big step came when Raj Shakir became the president of the World Federation of Neurology, and he brought the idea, why not to have an African Academy of Neurology, like American Academy, European Academy, and so on. So Rad worked very hard to convince people for this idea, and I think he, without him, it couldn't have been realized. So we met in Senegal in August 2015 and decided to start African Academy of Neurology. Raj Shakir is sitting here. I'm sure you know some of the audience here. You can see Fuad, who's sharing this session, and myself. So from there, we started real work. Also, I also suggested the epilepsy nurses training program for Africa, and from South Africa also, Lawrence started the EEG tele courses. He started before that, but he got it involved and more publicized, and it is also making difference. I think what happened is we participated to the training courses, what they call them, regional training courses of the African Academy, American Academy of Neurology, and mainly by the European Academy of Neurology, which also invites other international organizations to contribute. And I think now they are going towards the 13th course. And we ran the 7th one in Khartoum. And also we did a study, did education training in neurosciences, training in neurology, which current status at that time. And our findings actually were a bit surprising, that many of these young people are very enthusiastic to learn neurology, but there were no resources to let them get into it. We also contributed to the Atlas, which gives an idea about the available resources in Africa of both the facilities, the personnel, and the services provided. And I'm sure people have already spoken about this. The first Atlas came in 2004 by WHO and collaboration with the World Federation, and the new one, the second one, which we contributed to, was in 2017. Evidently, that the information confirmed what we felt, that many of the African countries actually are far behind, and there are countries which do not have even a single neurologist. This has to improve, and so on. People work on that, on training programs as well. It's the countries which contributed to the Atlas. Sorry, I will not go in the details of these because that will add much. Another big step was the celebration of the first World Federation of Neurology Congress in Africa, which was held in 2013 in Marrakesh. And that also brought to reality what Johan Arle said, with Africa, for Africa. And I think that was also good. I think Mohammed Wasai was there also in that meeting. This is a picture in Khartoum. And also we published these surveys in training in sub-Saharan Africa. In a nutshell, there are not enough neurologists, not enough training centers. The enthusiasm by the young people is high, but there are no avenues to train them. Regarding Sudan, we have the Sudanese Society of Neurological Sciences, which was established in 1967 by a neurologist and neurosurgeon, and both of the specialties are still working hand in hand in the same specialty. So we do weekly clinical meetings, monthly CMA events. You know, with the coronavirus pandemic now, all these activities they halted down. We did have annual courses, and many, I think, of you, some of the audience I can see, they came and helped us in training young people and young doctors and senior medical students. We brought, I think, a unique experience of doing outreach trips where many of the members of the society do go to a rural area once at a time, Northeast Sudan or remote parts of the country. And when we go there, we do charity clinics on a 3 or 4 days basis, and we run a course for the local medical school and the young doctors. We also do public education. I will show you quickly what we do in this public. We do go to the rural areas, to the local market, to the farmers, and tell them about how to manage stroke, what about fast. They ask us questions about epilepsy, Parkinson's disease. We try to answer their questions in very simple terms, and that has very good outcome and very good feedback. And we are continuing to develop these programs, actually, and we are trying to publish this. Actually, we also contributed to the national, regional, international scientific events, but we do also face difficulties. Neurologists in Africa, they don't have a network where they can communicate easily. And the trainees also, they don't have a good program where they can move between the training programs, or they can have specialty training. All this due to a lot of restraints, which I cannot stress more than what others said already. And we also contributed to the national protocols of management of neurological disorders. And I think this is a priority for African countries, is to have national policy for management of epilepsy, stroke, Parkinson's disease, CNS infections, which are quite prevalent in Africa. And we need to develop competence in them also. We also hold biennial neurosciences conferences, and this also they have been halted, but we will try to use the idea of OI conference and do like internet-based. This is Professor Dawood Mustafa, may Allah bless his soul. He was the one behind establishing SSNS. He also one of the contributors to starting the Pan-Arab Association of Neurological Societies and the Pan-African Association of Neurological Neuroscience organizations. These are parts of our courses. You can see Ogun, Najmuddin Ogun in a peripheral part of the country. We had Amadou Galadiob also visiting us. So that was the first course which we ran the 14th of May, 2009. And I think it drew a lot of admiration. Arle wrote about it, and I wrote an article on neurology about it. But the idea is we need to inspire people to try to develop local training, not only for doctors, but for nurses and for technicians, because doctors cannot work on their own to deliver good services, and it's a teamwork. So this has continued on, and I think the World Federation of Neurology now established training centers in Dakar, Cairo, South Africa. We hope our center in Sudan will be recognized. You can see we train people in EEG, nerve conduction studies. Alfred Jamshi also came and helped us a lot. People came from the UK, from America, from many parts of the world to help us. And also we do this is one of our charity clinics in a rural area. We just have a table and a chair and a couch, and that's it. We don't have much facilities, but I can see Victor Patterson was a professor from Northern Ireland who comes regularly to go to rural areas as well as teach neurology trainees and senior medical students. And we are really grateful to his contribution and to his ideas as well. So I'm concentrating on the experience I was involved in as an example of how to make a difference. We established a department of neuroscience at our tertiary care hospital in Soba, where we have lobbied for, we don't have simulators sophisticated like the ones shown in the stroke in Alexandria, but we do have quite decent facilities. This is our collected by many donations from local organizations and regional. And so we invited also international figures to give training, participate in the courses and conferences from time to time. The International Brain IBRO, International Brain Research Organization, contributed also to the training and the conferences we are running. And we are grateful to those who are behind that. You can see one of them, that's my friend and my brother, who made big difference to us initially, and he continued to give help. So the training programs are limited, and the number of people who can be taken is limited. So what we suggest is that in each of African regions, there should be a recognized training center, and preferably if there will be also local country training programs. So this is outreach. We go by buses to rural areas. We usually do also some tourism to the local people and show some of the old civilization in Sudan, which many people don't have any idea about. You can see this is in the Sudanese pyramids. We also this aquarium in the Red Sea and different parts of the country. So we started a clinical neurology MD training in Khartoum, and now the first batch graduated. The program well-written curriculum. We have used international recommendation by the most prominent organizations, American Academy, European Academy, World Federation, and now we graduated 8 neurologists last year in April 2021, and now we have 8 in the second year and 14 in the third year, in the third batch. We are looking forward to send them also to peripheral areas. This gentleman went to Central Sudan, established a center, and this is Dr. Khaled went to Eastern Sudan and started a neurology center. And this is also linked to the local medical school. So we are trying to win hearts and minds of people by getting also involved with the paramedical. So the technicians we are training, they were training EEG technicians. These are the senior nurses and epilepsy nurses. We are thinking also of establishing a neuroscience center in Khartoum as part of Soba University Hospital. We got the ideas, and now we are looking forward for financing it. Also, we have teleneurology facilities, and we also teach integrated neurosciences course to the medical students, trying to get them involved with neurology as early as possible. And I'm sure you know it's a very lengthy training, and many people dread neurology because it's a complex by nature of the system, but it's also difficult because it needs facilities and good trainers. And many of them are actually, the way they present neurology is difficult. So these are generations of, these are 3 generations of Sudanese doctors. First generation, Amir Abdulaziz, second generation, and then our generation. And now, and there are also young people who are taking over from us. We also have a problem that we want people to hand over to young people rather than to hang to the leadership, even in societies, on running conferences and training. So the limitations in management of diseases and providing services are quite routine and difficult. So availability, affordability, tolerability, and we have shortage of all this I did mention, and I don't think I need to repeat this. But the way forward is more training of neurologists, allied services, education to the medics and to the allied service, and there should be like a CME programs which will maintain people. Now, thanks to technology, now we are doing this from the comfort of our homes. The programs also need to have the exchange between the African countries, like people can do 1 year in Ethiopia, 2nd year in Sudan, 3rd year in Senegal, or they go for short period like doing EEG in one country, go to stroke training in Egypt, or what people should think into putting like memorandum of understanding between the African countries, and also international exchange programs to be fostered by the World Federation, African Union, or other NGOs or professional organizations like the World Federation of Neurology, the African Academy, fellowship programs for young people. But we have to win hearts and minds. Our politicians, they don't care much about neurology and these health sciences. So what people need is like a friend from Burkina Faso coming to Sudan to give a talk to a rural area. We translate, but the idea is to see somebody coming from another culture, try to help them out, do a clinic and train people. Some people don't speak English or French. We have to also get interpreters. Like now we talk to this lady, so she's a wheelchair, but she doesn't speak Arabic or whatever. So we have to train also people who will help us. So it's a teamwork. It's a teamwork. You can't do it on your own. And also, we have a lot of mobile networks in Africa used for gossips and for news and political conflicts or whatever. We have to work hard to take big chunk of this to treat people, do distance clinic, teleclinics, teletraining. And I was really pleased to see the training program for interventions in stroke in Africa. So we have to win the hearts of old and young people. I admire this young girl crying outside. I want to come into my clinic, but just giving her, this is the rest, it. So winning hearts and minds is important. Training and service in Africa cannot be changed in one day. It needs a lot of dedication. It needs a lot of planning and teamwork, and also inter-country and inter-regional work. Thank you very much, my brother Muhammad Pasai, and thanks to all those who made this historical conference to give chance for people to exchange ideas of changing this. Instead of crying about darkness, we have to light a candle. Jazakallah khair. Thank you very much and good morning.
Thank you, Dr. Saidi. Shukran jazilan. Very well narrated talk. Now, how many neurologists in Sudan and neurology training programs in Sudan? And if you are training trainees from other than Sudan?
The neurologists in Sudan are around 40 neurologists for around 40 million people. So it's one neurologist for 1 million people. Except of 4 of them, all the neurologists are based in Khartoum, in the capital. They are not working in the peripheral areas because there are no facilities, no CT scan, no MRI scan. But this is changing now, and we did train a lot of people from surrounding countries. They come in our regional courses, but in the MD program, unfortunately, we could not accommodate anyone because even we could not cover the number we have. We don't have also financial support. This is a good idea. If the Organization of Islamic Countries would like to give us some money, we can take trainees from other countries to get incorporated in our program. Now our program is 3 years old, and already we graduated 8 people who are now registered as consultant neurologists in the country. We prefer people to go to peripheral areas. So we are happy to help in training, not necessarily for the whole program. You can send us one from Pakistan to do 6 months in Khartoum. We send you somebody to do 3 months in Malaysia, whatever. We have to make a memorandum of understanding within the Organization of Islamic Countries to exchange training opportunities. It will help them, and we are more than happy to do that.
That's a very good idea. Thank you. I think we'll be connecting again and for collaboration and the communication to improve the care. So thank you again, Dr. Saidi. We are running a little short of time. We may have some questions, so we'll forward you the questions. So now we are going to break this session, and this is going to be a short break. So it's a 15-minute break, and we will join again at 11:20. So is that all right with everyone?
We request everyone to be on time so that we can start the session timely and end for the lunch break as well.
Hi, Rahman Rahim. So welcome to this 4th session of first OIC International Conference, and this is the 4th session. This session is to be chaired by Professor Dr. Sharaf Nur Ozturk, who is a past president of the Turkish Neurology Society. He is part of the World Stroke Organization and World Federation of Neurology, especially Environmental Neurology Specialty Group. So she'll be joining us soon. Now we will be starting this session with Professor Dr. Ashfaq Shoaib. Ashfaq Shoaib does not need much introduction in the field of neurology, and especially stroke neurology. He's a global stroke teacher and advocate, and he has worked not only in Canada, where he is based for many, many years, but in the Middle East, in the North Africa, in Pakistan, and in other parts of the world. This is a great pleasure to have Dr. Ashfaq Shoaib with us, especially on this topic, which Dr. Ashfaq Shoaib has already been working on for many, many years, is improving stroke care in the low and middle income countries, improving stroke care in the Middle Eastern countries. And now we will be talking about improving stroke care in OIC countries. Now, OIC is mostly Asian and African countries, where he is involved in improving stroke care for many years. But I think this session today will be very important for future plans for OIC, as we are working on a OIC Neurology Academy. I think his talk will be a very important guideline for the whole OIC and comstech group. So I would like to invite Professor Dr. Ashfaq Shoaib for his talk. Title is Improving Stroke Care Across OIC. Dr. Ashfaq Shoaib.
Assalamu alaikum. I hope you can hear me.
Yes, and see you too.
Professor Wase, I just look at your office and say, similar to my office. It's always nice to be with you, and I congratulate you and your team for hosting this meeting I must say this is long overdue. We should have had this a long time ago. So my congratulations to you and to your team who've organized it. I am going to go to my presentation, which I hope you can see in there. I'm going to go to the mode there, which should work. So once again, thank you. I truly appreciate this. It is late here. It's only 11:15 at night. The view, which I love showing. So I've got no conflicts with this presentation. This is my backyard. We still have a few months of snow left, although I'm looking forward to be in Pakistan in approximately 2 weeks or so from now. So I agree. I think when we talk about the OIC countries, this is a big spectrum. There's many where the stroke care has improved and is almost at par or getting close to at par with Europe or in North America. But unfortunately, many countries, and the examples I can give you are countries, especially in Southeast Asia, where the age-adjusted incidence or prevalence has not changed. So this is a developed world, right? You can see, I'm sorry, my apologies. This is Southeast Asia. So you can see from 1990 to almost 30 years later, there's very little movement in the prevalence, maybe a little bit improvement in the incidence. And if you compare this to Europe or to North America, you can see that there's been a very, very dramatic decrease overall in the incidence and prevalence. And most of this comes because of proper management of risk factors. So when we talk about stroke and we talk about management of stroke, there's a big spectrum. In countries where, unfortunately, the resources are limited, we have to, and this is really important, we have to focus on prevention of the disease itself, that is stroke, and also focus on treatments that can help most patients. By this I mean things that we can offer to the vast majority of patients who come in with a stroke, and not focus so much on some of the more trendier things like thrombectomies and thrombolysis. And I'll explain this to you as I go along. So my presentation's outline is the following. I'll just spend a couple of slides just showing what are the essential components of a stroke program. I want to spend a little bit of time on data from Pakistan. This is getting about 7-8 years old, but it's really important data on how much you can change the incidence and prevalence if you focus on prevention. My focus on acute stroke is mostly going to be the front end of stroke management, which is when somebody comes into the emergency department and what to do with those patients. And part of this is that over the last 2 months, I've been working very closely with my own institution where I graduated from, which is the Khyber Medical College in Peshawar. And there's a lot of work to be done there. And so I thought I'll focus more on prevention of complications, because that's where, unfortunately, most of these patients are not doing well. So with that, I'd also talk about some of the things that we can do, especially in countries in OIC that are in the low to middle income countries. So that's my outline. And so first of all, what is an integrated system? What you need is in cities, in large cities. So I'll again use the example of Peshawar, where I graduated from. There are 5 or 6 big hospitals, and every hospital has an emergency department where all these patients are going. The net result is that these patients don't get the kind of care that you'd want for for an acute stroke, and you do need to have designated hospitals. So to give you an example, and this is not, I'm not being critical, I'm just being, I just want to bring the problem to your attention. I mean, that's the best way I can put it. So I graduated in 1980. I did what's called the house job at the Herbert Teaching Hospital, which has four medical wards. So every day of the week, Monday, Tuesday, Wednesday, Thursday, each ward is on take for the emergency department. And they basically take all the patients that come in. So it could be a stroke, could be GI bleed, it could be a tuberculosis, meningitis, or a host of other medical conditions. But these patients are all put together, and that hasn't changed from the time when I did my house job to the present time. So we've been focusing in the last 2-3 months to see if we can have at least some designated area in a hospital or two. And we're very, and things are moving. So in Lady Reading Hospital, we were in a Zoom call yesterday where they've just told us that they'll be putting together 16 beds for a stroke ward. So in a stroke program, you need to have in large cities some designated hospitals in the public sector. Now, if you have a hospital which is designated where your patients would go, this is where you can focus in on your nurses and occupational therapists and physiotherapists, etc. In here, these things are essential. So you need to have a stroke unit, and I'll tell you why that's important. You need to have rehab facilities, and you need to have, at the very least, some imaging that can differentiate between a hemorrhage and an acute stroke. And I do hope that in some of these countries where thrombolysis and thrombectomy is not available, that we'll take the example of countries like Egypt and Iran, where the government is paying for the TPA, and what a difference that has made. So if you can keep a registry, that's really important, because that's what we did in Qatar, and it was very, very useful to showcase to the government how common the problem is and how best your outcomes are if you manage them in a comprehensive program. So I first wanted to talk about prevention, and I'm sure most of you would agree that the best outcome for a treated patient with a stroke would never be the same as that of stroke prevented, right? I mean, we do see patients who make full recoveries with thrombectomies, but unfortunately, most patients have some degree of disability. And you also agree that, you know, a healthy person is, I'm trying to joke here, it's late at night for me. It's better to be healthy than ill or dead, right? This is the best argument for prevention. So common risk factors, and I've put this in because some of you may not be neurologists or may not know about vascular diseases, but these things are very common. In some Muslim countries, especially in the region of the Middle East, 8 out of the 10 countries with the highest incidence of diabetes is actually, unfortunately, the Middle East. In places like Qatar and Kuwait and Saudi Arabia, almost 20 to 25% of the population has diabetes and pre-diabetes. Smoking is prevalent, it's endemic, and it's not decreasing at all. And so if you look at these important risk factors in here, and I don't have to tell you about obesity also, major risk factors. I wanted to show you this because I like this presentation. This was published in 2013, and it's a beautiful work. It's from Professor Wase's institute at Aga Khan Hospital, where they focused on non-communicable diseases in Pakistan. And they were going to talk about strategic priorities. And this is really, really important for stroke prevention also. So they looked at common conditions, including tobacco use, look at how high that is, hypertension, obesity, and suboptimal glucose control. And this is what they anticipated for 2025. I mean, these numbers are striking, right? Look at the amount of deaths that are attributable to these conditions. And so they postulated, and this is what statisticians and epidemiologists are very good at. And they show that if you could reduce, if you could have public health awareness policies where you can reduce the incidence, cut back on smoking and hypertension and diet and glucose control, you can see the amount of improvement that you can see. The 30% reduction of tobacco use would bring in dividends that are just unbelievable, right? So my first message, and it's an important message, is that all of us who have access to policy makers, that we focus on prevention. We talk about fancy stuff in acute management, but it's really the prevention that we should focus a lot on. But the topic really is acute stroke, right? And we see a lot of this. So when I was talking to my colleagues in Khyber Hospital in Peshawar and the Lady Reading Hospital in Peshawar, we were doing some mock online patient cares with them. And it's just amazing that actually these hospitals are very busy, and they on any given day can admit between 5 and 15 acute stroke patients. They come in early to the hospital, but then what happens, which is very unfortunate, is that the hospitals are full. So most of these patients stay in the emergency department. So I wanted to talk about those things under the following. I'll focus on a few of these. So the primary goal, whenever you see a patient that comes to the emergency department, is you got to stabilize these patients and prevent immediate complications. This is the key. Complications are prevented not so much in the emergency department, but in the stroke unit, because the emergency department is very busy taking care of multiple patients, and the patients frequently left to their family members. And most of you know, at least those of you who are in Pakistan, that this is when they feed them. And if you feed them, they'll get complications. So make a diagnosis, so stabilize the patient, make a diagnosis, make sure it's not some other condition. And then if they come early enough, we would consider them for thrombolysis and for endovascular treatment. As the patients are stabilized, you look for an etiology so that you can prevent recurrences, right? But for today's presentation, which is for us in most of the countries, and I'm speaking to the large countries like Pakistan and Bangladesh and Egypt and Iran. So in most of these big countries, the key objective is to stabilize the patient. And once you can do that, and this shouldn't take more than 15 minutes to half an hour, in maximum a couple of hours, that you move these patients to designated stroke units. The stroke unit is one of the most easiest thing for you to establish. You do not need anything fancy. All you need is to have, in a busy hospital, designated beds, and you're going to admit these patients anyways to the hospital, right? Why have a GI bleed or some infectious disease patient in the same room as a stroke patient? So all you need to do is to just designate some beds as your stroke unit, and then you can talk about how to prevent complications in these patients. So two important things I want to focus on. One is, and so this is work from Qatar, where these patients, busy service, they were admitting 200 patients a month in the single hospital, the Hamad Hospital. And one of the first things we showed there was that if these patients wait longer in the emergency department, they wait longer than 8 hours, you can see that the risk of complications go from 14% to almost 20%. Just nothing else, just to stay in the ER. So that's very important. Most of these patients will have mild strokes. So we looked at this a bit more carefully, and we were able to show that if you measure the severity of their stroke, so mild stroke, moderate stroke, and severe stroke, you can see that the ones that get most complications, almost 40% of patients with severe strokes, if they stay in the emergency room longer than 8 hours, that's 1 in 2 patients, they will get bad complications. And if they get the complications, then their outcome, and I don't want to go into the details of the modified Rankin scale, all I want to show you is that in the red is mortality. So just by staying longer in the emergency department where these patients get complications, your mortality increases from 4.6% to 11%. So one of the things we did there to improve care was that we designed the score. We call it the DHOW, which is a boat in the Middle East score. The Dow score was done initially, we piloted it, and then we looked at it in 1,000 patients, and then another 1,200 patients, published it in one of the BMJ neurology journals there. And this is really important because this is something you can do very easily in your emergency department. The whole idea was that anyone at a higher risk of stroke should have should jump the queue. So if you've got 5 patients in the emergency departments, the ones with a higher score should move out of the emergency department faster because they're at the highest risk of complications. So what is the Dow score? So we had dysphagia as the D at a point of 2. If these patients required and if they failed the screening, which is very easy to do, just on the bedside, take a glass of water and have the person drink it. And if their voice goes hoarse, they're probably aspirating. So anyone with dysphagia, with hemiplegia, and required monitoring, and are incontinent or obese, these are the patients who are at a higher risk. So the higher the score, the more likely that they would get into trouble. So here's the Dow scores, the score of 0 to 3, very unlikely that these patients would get into any medical complications in the emergency department. On the other hand, if the score was 4 to 5, you can see it goes up to about 4% to about 17%. So what we showed was that if you move these patients, especially the high Dow score patients, earlier out of the emergency department, you can see that if they're going out of the emergency department in less than 8 hours, the risk of complications is, as opposed to 10%, falls down to 0.5%. So this is really important, that if you're going to improve stroke care in your hospital, you need to focus on moving these patients with a higher Dow score, or simply the ones who are much more severely affected. What about stroke units? As I mentioned, you need to have stroke units. So they're very simple, low-tech units. So compared to patients who go into a medical ward, you can see that an absolute difference of 6% of patients, more patients would go home if they're in a stroke unit. And you can prevent death in these patients also. And if you look at the details, and if you look at the numbers, which is very, very important for those of you who don't track the details of morbidity and mortality, etc. So you imagine your hospital, in your region, you had 1,000 patients with an acute stroke per year. Of these, 750 would likely be admitted to hospitals because other could be TIAs or too mild. So if you had 70%, this is important, if you can get 70% of these patients to a stroke unit, just by those numbers that I gave you, you'd prevent additional 33 patients from death or disability. If you give them aspirin, all these patients, you're preventing another 8 patients from death or disability. Now, TPA, which is very, we always talk about it. Unfortunately, only a very small percentage of these patients get TPA, where your prevention would be 1 additional patient. So stroke units are clearly the way to go. And these are recent data that, irrespective of age, whether they're male or female, or the stroke severity or the type of stroke, all the patients who are in the unit do better than those who are admitted to the medical wards. And there's data from multiple countries in China, India and Southeast Asia and Africa, etc. So they do well in all those countries. And here's some work that we published from Qatar on a stroke unit, where we were able to show that simply by creating a unit, you cut down your length of stay from 14 days to 6 days, and you can decrease your complications from as high as 23% to 6% by having them in a geographical area. Now, what is our data? Unfortunately, if you look at the percentage of patients or countries in the high income group, 91% of countries have stroke units, and only 13% or only 18% in the low income countries. And so that translates into more patients in high income countries getting acute stroke treatment, which is 60% versus 26% in low income countries. The healthcare, stroke care is even more dismal in Africa, where this is just recently published data from several countries, got published a month ago, that if you look at stroke units, which is the S, or if you have stroke centers, which is the next icon next to it, there's only 4 countries in all of Africa that have stroke centers, comprehensive stroke centers, and 5 countries that have what we'd call stroke, what we call stroke centers. So what can we do? There is a lot of work going on with the WHO. The MENA-SINO alliance is an alliance of multiple countries in the Middle East, and it also includes Iran, Pakistan, and Northern Africa. They're trying to increase awareness, and they're doing some excellent work. I was involved in some work in Iran, and I was very impressed with them. In Iran, they created this national acute stroke treatment plan, and was sponsored by the Ministry of Health. And one of the key things they did was that they established stroke units across the country, and also made TPA available for free. And it's been a spectacular improvement in the care of patients in at least one of the OIC countries. So what can we do? You know, we have to improve dietary habits. We have to increase physical activity and access to clean air. We have to focus on those risk factors that I've talked to you about. And some of the smaller things that we can do is, here's a very nice publication in the New England Medical Journal about 2 years ago from Bangladesh, where they've shown that if you actually aggressively manage hypertension in small communities, you can see a much better outcome in reducing the blood pressure, which is one of the most important risk factors for stroke. Not only that, the other area that I'm particularly fond of is that patients don't like taking multiple medications. So if you take a poly pill, you can see that your blood pressure improves better, and your outcomes are better also, and you can decrease your cholesterol levels also. So most of these treatments are simpler. So when I talk about what happened in Iran, when I talk about hypertension management, and I talk about poly pill, I'm trying to emphasize that in countries where resources are limited, one has to look at these proven therapies that work and that are not very expensive. One other thing that's important is how do you manage these patients in hospitals, right? So this is a beautiful publication just a few weeks ago. It talks about management of acute stroke in somewhat resource limited settings. And their entire emphasis is on stroke unit, where you want to make sure that the glucose is well managed, that you can prevent aspiration, and you can prevent infections and bed sores in these individuals. So my emphasis again for the group who's in the audience is that you've got to focus on 2 or 3 things. Most importantly, managing the preventive strategies, and secondly, from what I've found out in the middle in my country where in Peshawar, I graduated from, that most of these patients are getting aspiration pneumonias, and that they need to move these patients out of the emergency to a designated stroke unit. The final thing I want to talk about was in thrombolysis. I have been trying very hard to get hold of this agent. It's called staphylokinase, and it's genetically modified so that you can decrease the risk of sensitivity to it. But this drug seems to be as good. They just got published a a few months ago in Lancet, where they compared RTPA to staphylokinase in acute stroke patients. And the data is very impressive. They're almost identical. So I'm hoping that this drug will be cheaper. And for those of you who do not work in medicine, TPA is a good drug, but it's very expensive. So if we can find an alternate that's cheaper, then we can certainly use these in our patients. So I do want to summarize and finish on time. I can tell you that stroke is one of the most important causes of disability and death. And disability is really important because most of these patients do not have enough networks around to take care of them. And it's left to the families, and these patients may live for many years disabled. I think the OIC could work through the ministries of health to promote management, to promote good health, and to diagnose these vascular risk factors and treat them early and promote healthy habits. I would strongly urge you to consider coordinated efforts towards creating stroke units. They're not very difficult to do. They're much more cost effective in improving care. And if you have good units, this more fancy stuff about thrombolysis and thrombectomies would come in. It's just too expensive, and it's only available for a very small percentage of patients, whereas the stroke unit can help the vast majority of patients who are admitted. So in my final comments, again, I'm very thankful that you allowed me to make my case for management of acute stroke and how to improve it. So manage risk factors, promote good health, and go for stroke units. And I thank you,
Professor Dr. Ishfaq. So if there are any questions, you can put it in the chat box. What is the main challenge? Because you have been working in this part of the world for so many years. What do you think is the main challenge? Is the policy making, is the awareness, or lack of advocacy, or is just we have a small number of neurologists who could take care of these patients? So what seems to be the major challenge in this OIC arena related to stroke care?
I think all of the above. I mean, all of these. I'm just so impressed by the way the cardiologists have taken over and have managed and created all this, mortality, right? In our case, it should be morbidity, because stroke patients don't die. They actually are disabled from it. Our risk factors are similar. I think at the policy level, at the community level, at awareness level, and I don't think we have enough neurologists who can take care of these patients. In Canada, about half the patients who have strokes are actually being taken care of by family doctors and internists. So I feel that it's not just the neurologists who could offer them care. It is so important that we educate the emergency departments and very importantly, what has really made me feel quite aware recently is the lack of stroke units, because these patients are actually getting complications that are in many ways iatrogenic. And so awareness there is the key, I think.
Okay, thank you. I'd like to welcome Professor Dr. Sharafnur Öztürk, who is the chair of the session. She has joined us from Konya, Turkey, and she will be chairing the session with us. And now I would like to invite our next speaker, who is a very good friend of mine for many, many years, and Professor Dr. Mazharul Mannan. We have worked together in the Asia Pacific Stroke Organization and the Asian Oceanian Association of Neurology. And I have been to Dhaka a few times, invited by Professor Dr. Mazharul Mannan, so I have enjoyed his hospitality. And he is very well known across Bangladesh, not only Bangladesh, but the whole region. His father was one of the most famous neurologists in Bangladesh, and Mazharul Mannan is like his father, well known. He has done a great job in neurodevelopmental disorders throughout Bangladesh. He is a faculty at BSMMU, and he is also part of our Asia Pacific Stroke Organization. So we have invited him to talk on neurodevelopmental challenges, and he'll be talking about this issue not only in Bangladesh, but the whole OIC region, and what can be done to address this problem in the OIC countries. So it's up to you. It's to you, Professor Dr. Mazharul Mannan.
Good afternoon, good noon, good day, good morning. It depends on from where you join. And assalamu alaikum to everybody. It is really always pleasure to work with Professor Wasse. We are not only friends, we are like a family members, and we have a very good times everywhere. And obviously, some of you, we already know each other. So it is always a pleasure to see you all together. Fantastic. I have to say, I have to admit, again, it's a fantastic initiative by Professor Wasse to put all of us together and to organize such a fantastic program, which is not only full of knowledge, but also full of surprises that how many things we are doing all over the OIC and all over this region. As we already know, the time is a little bit out of our hands. So I like to start sharing my slides. If you can all see me, I hope that you can see me.
Yes.
Okay, so though it is, we call the Bangladesh Initiative on Autism and Neurodevelopmental Disabilities, it's not only Bangladesh. We work together very strongly with the regional countries. Unfortunately, not all the OIC countries, but in Asian region and some of the OIC countries, we already work together for a long time. Joining this initiative, it was initiated by our daughter of our Prime Minister, Sheikh Hasina. Her daughter, Saima Wazed Hussain, is now the ambassador of autism and neurodevelopmental disabilities. Obviously, she is also working with mental health and as a WHO and UN consultant. And so I have the opportunity, and still now we are working together. And let's see, we started working in Bangladesh with neurodevelopmental disabilities. Biggest organizational program was in 2011. All of you knows, unfortunately, we missed some of our country representative for some of our countries, but obviously you can see our Prime Minister Sheikh Hasina in the stage, and that time the First Lady from Sri Lanka.
Are not moving. Mazhar, slides are not moving. Could you put it on the slide share mode? It's not moving.
Nothing?
No, just the first slide.
Okay.
Maybe click like number 2 on the sidebar. Maybe we get it on the front.
Let's see.
Yes, now it's, yeah. So now we are number 2 slide. Yeah, it's okay now.
So it is too small to stay it like this, or you want to make it to enlarge?
I think it would be better if you could enlarge it.
Like this?
Well, it's the same. No change.
Please move this window away from the shared application. Let's see.
We can still see it. I think you can continue.
Okay, so I think, yeah, because so in 2011, we started with a big conference with autism and neurodevelopmental disability in Southeast Asia, with all the people who was actively involved with autism and neurodevelopmental disability movements in Asia and Southeast Asia. And with the help of WHO and Autism Speaks from USA, we organized the first conference on autism and autism spectrum disorder and neurodevelopmental disabilities in Bangladesh. where we get some other countries also. If you can see, we mentioned over here from Bhutan, Indonesia, Sri Lanka, India, Myanmar, Nepal, Jordan, UAE, UK, USA, and Thailand. So we started from there to work with neurodevelopmental disabilities in this region. And if you know that common challenges in our region, including OIC, it's the lack of evidence-based studies on neurodevelopmental disabilities. That time, I'm talking about 2010, 11, and 12. Lack of public professional awareness, stigma, misconception, discrimination, lack of resources, human, material, and financial resources, lack of interest or understanding as a huge public health issue. That these are the very common regional challenges we had. And challenges for developing countries like Bangladesh, obviously there was the stigma, limited infrastructure, limited scope for education and employment. Medical professionals have no training on disabilities like neurodevelopmental disability, or maybe lack of, So magnitude of autism in Bangladesh in that time, obviously we have more recent studies. Autism found to be 0.884% among children. That was a WHO. And then we had in 2009, we had a household income and expenditure survey 2009, where we find out 9% with disability, not neurodevelopment disability. We're talking about children with autism. That time also, we thought that it could be more than 1.5 million. And then we started in 2011 to do a situation analysis in Bangladesh. This is how step by step we go. And we conducted over a 6-month period situation analysis. What we have at that time inside the ministry or organization. So consider disability in general, had access to all government materials, involved cross-section and expert stakeholders, both government and private, found prevalence studies were few in number and varied in design, unreliable. So that was the situation analysis outcome that we did that time before we go for further. So you see, and we started also putting the parents together so that they can come out and speak. That is the biggest problem with the children with disability or autism parents or neurodevelopmental disability parents. They don't want to come out of the stigma and speak about themselves. So we started developing also organization where they can come out, speak and talk and learn and do better for their children. Prevalence by type exclude developmental disabilities, autism completely neglected. These are the findings what we find out in situation analysis. And we find out that it is 5 times higher in rural prevalence of disability, whereas service were urban based. So we have to think about this, that the studies shows what studies shows and what reality is. So, and what is on specific school was very few that time, only 3 in Dhaka, and those are also parents driven, and research practically non-existent that time. We're talking about 2011 and others. So after the conference in 2012, we had a press conference, Meet the Press. You can see our Prime Minister's daughter, our Vice Chancellor at that time of Bangabandhu Sheikh Mujib Medical University standing behind, our Honorable Minister sitting next to the Prime Minister's daughter, and representative from Autism Speaks from USA, the biggest NGO in USA who do also research, mainly research on autism and other neurodevelopment, on autism, sorry. So what happened next? The step we followed, we are setting up. So when we already find out that situation analysis, we set up Inter-Minister Coordination Committee, we call IMCC. We meet over 4-month period. We continuously meet every week, truly participative and consultative, secretary and additional secretary level, followed like mind map, started with 6 departments, and now many more others already enjoyed. Now we are having 17 ministry together. NGO committee, we put the NGOs because they are also in developing country. NGOs are the most powerful parallel power for in any fields. So research group on capacity building. So these are the things we start doing. And these are the meetings. You can see most of the major ministerial representatives are here, along with the specialist. Left side you can see specialist, and also our Prime Minister daughter, our Vice Chancellor, and others. Right side you can see the ministry secretary. Most of them are secretary that time of different ministries: health, social welfare, education, primary education, women and child affairs. This is the biggest power we had that time, that we was capable to put together all the ministries. Let's see what we have, how can we do together, and how can we improve and see the changes. So after that, we develop a strategic and convergent action plan upon the situation analysis. So then we took 4 months to sustain collaboration between 8 ministries. That time it was 8 ministries. We developed community awareness and empowerment, research and statistics on the public health magnitude of autism, multi-sectoral and multi-level capacity building we started. Why we are showing this to you all? Because you know, and if you Google wherever, you know that we are a very strong hold of working in autism and NDDs, the Bangladesh. And just to show that working step by step and together with all the ministries and resources, we can be very strong in this field. And I will show you at the end why we are showing this, because we have something in mind. So I will show you in the end of my slides. Development of a continued life cycle intervention within existing government and private frameworks. We start recognition of the effectiveness of multi-sectorial and strengthening of process through collaboration action at the community level. So what we need collaboration. Health ministry do something, social welfare ministry do something. It's very common in Asian countries, but they don't have collaboration, they don't have cooperation, they don't do together. So we try to make them working together and in field level and see how it's work. So the SCAPEN implemented, we put the Ministry of Health, Social Welfare, Women and Child Affairs, Education, Primary Mass Education, Labor and Employment, LGRD, Finance. So, and obviously together with NGOs, university training institutes and others. So this is how you see multi-sector life cycle intervention. Why? Because the strategic and convergent action plan, we need to include all the ministry, because when a child born, if we don't involve all the ministries from the beginning, at the end of his life, when he is becoming, let's say 14, 15, 16, 17, 18 years old, how he will be involved in productive work in the society, how he can be or she can be productive in the society. So that's why we put all the ministries from the beginning to see the whole life cycle intervention. When, which age, if you see this, that the age cycle, let's say 0 to 2 years old, that time, not only health, we write down the first one, the health, but obviously that time we can involve social welfare also. When this child become 2 to 5 years, health, women and child affairs, social welfare involved. Then so step by step, when they become elderly, when they become teenage, when they become a person with adult person, obviously we should know where and how to involve them through the ministry, through the government structure, to make them productive, make them useful to the society, or make their life easy by helping them settle down, learning things and others. So it's very, I know this slide is very hard to read and others, because it's too many things to put in together. But the main thing is we try to do a multilateral strategy. It's a big, so we make 3 committees that time: steering committee, the National Advisory Committee, and Technical Guidance Committee. Totally different. Why? National Advisory Committee is totally the bureaucrats, the ministries and others. They love to be together. They love to talk together. They love to be alone separately. But National Steering Committee obviously have ministries, obviously have NGOs, people working with a different field, and National Technical Guidance Committee is totally those who are very much specialists in this field. These 3 committees work together parallelly to find out the ways, find out the system, find out the problems, and also how to solve it, where to work. These are some meetings pictures. It is inside the ministry. Health, that time health secretary usually, or health minister usually lead the ministerial meetings and discuss every 2 or 3 monthly where we are, what to do. So, and this is how the ministries work. The health ministry work in screening, early detection, assessment, diagnosis, parent counseling. These are the things they do. Social welfare ministry do their physiotherapy part, giving them ID cards, other support services, assistive device. Women and children affairs do awareness, inclusion. Obviously, awareness also do by the other ministries also. But these are the major works they do, different ministry, primary mass education, secondary education. We later, in 2012 and 13 and 14 and 15 and 16, every time we change, we find out different way of involving different ministries to make it more effective and more sustainable. So these are then local government also, their finance is there. So, and this is how highlights of SCAPAN. So we mapped existing resources of 8 ministries. We develop horizontal model of autism inclusion. We develop life cycle needs, universalizing access, providing detection and intervention, involving civil societies. And this is when we hand over all our findings with the action plan to our honorable president in to make it more effective and to get his help. We involve all the ministries and to effectively involve to implement what we find out and what and where to do. International policy, you will be happy to know, and some of you already knows, that the government of Bangladesh, with the support of 70 co-sponsors, tablet resolution ARES 67/82 on December 12, 2012, addressing the socio-economic needs of individuals, families, and societies living with autism spectrum disorder and other developmental disabilities. We passed this UN resolution, and we are really happy that Bangladesh lead this year, and with 162 or I think more countries supported this, and we passed the UN resolution in 2012. And in 2013 at WHO, we also passed a resolution on ASD with co-sponsored by 53 countries. And obviously Qatar was our very close ally, our friend, who was the very strongly supported among those 53 countries. And we passed the resolution at World Health Assembly in May 2014. These two Bangladesh achieved. And then we have in 2011, we have Dhaka Declaration. 2012, we have resolution on ASD at Yogyakarta with CRO countries. 2013, we have a Delhi Pledge in India. And 2017, we have a fantastic NDDs and autism conference in Thimphu, organized jointly with WHO, Bangladesh, and Bhutan. And I think you remember it was a fantastic place where to be in Bhutan. And we obviously passed a resolution in 2017, which called Thimphu Declaration. And this is the picture of the sun we have in New Delhi, and awareness and information that we work on through the whole last 10 years. Recognition of autism as a medical disorder we are working on, and not only the mental disorder. Participating in international awareness campaign, disseminating information through local media, collaborating with local health and education campaigns, addressing existing myths and cultural beliefs, educating all professional and current research and data. And obviously we work very strongly educating parents and caregivers. That is the most important point we want to address next couple of 10 years. This is the change. In 2010, when we started working, that time you couldn't see such a gathering of children with autism and neurodevelopment is coming out of from the family, coming out of the society, coming out of that dark room and having together, enjoying life. See the smile of these children. This is the changes we achieved by working together with all the ministries and the regional countries, with the help of the regional countries. and we developed Mina poster. It's called UNICEF has a something Mina cartoon. We developed some posters and cartoons. We always celebrating World Autism Awareness Day by lighted up blue every 1st of April night, because 2nd April is the World Autism Awareness Day. We increase in the country capacity. First stage we do focused on sensitization and understanding about all disabilities. In second stage, we involve specialized training on distinguishing different developmental disabilities. In the third stage, we training our experts, develop our experts to make master trainers for whole country. Evolving support service, professional educational and developmental training courses for doctors, health professionals, teachers, therapists, and community health workers. We develop them. We sensitize training program have been conducted for administrative officers like bureaucrats, teachers, police trainers, medical professionals. We don't only train medical and health workers. We train everyone, every sector. Even now, every month, we have different people for different sector, from media to police, armies, and other sector, and obviously with root level political people, root level teachers, and root level others also. The Ministry of Social Affairs has launched an extensive project to build 68 integrated service center to offer rehabilitative service all over country. Completed a national survey also, they completed. And in 2013, we passed a law on disability, and you will be happy. In the same year, we passed Neurodevelopmental Disability Trust Act in Bangladesh by the parliament and the cabinet, where we include 4 major neurodevelopmental disabilities, and we ensured their rights, and we ensured their future through the law. And now what we need among us today is this OIC, the region, what we need, planned and collaboration approach, dovetail ASD service within existing educational, health, employment, social, and developmental programs with a continuum of support system. We need help. Some of your countries may have more developed system, more developed screening tools, more developed other system that we can implement in small countries like Bangladesh or small like Nepal, Sri Lanka. We need to share convergent service delivery system, which should be cost effective and sustainable. International collaboration and partnership with governments, organizations, experts, and families. Empowerment of parents, very important things we need to do. Promoting strengths and skill of person with autism, creating self-advocates in every field. And I know India is doing very well. You can see our Prime Minister with all the regional representative who was there in 2014 conference or 2012 conferences. So there is the people who are here. We meet with the there is the WHO, DG of WHO, Director General of the WHO was there, and the whole team was meet with the Prime Minister Sheikh Hasina and the other year. Why we need collaboration? Because common objective is the same. We need improve on existing service programs and opportunities to reduce redundancy, repetition, increase the feasible and sustainable accessibility, increase the accessibility to service, and increase the capacity. So, and we need inclusion in all sectors like education, social, and finance. And there we need collaboration. Goals of the global initiative that we now working on, global initiative to promote, protect, and ensure inclusive development, to address life cycle through multi-sectoral and multi-level planning and action, to share cost-effective, sustainable strategy of service delivery system that if any of your country have, we can share, we can do partnership, and to raise awareness, end discriminatory practice, enhance greater participation and inclusion within the communities. We need this to do all together in global way, and also to promote greater access to health, education, employment, to enable and empower individuals with autism and families to be involved in decision-making process. These are the things we need to do. Actionable areas of the global initiative of autism: awareness, convergence, research and data collection, plan development of professional family members and grassroots level service providers, government personals to understand and address autism spectrum disorder issues. This is how we do the capacity building. We need to do work together. We need to share if you have more things. Development, adoption of supportive policies and legislation specific to autism. And the other things, address issues of financial empowerment and skill development for persons with ASD, ensure a range of options for living, including independent living in the community. We need to do enable person with ASD to become self-advocates through leadership training, invest in the empowerment of families. We need to invest in this sector, identify and address barriers to inclusion of person with ASD, autism spectrum disorder, and promote accessibility. And these are the things, these are the field in a big nutshell where we need to work together inside the OIC, inside the region, and obviously we need to share our knowledge, our research, our working capacity, and anything we find out, anything, even if it is a screening materials, if it is a diagnostic materials, if it is a awareness materials, we need to share. Thank you very much. This is my email. If you want to write to me, it's my email where you can write, we can communicate, we can discuss, we can work together for the future betterment of the people with person with neurodevelopmental disabilities. Thank you very much.
I think Professor Wase disconnected. Shamshad, please make Professor Wase co-host again so he can unmute his mic.
Professor Asai.
I think he's rejoining, so we'll just give it a minute to make him co-host so he can.
Actually, I will introduce the next speaker. Good morning, everybody. Do you hear me?
Yes, ma'am, we hear you.
Yeah. I would like to thank again Professor Vasai and all organizing committee to chairing this very important session. I will introduce our next speaker, if it is available.
Sure, I think.
If there is any question, no question. If there is any question, please put in the air. Thank you.
Sorry?
If there is any question or anything, please just let me know in the chat box or in the email. Thank you very much, Mr. Chairman.
Okay. Thanks, Dr. Manan. It was excellent speech, very informative. You have really great efforts on this area, and we need to announce all these efforts and strategies to other regions and other countries, actually. Very, very effective strategy you have. Our next speaker is Professor Mustafa El-Alawi Faris. It's a great honor to introduce him. He is a professor of neurology at the University of Mohammed and director of the Alzheimer's Center of Rabat, and Professor El-Alawi Faris is president of Moroccan Foundation against neurological disease, and he was past president of WFN migrant neurology specialty group, and he had unbelievable efforts on these. We had very important efforts and activities, and he's also editor of the book of neurology in migrant and refugees. I would like to thank again for his all these great efforts and motivation on this special area. Please, Professor Alawi Faris.
And
the topic is neurological issue of refugees and migrants.
Professor Sefna, we are actually trying to connect with Professor Mustafa. He's unfortunately not connected via Zoom due to some technical issues.
Oh.
So I would request you, if you can continue with your presentation first. Meanwhile, we are sorting out the issue of Professor Mustafa for the connection via Zoom.
Okay. I will try to.
Really sorry for this technical issue.
Okay. Yes. Thank you. I will introduce myself. Do you see me? Yeah. I'm professor of neurology in Selçuk University in Konya, Department of Neurology, Neurointensive Care and Stroke Center. And I was past president of Turkish Neurological Society, and we had a lot of efforts on environment and to make some policy and strategies. And I'm co-chair of WFN environmental specialty group, and I would like to thank again Professor Vasai. He is our general secretary in this group, environmental neurology group, and he's always very active, you know, very well. And within this group, we are trying to increase awareness and to make some activities and strategies to increase care on this subject. And neurological diseases, environmental factors, genetic factors, treatment and prevention are always related subject, and they affect each other continuously. And we know that 23% of all global deaths are attributable to air pollution. And out of these 12 million deaths, 8 million die as a result of air pollution triggered non-communicable diseases, and they are including stroke and myocardial infarction and other vascular diseases. Stroke ranks the highest at 2.5 million, and this rank followed by heart diseases, not low, it's 2.3 million deaths, and other neurological consequences, especially in the form of neurodegenerative diseases like Alzheimer's diseases, Parkinson's diseases, even multiple sclerosis and other polyneuropathies and other rare neurodegenerative diseases are also related to environmental factor. We will discuss all environmental factors one by one. The most important part is air pollution. Air pollution is considered one of the most important risk factors for stroke and represent the world's largest single environmental health risk. This is defined by WHO, and this is triggering a global and diffuse chemical contamination, and all these contamination mostly directly related to our activities, unfortunately. 29% of global stroke burden has been attributable to air pollution. This was very important report and paper, and it has a great effect on awareness on relationship between air pollution and stroke. So we are asking our patients for their cities and situation of air pollution. Air pollution is defined as the absolute increase in pollutants, especially particulate matters are important, 2.9 and particulate matter 10, sulfur oxide, nitrogen oxide, ozone, and carbon dioxide. Air quality index is important to show cities' air pollution situation, and many cities, many countries using this scale as routine data. Air quality index describes the cumulative impact of 5 air pollutants, including ground level ozone, particle pollution, carbon monoxide, sulfur dioxide, and nitrogen dioxide. And if you look at the global air pollution situation affected on household air, you can see the highest areas, highest air pollution situation in Africa and lower part of Asia, actually. And we know that the environmental factors are more effective on this area because of wars, because of climate, because of other related factors. And you can see again on this figure, African region and South Asian Asia region. The western part of Turkey is more lucky for to have more maybe cleaner air, household air. If you look at air quality index, we can see very striking levels. The ideal level is between 0 to 50 clean air. Unfortunately, a very few region of the world has this chance. And between 51 and 100 moderate air, you can see moderate size cities. And in a bigger cities, between 100 and 150, this is unhealthy, and especially winter times, you can hear some announcement, please don't go out, please stay at home. So this is dangerous, and this is more dangerous, especially in special areas of cities related to fabricas, big production sites. And 250 300, very unhealthy. And this is really very special condition. And more than 300 is really very hazardous, and you can see acute disorders related to this situation. Yes, air pollution cause all global deaths of all deaths, and it's 27% that are caused by air pollution. And future studies, we need future studies to focus on high-risk population, including elderly people with diabetes, multiple cardiovascular risk factors, with carotid diseases, because we believe that air pollution has more impact on these special groups. And air pollution is a global emerging concern. Pollutant transportation is important. Atmospheric brown clouds are important. Desert dust storms are very, very effective. And giant wildfires, unfortunately, we all see these kind of fires in our rural area, in our forest, unfortunately. Reduction in human activities linked to air pollution, including road, air, sea traffic, can result in a dramatic reduction in air pollution, in particular nitrogen dioxide. During the pandemic, there are many reports related to this. There's an important decrease in pollution because of restrictions of pandemics. Maybe if you need more. As Turkey, we are not so good condition. We have some cities which have important environmental pollution, but we have also some green cities, not too much. And we have a platform, clean air platform, is fighting on this subject. Yearly 30,000 premature deaths from air pollution was reported, and no regulation about the limit values of particular matter 2.5 yet, and only pilot measurement stations we have. In 2017, only 1 out of 81 cities had particular matter 10 levels below WHO guideline levels. Air quality at 67% of the cities are dirty, even according to national air quality limits. 7 existing coal power plants has exception to emit above EU limits until 2020. Since 2017, nearly every year, 7 times more people die from air pollution compared to car accidents. Actually, this is very, very important, very serious problem. We are aware for car accident, other factors, but we don't have many awareness for air pollution, but we are trying to increase this awareness, this issue. We are trying to add this issue to medical school training programs, core curriculums, and to establish awareness in an early years of medical training and medical proficiency. No health impact assessment or cumulative assessment in permit process of industrial facilities. And, you know, politicians are always using the need of industrial facilities, and unfortunately, non-planned or industrial facilities which are not good established are causing more environmental pollution. And there is another environmental factor, global chemical contamination. This contamination is silent, actually silent. We don't recognize this factor. Diffuse, occurring in all media, in air, water, soil, in a heterogeneous way, and it's worldwide. Its role in the dramatic increase of the non-communicable disease is really very important. These are endocrine disruptors or chemicals. The European Commission defines endocrine or chemical disruptors as an endocrine disruptor is an exogenous substance or mixture that alters functions of the endocrine system and consequently causes adverse health effects in an intact organism or its progeny or subpopulations. So, another important environmental part is biological aberrations and disruption of ecological systems. Infections are very important. Actually, we are very aware for the infections because of current COVID pandemics. But infections are well-known etiology of stroke with strong links, especially tropical infections such as malaria, Chagas, neurocytosis, commonly affecting younger people. And infectious diseases increases the risk of ischemic stroke, we know. And there are many reports for relationship between multiple sclerosis and previous or continuous viral infections or protozoal infections. And vascular complications of COVID-19 pandemic were discovered and understood during the first wave in the Europe, and we are all aware, all stroke neurologists, for the effect of COVID-19 on stroke, especially on stroke risk factors. Their high rate was hardly predictable. COVID-19 is a risk factor for ischemic stroke and acute myocardial infections. At least it has many unwanted effect on prognosis, especially patients with other comorbidities and risk factors. And urbanization is another danger. More than half of the Earth's population lives now in urban areas, and often we all are living in megacities, which has dangerous level of air pollution. And related risk factors are complex as there are multiple and they interact with one another. There are other chemicals, hazardous chemicals. The urban life is characterized by various factors such as overcrowding, violence, psychological and occupational stress, and nutritional behavior. And urban life is further negatively impacted by urban air pollution and noise generated by car traffic, airplanes, occupational settings, and frequently also we have excessive waste issues and we have inadequate sanitation. And urban life is also a danger for pandemic situations. And the health beneficial role of cities' green areas has been demonstrated with many reports. And we have another important issue which is related to environmental pollution and also this human-made factor beside natural factors, climate change consequences, temperature extremes. Global warming related increases in heat have been associated with 50% increase in heat-related mortality for especially elderly people. And climate change consequences are heat stroke, dehydration, renal failure, dermatological malignancies, tropical infections, adverse mental health, pregnancy complications, allergies, and most importantly, cardiovascular and pulmonary events. And climate change has also resulted in a global reduction in the yield of crops, falling by 1.8% to 5% since 1981, resulting in malnutrition. And we know that a very large area of the world are complaining from hunger, actually, from malnutrition. Subtle environmental changes due to global climate change have also resulted in the destruction of habitats and species, resulting in erosion of water and food security. And transport-wise, excessive dependence on motorized vehicles to travel long distance cause to increase air pollution and reduces physical activity, and poor nutrition in unhealthy diet, high in animal products, and processed foods increase stroke risk and other neurodegenerative diseases. We don't know exactly, but there are some suspicions on this. And there are many factors, you know, from livestock, plastic waste, other factors. Green cities are very important. We create our green spaces. A green space is defined as open, undeveloped land with natural vegetation, but also exists in other forms such as urban parks. Yeah, so we can build, we can establish our green cities, our breathing area in our cities, actually. We can create parks, public open spaces, street tree, greenery. And WHO launched the Healthy City and Villages initiatives, which defines a healthy city as one that continually creates and improves its physical and social environment and expands the community resources that enable people to mutually support each other in performing all the functions of life and developing to their maximum potential. This is very important. What you see is very important. What you live, the environment which you live, very important. Previous years we had architecture department. They conducted a study for the effect of buildings on brain of the people, fear, agitation, or relaxing. And we saw that nice green buildings, green parks are really very important effects on piece of soul, piece of brain. So with functional MRI, we have shown this. It was very, very surprising. Yeah. And green cities, forest bathing, these stress treatments are reporting, are having announced by more with the passage of year. Exposure to green spaces are associated with greater physical well-being, improved perceived general health, mental health, and stress, reduced obesity, greater birth weight, and reduced cardiovascular and all-cause mortality. This is really very important issue, and we must actually push our politicians to establish this kind of area in our cities. So what are the mechanisms of green spaces on health? So these provide more opportunities for physical exercise, greater opportunities for social interactions, greater exposure to sunlight to counter seasonal affective disorders, and more vitamin D, increased exposure to microorganisms that support the immune system, cooling influence of green space on surface radiating temperature, and less sun exposure. We know that less sun exposure reducing risk of skin cancer and heat stroke. So what is the future? How is our future? We need a change in the perspective of prevention, and it's time to consider prevention at the level of our communities and not only as our patients' personal individual responsibility. Most require action at the level of our communities and societies. We need to push, to motivate all sections of governmental level. Systemic advocacy, important. Advocacy creates awareness and pressure on policy and decision makers, and we are starting to see real impact as more people are becoming aware of the health impact of climate change and air pollution. So actions at the different levels are very important and must be combined. These can be individual as advocacy, role modeling, engage patients and colleagues, and with our research, and collective. It can be collective. Again, advocacy important, policy and politics and research methods, and both we can combine these advocacy to prevent individuals and patients from harmful effects of environmental pollution. So what would be environmental research topics? We need to know more about both the short-term and long-term lifetime cumulative effects of pollutants. And we need to know effects of air pollution to neurological diseases algorithms, focus on combined effects. Actually, we can research more than one effect because they can affect each other. And epigenetic changes and hormones are very important, and new therapeutic targets with epigenetic modifying drugs are important subjects to research. Yes, advocacy and policy is important. Advocate at local, regional, national, and global policy level for policy carbon taxes, green spaces, shift to renewable energy sources. So we must use our voice. And we need to reduce the social and economical inequities. We need to advocate for and use telehealth. This is a new, actually not so new, but it's increasing trend, telehealth. Access to green spaces for prevention, decreased severity, mortality, and increased recovery. Wealthiest countries need to support poorer nations. They have responsibilities on all the world. Make impact on climate change an active consideration and consider becoming an advocate to benefit both patients and planet. We have one planet to live. And increase awareness for climate change and environment with media and political agenda highlight its important area for WSO. Increase awareness, advocacy, education, and research for air pollution and neurodegenerative and neurodevelopment disorders. Increase awareness for the importance of low birth weight of babies and their nutrition. We must collaborate with WHO, environmental experts, and environmental activists, and we must collect more data, more interventions for interventions, mechanism, and outcome. And we must regulate health policy, measurement of ozone and particulate matter. We must redefine normal values. We must define impact of COVID-19 lockdown on stroke incidence and maybe for on other diseases. We must reduce ambient noise. This is important. Generalization of influenza and COVID-19 vaccinations are important. We need to increase awareness for need of vaccination. And we need to reduce the duration of work to find enough time to care our health, actually. And the most important area for research, toxicological research, medical research, social and human research, research into green spaces, research for prospective epidemiological studies, on different populations, on different pollutants, short time and lifetime cumulative effects of pollutants, effects of air pollution, and climate change to stroke algorithms. And we need to make partnership with industry to identify shared opportunities and reduce waste. We must consider climate change in our overall organization research strategy, and we need to regulate health inequities and actively enhance positive environmental impacts. We need to make researches for epigenetic changes and hormones, and we need to investigate how to achieve behavior change to adapt healthier planet and friendlier lifestyle. And we can have urgent solutions for patients and even ourselves. Recommend activities in nature, for example, promote advocacy for more urban green spaces, promote more development of public transport and walking, recommending eating predominantly local, unprocessed, plant-based foods and drinking waters, measure individual exposure, and lead by example. We must be role models. Yes, we are a summary of our recommendations. As WFN Environmental Specialty Group, our president is Gustavo Roman, and I'm vice president, and dear friend, my dear friend, Professor Vassai is Secretary General, and he was really very active in the previous stage of this group, and he's still studying very hard and motivate us. And you see our specialty group, and we have important aim and visions. The goal of the environmental neurology specialty group are to increase awareness of the relationship for the environment and neurological disorders, to promote education and clinical research in all matters having to do with the adverse effect of environmental substances of interest, include agents that occur naturally, and as well as pollution that arise as a result of human activity. And humans may be exposed to these substances, events in industrial occupation situation, or as a result of terrorism or forced displacement. And there are very important and global threats, we know, and we are studying on it. Activities, we had many activities in WFN Congress and other congresses and meetings to increase awareness on air pollution, environmental factors, and relationship between neurological disorders. And our hope actually is clean and healthier world, and we all have a voice and could contribute to these global efforts to effect important, impactful change. Yes, I wish a very healthy, very nice world for all of you, and thanks again for your patience and interest. Thank you very much.
Thank you very much, Professor Sefner.
Thank you.
So we have Professor Wasse with us back. Let's see if we can unmute Professor Wasse.
Thank you, Dr. Sharaf Noor. I think this was a very interesting topic you covered. I have just, because you put a lot of recommendations for the OIC countries. So how this OIC countries work with the WFN specialty group together to work on this agenda. I think this is going to be very important for future interventions related to environment in this area. So what do you think that we should work together, and how should we work together?
Yeah, thank you very much. This is really very important issue. And
we can hear you.
Do you hear? Do you hear me?
Yes, you're audible. You're audible.
Okay. Thank you very much for this very important question and suggestion. I would like to thank also to our specialty group, Professor
There is also
Wasse.
a question in the chat box if you could respond to.
Okay. Professor Wasse, Professor Anna Ranta, and Professor Jacques Reis, we prepared a position paper actually for all these issues, and I used this paper for my speech. Yes, all regions have different threats actually for environmental pollution, and within this group we can have ambassador for different regions to prepare specific data and to prepare specific brochures and advocacy matter actually, because different regions have different factors for pollution, and epidemiological data are also very different. And first of all, we can have maybe we must have prompt epidemiological data for this special region, and we must discuss all these issues with our members, and you're very welcome if you have suggestion for this issue. And please, dear audience, our audience, please suggest your suggestions also for this issue. We can evaluate them, and you can contribute to this important plan, actually. Thank you.
We have a couple of questions in the chat. The first one is how to decrease environmental stress over neurons.
Sorry?
There's a question, how to decrease environmental stress over neurons.
Yeah. Yeah, there are many factors which have effect as stress on neurons. These are air pollution, these are chemicals, these are noise, these are stress, psychological stress, these are all and epigenetic mechanisms. So air pollution is very important. We must decrease air pollution because air pollution can show effect on all media, on air, on soil, on water, on foods, on everywhere. And we must plan green spaces or some environment like green spaces at least. And we can behave healthier as individuals. So this can be specific to the region for these different effects. So we must find our way as neurologists, as doctors, in a healthier way. Thank you.
Thank you, Professor Sefner. Because we are short on time, what we'll do is any other questions, you can email them to me at hasib.ahmed.comstech.org, and I'll forward them to Professor Sefner to be answered. Professor Sefner, I would request you to introduce our next speaker. His lecture is recorded, so we'll then play the video.
Professor Mustafa El Alawi Faris, is he here now? No?
No, so it will be Dr. Adnan Qureshi.
Okay, fine. It's a great pleasure to introduce Professor Adnan Qureshi. We know him very well, I'm sure. He is past president of International Society of Interventional Neurology, and he has actually very important support on the societies of interventional neurology. And I know that I know from our young colleagues, he was very motivated, very supportive to increase efforts on neurointerventional area, and all neurologists actually have some motivation to do this, at least to learn this, at least to create interventional area on their regional hospitals. And he is professor of neurology in University of Missouri at Columbia, and a lot of publication, a lot of research, and we are very happy to have you in this Congress. Professor Qureshi, please. The title is Improving Neurological Research Across OIC.
Good morning. Thank you very much for having me as part of your symposium. So I'm actually going to talk about neurological research and the opportunities and the challenges that are associated with doing neurological research. So I think like any opportunity in life, there are always things that are considered as opportunities or positive, and there are the challenges that may actually appear as negatives. So when I look at the question of neurological research, I think that perhaps some of the things that are positive are highlighted in green. So there's obviously interest. That's why we are having this conversation. There is a large number of patients that the OIC as a group does see. There's a large number of research staff. And the cost of doing research is actually low. However, there are certain negatives. Perhaps the knowledge level may not be there. Although there is a large number of patients, but perhaps the number of research centers may be actually low. Centers that actually can perform research and not just manage patients or perform clinical care. One of the challenges I see is always that there's a lot of clinical responsibility. So obviously then it takes limited resources and limited effort that's left for clinical research or research in general. And again, the funding opportunities are limited. Research does cost money. And essentially in the absence of a sustainable research funding, it is hard to actually continue research. So well, one would think that these are the limitations, and perhaps other countries, the United States, do not have challenges. But I think that perhaps you need to look at a closer look and understand that challenges exist everywhere. So I think that, yes, perhaps there is more interest, perhaps there is a knowledge base and infrastructure in place, perhaps there are funding opportunities that are greater, but there's a limited number of patients. There are multiple trials going on for the same group of patients. And the research staff is actually low. Research staff is very expensive and it's hard to maintain. So there is actually a limited number of resources that are available for research. Surprisingly, yes, there is a large number of hospitals in the United States, over 5,000 hospitals. But actually, if you look at the hospital that are research capable centers, that is surprisingly pretty low or very low in the United States. And clinical responsibility is an issue everywhere, even in the United States. There's a constant challenge between clinical responsibilities and time and resources allocated to research. However, if you look at the productivity between the two scenarios, there is a marked mismatch between the amount of research that's to be done in the United States as compared to other countries. And actually, I want to clarify that there are other countries that have done better than the United States or continue to do better. I think that there's an emergence of more productive research in China and Europe now. So I think the scenario is actually changing. But I think that there are two unique challenges that we have to acknowledge. I think that there is not a clear reward for doing research in many countries, and perhaps the OIC countries. And I think there's also a lack of spirit of working as a group. I think we all perform exceptionally well as individuals, but perhaps not so well in working as a group, which seems to be an essential element for conducting successful research. So I think that at some point, we have to strengthen the weaknesses if we're going to look at these neurological research opportunities. And essentially, the only way to strengthen these resources would be to actually do work, actually do clinical trials, and work through clinical trials to strengthen some of the gaps that we have seen or have identified in the previous slides. Now, I want to actually say that perhaps the start shouldn't be a complex clinical trial. It should be a simple, pragmatic clinical trial. And actually, surprisingly, that's where research is moving. Even in the United States, there is actually increasing emphasis on doing simple, pragmatic clinical trials because it seems like the yield is much higher, the cost is much lower, and in the end, the impact to society is far more favorable with pragmatic clinical trials than more complex, sophisticated clinical trials. What does a pragmatic clinical trial really mean? I think it probably is the intervention is simple. And if you look at the intervention that have really made a difference, for example, let's take patients with stroke. and the outcome of patient with stroke, it has not been the most sophisticated interventions as mechanical thrombectomies and intravenous thrombolysis. It has far been standardizing care in stroke units and simply taking some basic steps to improve the overall quality of care for these patients that have probably made the greatest impact than more sophisticated interventions than mechanical thrombectomy and intravenous thrombolysis. Conduct is simple. So instead of a more sophisticated design, it actually is a more simplistic design. And with limited data that is collected, I think that there is a recognition, even in the United States, that trials have been trying to collect a lot of data that in the end doesn't really play or doesn't really add to the scientific question or answering the scientific question. And there is a large amount of data that's collected that is never even analyzed in clinical trials or not analyzed to its fullest potential. So I think that perhaps our focus, if we're going to move forward, should be a simple, pragmatic clinical trial. For example, I want to work with an example, and this is something that I've been working with Professor Wasev, intravenous fluid therapy for stroke treatment. Now, there is almost 15 million people that have stroke worldwide every year. Intravenous fluid is used in approximately 14 million people, stroke patients, every year. That is 100 times more than intravenous thrombolysis or mechanical thrombectomy will be used in stroke patients worldwide. And now we also know that if you look carefully, existing intravenous fluids have high chloride content and perhaps low osmolality, both of which are actually associated with an increase in death and disability after stroke. And there is room to actually improve upon that, perhaps develop an intravenous fluid that actually is chloride deficient and has the best composition, and that may actually make a much bigger impact on reducing death and disability after stroke than perhaps more sophisticated intervention. And actually, if you look at patients with intracerebral hemorrhage, and actually look at those patients who develop hyperchloremia, so an increased chloride content, something that we've always ignored, and who has ever actually cared about chloride content and chloride composition or chloride levels in patients with stroke? But actually, if you look at patients with intracerebral hemorrhage and actually look at mortality at 90 days and death or disability at 90 days, patients who actually have no hyperchloremia and compare them to those who actually have one occurrence of hyperchloremia and two or more occurrences of hyperchloremia, and again, hyperchloremia being defined as a serum chloride level of 110 millimolar per liter or greater, there is a significantly higher rate of death and significantly higher rate of death and disability at 90 days in patients who actually have multiple episodes of hyperchloremia or even a single episode of hyperchloremia. And this is actually after adjusting for all the other known predictors of outcome in intracerebral hemorrhage. So surprisingly, something as simple as an electrolyte imbalance like hyperchloremia can make a big difference on patient outcome. And that is not just limited to intracerebral hemorrhage. You see the same effect in ischemic stroke. So if you analyze the data from the ALIAS 1 and 2, and actually look at patients with ischemic stroke, and look at the rate of death and disability at 90 days, and actually look at one occurrence of hyperchloremia and then two or more occurrences of hyperchloremia, even after adjusting for the known covariates of age and the National Institutes of Health stroke scale, there is a significantly higher rate of death and disability in patients who develop two or more occurrences of hyperchloremia. And you can actually see the odds ratio is 2.7 with a confidence between 1.7 to 4.2. So again, not just an intracerebral hemorrhage, but even an ischemic stroke, high chloride or occurrence of hyperchloremia actually increases the rate of death and disability at 90 days. Now, actually, it's also important to recognize that most of this hyperchloremia that we are seeing in these patients is introduced by the patient with the intravenous fluids that we're giving. We're giving them a large content or large amount of normal saline. that actually perhaps is sodium chloride that's a little bit higher than serum chloride, but definitely much higher chloride content than compared to the serum chloride content. So we could actually simply do a simple trial, a seamless phase 2, phase 3 trial. We'd actually look at intravenous fluid that's more appropriate and compare it to the standard intravenous fluid in patient with acute stroke, which includes patients with intracerebral hemorrhage and those with ischemic stroke, and take them within 12 hours and start an intravenous fluid that usually will be continued up to 72 hours and look at the outcome at 90 days. It's seemingly a simple intervention, a simple design. And obviously we need to find what is the right fluid to be used in the clinical trial, which we call as a phase 2 dose finding study. We need to do a phase 2 futility study with a larger number of patients to actually see that there is at least an early signal that the death and disability will be lower with reduction of hyperchloremia. And then if all of these pieces add up, actually do a phase 3 efficacy trial where actually you're comparing the standard intravenous fluid with a new intravenous fluid that supposedly avoids hyperchloremia and making or assessing whether it reduces the rate of death or disability. So the first part could be simple, which is what is a dose finding study, where you usually take multiple doses. In this case, it will be multiple compositions of intravenous fluid to determine what fluid actually reduces the incidence of hyperchloremia. So the outcome is very simple. Essentially measure serum chloride for the first 3 days and find out the fluid that actually results in the lowest incidence or occurrence of hyperchloremia. You have sodium chloride, which is the standard fluid today in most places. And then you actually can use a mixture of sodium chloride and sodium acetate. So essentially you're not giving up on the sodium content, which actually seems to be important and beneficial for maintaining serum osmolarity that's favorable for the brain. But you are giving up some of the chloride content and replacing it with acetate. Now we don't know what mixture would be best. So it could simply be a 3-to-1 ratio. It could be 2-to-1 ratio, or it may actually be 1-to-1 ratio. That may be the best suited. So essentially we will be trying 4 different fluid compositions or 3 different new fluid compositions against sodium chloride to determine which one can actually provide us the best results when it comes down to avoidance of hyperchloremia. Once we make that selection, then we go to the next level where we have taken the normal saline, which is the standard fluid, and now we're actually comparing it to a combination of sodium chloride and sodium acetate. And whatever that ratio we have actually selected in basis of dose finding study, and now we're actually doing head-to-head comparison. Now the phase 2 futility study usually is not powered to actually show a statistically significant difference between the 2 groups. But it actually is powered to show a meaningful difference, a difference that would be compelling enough to actually move to a phase 3 trial. Because if in the initial analysis, you're not even seeing a signal, not even a hint that this actually could be beneficial, it doesn't make sense to actually go through phase 3 large trial, large number of patients are recruited when the early evidence was not even supportive of actually moving to a phase 3 trial. And this interim step has been added, which we call as a futility study, but perhaps again, trying to determine whether it's even futile to actually go to a phase 3 trial. And then if you actually make it to a, gone through the dose finding study, you've gone through the futility study, then one can actually move to a definitive study, where you're actually comparing sodium chloride, which is 0.9%, and actually comparing it to a combination of sodium chloride and sodium acetate. And whatever that ratio was selected in the dose finding study will actually move to the final phase 3 study. And the primary endpoint is death and disability, or death or disability at 90 days after randomization into this trial. So there's not a lot of information we need to collect here. There's not a very complex set of intervention that will be required. these intravenous fluids can be performed or prepared by local pharmacies, the cost of intervention is very cheap. Making normal saline in a local pharmacy and making a combination of normal saline and sodium acetate is really not a very expensive effort. And collecting 90-day outcomes in all of these patients is effort, but effort is not a significant amount of effort when research staff and research resources are relatively cheap. So I just bring this trial as an example, because at some point one needs to actually take a starting point. It doesn't have to be a trial like this, but obviously there are trials like this that actually have simple interventions, limited amount of data collection, and yet can make a big difference in a large number of patients worldwide as compared to more sophisticated intervention, which even in the United States are only applicable to a much smaller group of patients. So a neurospecific intravenous fluid is perhaps the best therapeutic that can be made widely available. A neurospecific intravenous fluid has applications in traumatic brain injury in addition to stroke. So it actually has a much broader implication than in addition to stroke. Now, many of you may not know the history of normal saline. And normal saline was first introduced in 1830s. And the first place that actually introduced was British India. It was actually introduced for treatment of cholera. And the second time sodium acetate was introduced was again in Pakistan, actually for cholera, again for volume depletion. So the history of these fluids actually is in Indo-Pak. It's not in Europe, it's not in the United States. So perhaps this is an ideal time to take it to the next level of something that it already has its origin in the Indo-Pak region. So how do we actually take these neurological opportunities and overcome these challenges? I think the answer is simple. We've got to start somewhere. It may not be the ideal place, but it has to start somewhere. And we have to learn along the way. And only then we will be able to bridge some of the gaps that we have in terms of knowledge, in terms of actually having research capable centers, in terms of actually creating enough initiative to actually overcome the clinical responsibility. And perhaps we have to work together to find these research funding. We don't need a lot of research funding. Obviously, we need some, but there has to be some local support that will allow us to move forward. And I think that in the end, I still want to highlight the importance of working as a group. I think a small number of people carrying a large baggage is very unlikely to go far, definitely not going to finish the journey. In contrast to a large number of people carrying a small amount of load, which definitely will take us to the finish of the journey, and will perhaps have a reward for everybody when the journey is completed. I'm going to conclude there with these particular statements. I hope that these statements and I guess these observations may be of value as we explore neurological opportunities and overcome some of the challenges that currently face us. Thank you very much.
Recorded slower.
एक second.
Professor Vasai. Thank you, Professor Qureshi, for this very detailed speech, very motivative speech, actually. Is there any question or there is not, at this moment, there is not any question, but if there is still additional question from audience, we can get it.
So any participants that have questions, please post them in the chat.
No. there is not at this moment. We have not question.
We'll just give it a minute and see if anyone has any
Okay.
question.
Okay.
Is Professor Vase connected or he's away? I think Dr. Burhan is not here, but Professor Mustafa is here now.
Okay, fine.
So we'll make him the co-host. And what can happen is Professor Mustafa can have one of the talks that was meant for session 4, which is neurological issues of refugees and migrants.
Yeah.
Professor Mustafa, you have access now. Professor Safner, you can perhaps introduce Professor Mustafa for his talk for session number 4, neurological issues of refugees and migrants.
Sure, with pleasure. Professor Mustafa Al Faris is a professor of neurology at the University of Mohammed, and he's president of Malcolm Foundation Against Neurological Disease. He was past president of WFN Migrant Neurology Specialty Group, and he has enormous efforts on this group. And we had many important activity during his presidency, and he is editor of the book on neurology in migrants and refugees. Please, Professor El Faris, it's a great pleasure to introduce you. Please, my friend.
Thank you, Safner. You hear me?
Yes, we hear you very well.
Thank you very much for the introduction. Thank you for Professor Wasai and the Pakistani colleague. And I am apologize for the technical problem. My talk is about neurology in migrants and refugees. You see my slides? Yes?
Yes. It's
okay.
Perfect.
Okay. Okay. No disclosure. That's the outline. I will start by some generality for the migrants here. Migration has been part of human history, and humans are always in search for better opportunity to improve the quality of their lives. The current international migrant is a reflection of the world resulting from the dynamics generated by changes in political, economic, and cultural structures. It reflects the advent of an interdependent world, stimulating new culture and economic exchange, and contributing to the social reconfiguration of host and departure society. The health of migrants is a global phenomenon that concerns several million people worldwide. Migrants have more health problems than the hosting population. Migrants' health, the health of the migrants have vulnerabilities due to several factors, such as difficulties in early childhood, poor living conditions in the host country, hard and dangerous work, and psychological problems related to the migration process. Migrants are more vulnerable to communicable disease. but also to non-communicable disease such as cardiovascular disease, diabetes mellitus, and obesity. Migrants tend to have more mental illness such as depression, anxiety, and post-traumatic stress, with an increasing risk in asylum seekers and undocumented refugees. Women and children are likely to encounter different health risks during all migrant process and to have human trafficking and sexual exploitation. Identifying and addressing political, racial, and social determinant of health in migrants enable health policymakers to carry out appropriate intervention to improve migrants' health. Now, some words about the neuroepidemiology in migrants. Many of the epidemiological differences between neurology in migrants and ethnic minorities and in Western world are explained by the wide variation in demography, culture, poverty, and genetics of the country of origin of migrants. Adult migrants from low and middle income countries who may have experienced early deprivation in their infancy and childhood are particularly vulnerable to subsequent neurological disorders and may still have a higher susceptibility to neurological and psychiatric illness that are reflective on the socioeconomic environment. However, there is little statistical data available for the incidence and prevalence of different neurological disease among migrant and ethnic minorities. Now, I will present some particularities in neurological pathology and begin by stroke. Stroke, given the high frequency of vascular risk factor in migrants such as hypertension, diabetes, obesity, and smoking, and the rapid acculturation, migrants have a high incidence of stroke. Migrants have often severe stroke at younger age with high mortality and more persistent neurological disability. To reduce the burden of stroke in migrants, specific attention must be paid to the prevention of vascular risk factors, health education, and better lifestyle for first and second generation of migrants. Migrants from sub-Saharan Africa or Asia may have specific causes of stroke that are very rare in Western countries, such as rheumatic heart disease that can cause severe stroke of permanent neurological disability in young adults, mostly women. Migrants with cardiovascular disease or stroke may not have adequate treatment as reported in Bengalese patient in UK with acute myocardial infarction living in UK. In Mexican migrants in the United States, Mexican migrants with acute stroke who seem to be less likely to benefit from treatment for specific treatment with thrombolysis and thrombolectomy. For epilepsy, since the diagnosis of seizure of complex partial epilepsy, seizures, is essentially based on history. If the patient does not speak the language of the host country, and the neurologist does not understand the language of the patient, the diagnosis of epileptic seizure, complex seizure, becomes hazardous and the epilepsy will be underdiagnosed. An approximated and unclear medical history can take temporal seizure for mental disorders, not neurological and epilepsy. Because myoclonus, which is rarely spontaneous, reported by patient, will cause juvenile myoclonic epilepsy to be confused with general epilepsy. Treatment with carbamazepine will increase the number of seizures and aggravate the condition of the patient. Some studies of multiple sclerosis have shown that migration from high-risk area to low-risk area at the beginning of life leads to reduce the risk of MS. Evidence that migration in the opposite direction from low-risk area to high-risk area increases the risk of MS seems less obvious. Several studies have shown that MS is much more severe in migrant populations such as North African migrants in French. They have more motor deficit and ataxia at the beginning of the disease and rapidly reach a progressive phase. The severity of multiple sclerosis in, for example, North African migrants may require the use of second-line treatment early in the course of the disease. Behçet disease is a particular disease for the Mediterranean area and Japan. The prevalence of Behçet disease is higher in native population of Northern and Middle East population. Neurobehçet disease is little known by Western neurologists, and some other neurologists may be in Asia. And this can diagnosis in a migrant that the diagnosis based on clinical, the diagnostic of Behçet disease is based on clinical signs, such as buccal and genital aphasia. You have no biological marker to diagnose Behçet disease. It is important for the neurologist to know that the mesencephalo-diencephaloid lesion of the MRI, the cerebral MRI, are very suggestive for the disease. The delay in the treatment of neurodegeneration can lead to severe motor and cognitive disorders such as dementia. Consanguinity is widely practical in many parts of the world, including Africa and South Asia. Its frequency is about 10% of the global population. The high frequency of consanguinity in some migrant population can lead to high prevalence of hereditary disease, such as neuromuscular disease in Pakistani children living in UK. This is a work from Yorkshire that show that 3 times the Pakistani children have 3 times more muscular disease than English children. The high prevalence on inbreeding in North Africa. They ought to have some ataxia rare in European population. And these ataxias are more frequent in this population. The frequency of a specific gene for Parkinson's disease in a given population may be known in order to correctly diagnose and treat Parkinson's genetic disease. For example, in North Africa population, Parkinson's disease due to the mutation of the LRRQ2 gene is present in more than 30% of the population. These patients are often young and have severe levodopa and lucid dyskinesia. These patients should be preferably treated by dopaminergic agonist and delayed as far as possible the use of L-dopa. Now another problem for the aging migrant. Migrants and ethnic minorities are more susceptible to have cognitive disorders, Alzheimer's disease and vascular dementia and other dementias than the native population. That is due to high frequency of vascular risk factor, poor diet, and low socioeconomic status. Prevalence of dementia is 3 to 4 times higher in migrant and ethnic minorities in USA and in some European countries such as UK. Migrants are usually from non-Western origin, from low and middle income countries, Africa and Asia and Latin America, and are low educated and are not fluent in the language of the host country. And there are few neuropsychological adapted tests to diagnostic cognitive disorders in this population. Dementia in elderly migrants are frequently underdiagnosed and often diagnosed at advanced stage of the disease when the cognitive disorder and the psychiatric disorder disturb the family. Now I will present our book in neurology in migrants and refugees. The Neurology in Migrant and Refugees book is the result of the works and the reflection of the World Neurology Federation Specialty Group on Neurology in Migrant. This group was initiated in 2018 and chaired by Professor Antonio Federico from Siena, Italy, and myself. The group held several meetings in the International Congress of Neurology to raise awareness of the particularities of neurology in migrants to neurologists worldwide. The book edited by Antonio Federico and Wolfgang Grisold, the current president of WFN, and myself, and provides a synthesis of migrant health in relation to the WHO agenda and an up-to-date overview on neurological disease among migrants and ethnic minorities. This book will be useful to neurologists worldwide who can find appropriate knowledge for diagnosis and treatment when facing migrants with neurological disorders. These neurological disorders are sometimes difficult to assess in the absence of clinical experience with this population. The book will also certainly be very useful for international organizations, policymakers, and non-governmental organizations working in the field of health and migration. We hope that the book will find an indispensable place in neurological department libraries and will constitute a basic textbook for teaching neurology, taking into account ethnicity, culture, geography, and health inequalities in the care of neurological disorders. Here the table of content of the book. We have a foreword from Professor William Carroll, the past president of WFN, and two special articles by a neurological historian and practitioner, by the Professor Dr. Pietro Bartoli from Italy, that he have a very interesting experience in Lampedusa with migrants from Africa, and an article in the relation between migration and poetry par Dr. Giovanni Bracco. The second part of the book is dealing with historical, geographical, and health problem of migration. We have two really known historians of migration, Professor Patrick Manning from the University of Pennsylvania, and Professor Dirk Horder. Dr. Hisham Shafiq wrote an article in the history of migration, particularly in North Africa, especially in Morocco. We have a very interesting article dealing with the relation with migration, environmental and clinical change with Jacques Raïs and French colleagues. An article in Child with Migration, the problem with children with migration and school achievement. And I write an article on the barrier to health for migrants and refugees. The other article are contribution of migration and refugees from Antonio Federico. How can host country provide neurological care to migration? Professor Shakir Rad. And article in neuroinfection disease in migrant, and an article in the variant great problem with the COVID and neurological complication of the infection of COVID-19 among ethnic minorities and migrants in North America and in UK. And an interesting article from Serif Noor Uzturk, cerebral vascular risk factor in migrants and refugees, stroke by Professor Belhassan, multiple sclerosis by Riyad Guider, neuromyelitic optica spectrum by Bill Carroll, and a particular article in the neurological manifestation of basic disease related to migration and ethnicity. An article from Gera Kruja from Albania in headache in migrants. Epilepsy with a group of the SA and very known specialist Selim Ben Badis, and article in movement disorders and in dementia and cognitive disorder with the particularity of the assessment of this cognitive disorders in migrant. To the article in the psychiatry, anxiety and depression and somatization, and an interesting article from Wolfgang Grisold in palliative care in migrants. And the last article in the relation in the health migration, the Sustainable Development Goals, and the COVID pandemic. Here the cover of the book. It was published in November 17. We have 27 articles and 35 authors and 12 nationalities, and the book have very successful in the downloads with 2,500 downloads until this 10 June. I just recover also. I hope that some neurologists from the region, especially in Asia, will have this book and discuss the continents. And thank you very much for your attention.
Can I ask a question? Dr. Sharaf Noor, can I ask a question to Mustafa?
Please.
Yeah, Mustafa, I think you have done a great job. This is probably very good book. I am a part of this book and I have gone through the book. This book is now available across all over the world. So I think this is a very interesting information. And maybe this should be updated after a few years, but you have done a great job related to this topic.
Thank you, Professor Wasai.
Thank you, Professor El-Alawi. It was great pleasure and honor to be part of this great effort. You were very important for the improving of this group. Thanks again for your contributions.
Dr. Sharaf Noor, could you give your concluding remarks for this session as a chair?
We don't have any other speakers?
Yeah, the next speakers, we have to break and then we will do the next session after lunch break.
Okay, thank you, with pleasure. Again, to be here was great pleasure, great honor for me with you for this very important symposium, congress actually. And I would like to thank again Professor Wasai and Professor all other professors who gave a very valuable speeches. And I would like to thank audience for their patience and interest actually. This session was very important and evaluated many subjects on the region and especially for strategies and for future. So we need to make more stronger collaborations for these problems, for these global and regional problems. I hope we can meet in future congresses, future conferences to make efficient solutions and suggestions to change the world actually. Thank you very much.
Thank you, Dr. Sharaf Noor, and thank you, Mustafa, and thank you all the participants. This was a great session. And we break for lunch because the participants are here since 9 a.m. So it's been 5 hours, pretty much non-stop lectures. So it's a 30-minute break. We will get back at 2:30 p.m. Pakistan time. And that's going to be our last session, which is session 5. There are 2 talks from this session, which we'll be trying to accommodate in the next session. One is related to multiple sclerosis by Dr. Burhan Chaudhary. He's based in US. And the other one is on neurorehabilitation in OIC countries. So the rest of the 4 talks and these 2 talks will be trying to accommodate in the next section. So next session starts at 2:30 p.m. and we see you again at 2:30 p.m. Thank you very much. And if you have questions or comments, please share. We'll be able to share those comments to the speakers and we'll be able to respond back to you soon. Hasib, you have any announcements?
Thank you, Professor Vase. To all the participants, those that have questions that were not answered, I've shared my email in the chat. Just email them to me, the question and the relevant speaker, and we'll email them out. And they can all mark their attendance as well by sending me an email. We'll resume back at 2:30 p.m. Pakistan Standard Time, which is roughly half an hour to begin the final session for the conference. Okay. we'll formally start the session 5 of our conference, which is on research advances in neurodegenerative diseases. For our chair, we have Professor Dr. Daraksha Halim, who is a meritorious professor in neuroscience at ICCBS. She's one of the top scientists of Pakistan and has been identified as top 2% scientist worldwide by Stanford University. She did PhD from Institute of Neurology, London University, and then is engaged in teaching and research in University of Karachi. She is fellow of Pakistan Academy of Sciences and has been holding administrative positions in the university as Dean, Faculty of Science. For our co-chair, we have Professor Dr. Farzana Shaheen. Her research interests include phytochemical studies on medicinal plants, synthesis of anti-epileptic compounds, peptides, peptidomitics, and cyclic peptides. She has over 90 research publications in international journals, and she is a recipient of UNESCO L'Oreal Fellowship, Fulbright Fellowship, OWST Award for Young Women Scientists from Developing World. So I would invite the chair and co-chair to moderate this session. And our first talk will begin with Professor Dr. Daraksha Halim.
Thank you for the kind introduction. The topic, actually, first of all, I would like to thank the organizing committee for giving me a chance to present this talk. The talk I'm going to present is central serotonin in chronic pain and depression. Chronic pain conditions such as osteoarthritis and low back pain are highly prevalent, and often the two diseases coexist. In fact, sometimes the coexistence and individually, the treatment outcome of these diseases is very unsatisfactory. And in today's talk, I'm going to tell you the 5HT mediated shared mechanism that is involved in the pathogenesis as well as treatment of this comorbidity. So let's start here. Chronic pain and depression, they both are highly prevalent, and there is a bidirectional relationship between these two. The treatment for these two at present is separate. As you know, acetaminophen, non-steroidal anti-inflammatory drugs and opioids are used for treatment of chronic pain, while SSRIs are used for the treatment of depression. But the treatment outcome for both of these diseases is very unsatisfactory. Chronic pain, such as low back pain, osteoarthritis, are prominent causes of disability worldwide. Prevalence of chronic pain across countries ranges from 18 to 43% and increases with increasing age. Females have a higher prevalence at all ages. This slide shows you the prevalence in different age groups, and in every age group, more female than males are affected. Depression. Depression is one of the most prevalent forms of psychiatric illness, which affects all communities. More in women than men. This disease is also more in women. Prevalence range from 10 to 30% across countries, depending upon socio-cultural and economic status. For appropriate diagnosis, 5 of the following symptoms must be present continuously for a minimum of 2 weeks. And these are 9 symptoms, which I think most of you know. Prevalence of depression in different age group. Here also you can see that prevalence is highest in this age group, 35 to 40, and more female than males are affected. The blue one is for males, pink one for females, and this is total global prevalence. A meta-analysis shows that 65% of the patients with clinical symptoms of depression have chronic pain, and 5 to 85% chronic pain patients, depending upon the severity of pain, have depression. Moderate to severe pain highly impairs productivity, and when it is associated with depression, the condition becomes worse and resistant to treatment. An understanding of both the mechanism involved in comorbidity, shared mechanism, therefore highly essential. Identifying a shared mechanism for treating both conditions, and particularly in comorbidity, is important for improving treatment of these chronic disabling diseases. In this regard, the role of serotonin is becoming increasingly known and is the focus of this present talk. The slides I'll present here, most of these have been taken from this article, which is my article. This is published in Current Neuropharmacology, targeting serotonin 1A receptors for treating chronic pain and depression. Cell bodies of serotonin containing neurons, they are present in the midbrain raphe and in the hindbrain. In the midbrain raphe as dorsal raphe and median raphe, the neurons from these cell bodies extend to all brain regions, including the regions which are involved in emotional control, means depression. And the raphe magnus, which is present in the spinal cord, it gives us off exons to the spinal cord. The two raphe, they are also interconnected. In the spinal cord, the dorsal horn of the spinal cord, this receives serotonergic innervation. This is actually how serotonin is synthesized in neurons. Tryptophan is the precursor. Tryptophan taken up from the blood into the serotonergic neuron is converted into 5-HTP in presence of enzyme tryptophan hydroxylase, and 5-HTP is converted into 5-HT in presence of L-aromatic amino acid decarboxylase. This enzyme tryptophan hydroxylase is present only in the serotonergic neurons. That's why tryptophan can be taken up by different neurons, different cells, but only 5-HTP synthesized in serotonergic neurons. 5-HT synthesized can be stored in the synaptic vesicles, and it is released on arrival of nerve impulse into the synaptic cleft. And 5-HT, which is not stored in the synaptic vesicles, or that has been taken up by high affinity reuptake system, that both of them can be degraded by monoamine oxidase, which is present on the outer wall of the mitochondria. There are a number of 5-HT receptor types and subtypes. At least 15 types and subtypes are known, and they are present on the postsynaptic sites as well as on the presynaptic side. Some of these are present on the presynaptic sites. For example, 5-HT1B on the nerve terminal and 5-HT1A on the cell bodies and dendrites. Evidence suggests important role of 5-HT1A receptor in depression as well as in pain perception. 5-HT1A receptors localization. As a autoreceptors, 5-HT1A receptors are present on the cell body and dendrites, while as a heteroreceptors, they are present on the nerve terminal end on other neurons. So heteroreceptor regulate functioning of other neurons, while autoreceptors, they regulate functioning of the same neuron. The activation of 5-HT1A autoreceptors will decrease synthesis and release of 5-HT by a feedback mechanism. This is the 5-HT autoreceptors in the raphe magnus, which the neuron from here extend to the dorsal horn of the spinal cord. And here 5-HT1A heteroreceptors are present on the first order neuron, which brings information, or you can say pain sensation, to the spinal cord. 5-HT1A receptors, in fact, they are a type of, you can say, inhibitory receptors. because they are G protein coupled receptors, and are associated with the negatively with the adenylate cyclase. So there will be a decrease in the formation of the phosphorylated proteins, and activation will also close calcium ion channels, will open potassium ion channels, resulting in the hyperpolarization. This is how the pain sensation is brought to the brain. First order neuron, sensory neuron, which comes to the spinal cord. Over here, it releases pain neurotransmitters, which is sensed by the second order neuron, and second order neuron goes to the brain, where third order neuron gives information to various brain regions, cortical and all that, amygdala, etc., where it is modified. The response actually is modified according to the previous emotions and the current emotions. A role of serotonin in the modulation of pain emerged because stimulation produced antinociception from the raphe was blocked by serotonin antagonist. This is raphe. When raphe was stimulated, 5-HT was released here. Actually, 5-HT is released here, and then it acts via heteroreceptors to inhibit the pain. When 5-HT1A antagonist is administered, it will bind with these receptors, and 5-HT, which is released here, will not be able to function. So a role of 5-HT1A receptors in perception of pain was therefore suggested, and it was suggested that activation of heteroreceptors can reduce pain. 8-hydroxyDPAT is a 5-HT1A agonist, and when it was administered intrathecally into the spinal cord, it reduced pain perception. But when it was administered into the raphe, it increased pain perception. So this increased pain perception was suggested to be due to the activation of autoreceptors. When these autoreceptors are activated, 5-HT relief to the heteroreceptors is reduced, and this produces pain perception. This increases pain perception. When 5-HT was injected systemically or administered systemically, 8-hydroxyDPAT was administered systemically. Low doses were able to enhance nociception pain, and high doses were able to reduce it, because low doses activated 5-HT1A autoreceptors only, and this reduced 5-HT availability at the heteroreceptors. But high doses, they acted via autoreceptors as well as heteroreceptors, and the effect of autoreceptor activation was counteracted by heteroreceptor activation. And again, high doses were able to further activate heteroreceptors. This is how serotonin can reduce pain perception in the dorsal horn of the spinal cord. This is afferent sensory neuron, or you can say first order neuron, which releases substance P and glutamate into the synapse. And they bind with their individual receptors to produce depolarization potential, which is carried to the brain via second order neuron. 5-HT, when released here, it will act via 5-HT1A heteroreceptors to close calcium ion channels and open potassium ion channels. And this will result in the inhibition of the release of substance P or glutamate both. Therefore, the intensity of depolarization potential over here is reduced. Buspirone, an antidepressant and anxiolytic compound, a partial agonist at 5-HT1A heteroreceptor, and it's a full agonist at 5-HT autoreceptors. So we selected this drug to see what happens when this is administered on pain perception. The effect was monitored on pain perception, and this is the published work on that. Dose-related effects of buspirone on pain. Pain perception was monitored on hot plate. You can see that low doses they increased pain perception, and high doses, they decreased it. This is the latency to lick. Latency to lick was enhanced in presence of high doses. Again, the number of licks were enhanced at low doses, and higher doses it was decreased, suggesting that low doses are enhancing sensitivity to pain, and higher doses, they are reducing it. So this effect was explained in this way in the same paper. Low doses of buspirone stimulate 5-HT autoreceptors because they're full agonist at autoreceptors and partial agonist at heteroreceptors. So low doses activate these, and therefore less 5-HT is released here, and more pain is produced. While high doses, they activate this and that, both receptors, and the smaller release of 5-HT due to activation of autoreceptors is counteracted by activation of heteroreceptors, and together with this, the greater activation of these heteroreceptors will reduce pain. In addition, we found that repeated administration of buspirone produces hypoalgesia. Why? Because these autoreceptors, they are desensitized and feedback control is reduced. That's why the more 5-HT will be released here, even under basal condition. This is the work published. Serotonin and 5-HT1A receptors in depression. The role of serotonin in depression was suggested in 1965 because reserpine, a drug which disrupts the storage of the monoamines, this was able to produce depression-like behavior, while iproniazid, which is actually a monoamine oxidase inhibitor, produced euphoria. How these drugs produced depression or euphoria? Actually, reserpine binds with the vesicular transporters, and therefore monoamines, they are not stored here in the vesicles. Not stored in the vesicles, they are acted upon by monoamine oxidase and are degraded, and less monoamines are released over here to produce depression. While in presence of a monoamine oxidase inhibitor, although reserpine binds here, 5-HT is less stored in the synaptic vesicles, but it is also not degraded by monoamine oxidase, and it's present in the cytoplasm of the neuron. And that's why the in presence of iproniazid or monoamine oxidase inhibitor, more 5-HT will be released not from the vesicular pool, but from the cytoplasmic pool. In 1987, fluoxetine became the first US FDA approved SSRIA, and a number of these are now known. This slide shows you how SSRIs they act. They bind with the high affinity reuptake site, and 5-HT is now not stored here. It's actually it is less taken up by the neuron, and therefore synaptic concentration of 5-HT increases to produce antidepressant effect via heteroreceptors. But a thing which has been seen that long-term administration is required. Although SSRIs, they increase synaptic concentration of 5-HT immediately after they are administered, but antidepressant effect is produced after long-term administration. This slide shows you why antidepressant effect is produced after long-term administration. In fact, extracellular 5-HT increases when SSRIs are administered, but the increase is not only in the synapse, but also in the cell body region. So there is activation of autoreceptors too, which actually counteracts the effect of high affinity reuptake inhibition, and less 5-HT is available here. to produce merely no effect. But when the drug is administered repeatedly, these autoreceptors are desensitized, are down-regulated, and the effect due to autoreceptor activation is reduced. More 5-HT is available here now to act via heteroreceptors to produce antidepressant effect. In terms of how these actually heteroreceptor activation produces antidepressant effect, these heteroreceptors are present on the GABA neuron. And heteroreceptors, you know, they are inhibitory. Autoreceptors and heteroreceptors both are inhibitory. So activation of these receptors decreases 5-HT release at glutamate neuron. So more glutamate is released to dopamine neurons, and the activity of dopaminergic neurons increases. Dopamine, you know, is said to be a neurotransmitter which produces happiness. So we can say overlapping pharmacotherapy of pain and depression. These studies are therefore relevant that the activation of 5-HT1A heteroreceptors in the dorsal horn of the spinal cord and limbic regions produces respectively a pain-killing and antidepressant effect. But systemically administered 5-HT1A agonists activate both receptors. The effect of postsynaptic activation is counteracted by presynaptic activation. So biased activation of 5-HT1A heteroreceptors may be a useful strategy for treating chronic pain, depression, as well as their comorbid condition. So here, everything is shown. The autoreceptors, which are present in the mid and hindbrain, and these are the autoreceptors present in the raphe magnus. The serotonergic mechanism in pain, serotonergic mechanism in emotional control. Upregulation of 5-HT1A receptors is involved in the comorbidity. So biased activation of 5-HT1A heteroreceptors may be effective in treating depression, pain, and the comorbid condition of the two diseases. So nowadays, pharmacological studies which are being addressed are that SSRIs with 5-HT1A autoreceptor antagonist activity are being synthesized. They can produce a biased activation of 5-HT1A heteroreceptors. Another strategy is siRNA, inhibitory RNA mediated selective suppression of 5-HT1A autoreceptors. Also, it has been seen that 5-HT1A autoreceptors, they both are coupled with G protein, autoreceptors and heteroreceptors, but these G proteins are of different type. This is G alpha I3 and this is G alpha naught. So it means drugs can be prepared which selectively inhibit these receptors, autoreceptors, and activate autoreceptors, producing a biased activation of heteroreceptors. So at the end, I would like to acknowledge the grant support from Higher Education Commission, and the work which I presented here was performed by Dr. Shazia Nawaz and Dr. Tarvinder Salman. So thank you very much, everybody. The session is open to questions, please.
Any questions in chat box, Hasib?
Yes, sir, I'm looking. No questions so far.
I hope people are listening. So
I guess your lecture was very clear and crisp and self-explanatory.
Thank you very much. Thank you very much. I'm going to introduce you the second speaker of the session, Professor Dr. Farzana Shaheen. Her research interests include phytochemical studies on medicinal plants, synthesis of anti-epileptic compounds, peptides, peptidomimetics, and cyclic peptides. Over 90 research publications in international journals she has. She is recipient of UNESCO L'Oreal Fellowship, Fulbright Fellowship, and OWSD Award for Young Women Scientists from Developing World. So, Dr. Farzana Shaheen, please.
Madam. Assalamu alaikum. First of all, I would like to thank organizing committee for providing me this opportunity to present our research on preclinical development of new drug candidates that prevent brain from epilepsy and stroke. My talk has three parts. The first part is on the discovery of potent anticonvulsant nature products, isoxazolone, as active principle of folk medicinal plant epimidanidatum. And these compounds were identified as potent sodium channel blockers and as neuromodulating agents. We have now 2 US patents on this discovery. The second part of my talk is on the discovery, on the development of Z acid as the most potent analog of isoxazolone in stable and single isomeric Z configuration. Summer stability, toxicity, and biomarker analysis of Z acid was also completed, and nasal formulation based on Z acid showed 100% control on PTZ-induced epileptic form activity. Nasal formulation also protected rats from 2 vessel occlusion ischemic injury in vivo stroke model. The third part of my talk is on preclinical research on Z acid nasal formulation, acute chronic toxicity in mice, rats, rabbit, and primates. Proved safety of Z acid nasal formulation, genotoxicity, hemolysis, cellular level toxicity data, and along with other data also proved its safety. Then we also completed pharmacokinetic studies of the nasal formulation in rats, rabbit, and primates. We have filed patents and they are now published in Pakistan, USA, China, and intellectual property organization website. Ethical approval is already obtained from Institutional Ethical Committee and National Biotech Committee for phase 1 clinical trials. And currently we have application filed in draft for grant of for approval of phase 1 clinical trials. So these are our US patents and patents in China and in Europe. Epilepsy is a chronic neurological disease that affects people of all ages. Around 50 to 60 million people have epilepsy, and 80% of epileptic patients reside in developing countries. Approximately 90% of epileptic patients in developing countries are not receiving appropriate treatment. This disease is more common in young children and older people, and the currently available anti-epileptic drugs are associated with adverse side effects, lack of efficacy, and lower IQ, and several other side effects. The cost to develop one new drug from R&D to marketing approval is about $2.6 billion in an average period of 9 years. Due to high cost involved, there is no innovation in anti-epileptic drugs. So the new drugs which are now available in market, they are second and third generation analogs of anti-epileptic drugs, and these new drugs are costly compared to older drugs in Pakistan. Epidiolex is a newly approved anti-epileptic drug, which it's approved just recently by FDA for the treatment of resistant epilepsy. But its cost is very high for one patient. The cost is about $32,500 per year. It's not available in Pakistan. Most people with epilepsy take anti-seizure medicine on a regular basis to prevent seizures. Some patients experience increased seizure activity, that is called seizure clusters or acute repetitive seizures, which require rescue medicine that can be immediately and easily administered to control seizures. Intranasal administration offers a great potential for direct nose to brain drug delivery to control seizures in an emergency situation. So rescue medicines which are available are mostly from benzodiazepine class of compound, diazepam, clonazepam, and midazolam. These medications are administered by a buccal, rectal, and nasal routes and get into the bloodstream rapidly to work to control the seizure quickly. So FDA has approved them for the treatment of cluster seizures, and these are the structures of these rescue medicines. Anti-epileptic drug midazolam nasal spray is the first FDA-approved nasal medicine in 2019 for treating cluster seizures, but its cost is very high. It's about $584 for its life to spray. And similarly, diazepam-based nasal spray is also very expensive. These rescue medicines, they are effective only in short-term treatment of all seizures, and they are used in emergency situation only. And tolerance develops in most of the cases within few weeks, and their effectiveness is also reduces over the period of time, while their side effect increases since the dosage has to be increased to maintain the same degree of effectiveness. So for screening of anti-epileptic natural products, two biases are used, two in vivo biases are used. One is maximal electroshock test, and the second is chemical induced test. So in maximal electroshock test, drugs that are effective in this test, MES test, they also inhibit the sustained repetitive firing of neurons through an action at voltage sensitive sodium channels, such as phenytoin, and the behavioral and electrographic seizures produced in this model are consistent with human disorder. While in chemical induced in vivo models, that is carried out by phenterline, tetrazole, pilocarpine, and bifenthrin, they can also induce seizure-like activity in animals, and drugs which are effective in PTZ test, they have different mechanism of action. So now we'll present details of some of the details of our research. We discovered potent anti-epileptic natural products from medicinal plant Delphinium danidatum, and this project was initiated by Professor Dr. Taur Rahman and Professor Dr. Mohammad Iqbal Chaudhry. First of all, a nationwide ethnobotanic survey was conducted, and several plants were identified which are used in traditional system for treatment of epilepsy. Among them, Delphinium danidatum is traditionally used for the treatment of epilepsy and also for migraine, paralysis, and antidote for snake bite. In Unani system of medicine, Jadwar is considered as antipyretic, antiseptic, anti-inflammatory, anti-convulsant, antidote, cardiotonic, and tonic for the brain. So we use bias-guided isolation strategies from this work on roots of this plant. Ethanolic extract was prepared, which was for the partition between hexane and chloroform fraction at different pH, and then finally we obtained non-alkaloidal extract that was free from all alkaloidal content of this plant. Since this alkaloidal content, the toxicity of these plants is due to the presence of dietropenoid and non-dietropenoid alkaloids of this plant, so we were able to remove this alkaloidal part from the aqueous extract that was found less toxic, and further it was found that anticonvulsant constituents were predominantly present in this least toxic aqueous extract. We further studied the aqueous extract activity in vivo and in vitro model. In vitro studies, aqueous extract strongly inhibited sustained repetitive firing of hippocampal neurons at the dose of 0.6 milligram per kg. And this effect was similar to standard anti-epileptic drug, phenytoin, which also inhibited the sustained repetitive firing of neurons at the dose of, in dose-dependent manner. So aqueous extract also inhibited the PTZ-induced epileptic form activity in hippocampal neurons in cultured cells, and also suppressed the bicapillin-induced epileptic form activity. So further bias-guided fractionation of aqueous extract resulted in the isolation of an oily material, which was found to be 10 times more active than the aqueous extract in vivo and in vitro studies. Oily material obtained from the aqueous extract strongly inhibited the SRF on neurons at the dose of 0.06 milligram per ml, and then it was found to have it protected 100% animals from hining tonic extension phase in maximum electroshock test. And in PTZ test also it protected animals 100% from the seizures induced by PTZ. Bacillin-induced seizures were also inhibited by this oily material, and this also indicated the presence of compounds in this fraction which are capable of having interaction with the GABA receptor. So PTZ-induced epileptiform and bacillin-induced epileptiform activity was also inhibited by this oily fraction. Further purification of this oily material resulted in the isolation of isomeric mixture of isoxazoline. This is the structure of isoxazoline, and they were discovered as potent anti-epileptic nature products from medicinal plant based on folk knowledge. They were found more potent than other voltage-gated sodium channel blockers and anti-epileptic drugs. And they were also identified as neuromodulating agent and has potential to treat other neurological disorders. So this is a summary of our discovery. We've also conducted total synthesis of this natural product, and synthesis also confirmed the structure and biological activity of isoxazoline. We also determined the anti-conversion activity of all analogs of isoxazoline, and we were able to develop a method through which we can obtain this acid analog of isoxazoline in Z configuration in bulk amount. So then we studied anti-epileptic acid or Z acid analog of isoxazoline, and they were discovered as potent analog of isoxazoline. So then we completed the preclinical development of Z acid. Z acid obtained from different production lots showed reproducibility of activity in acute and killing model of epilepsy. It was found configurationally stable at different temperature, and stability and purity was established by NMR and GCMS and VCC profile. So then we checked its activity in acute anti-conversion activity testing in mice. Z acid prevented the seizures in PTZ-induced seizure model at the dose of 300 mg per kg. And in anti-epileptogenic activity in killing model, different doses were used, but a dose of 250 and 300 mg per kg has shown refined anti-epileptic activity. The anti-seizure activity of Z acid was also identified through EEG recording. The seizures were induced by administration of PTZ, and seizures were monitored in the form of spikes discharged per minute during these 3 sessions of EEG recording. Baseline recording of PTZ injection and recording of drug injection. The spike discharge was significantly reduced by diazepam and Z acid. Diazepam is standard drug, and Z acid administration in PTZ and diazepam and PTZ Z acid groups respectively as compared to PTZ injected animals. Then we studied the toxicity of Z acid in mice, and different doses were used, and we found that Z acid treated animals at different doses did not was having no acute neurotoxic effects when animals were monitored for 24 to 48 hours. Then we performed subsonic toxicity studies in mice, which was continued for 3 months with a daily dosing of 300 mg per kg. All animals survived until the end of the experiments, and blood samples of processed for LFT profile and for all other biochemical parameters. Gross anatomy of organs after treatment showed no signs of toxicity. These are the results of toxicity of Z acid in mice, which was done for 3 months. All biochemical parameters were found in normal range. Then we developed Z acid nasal formulation, and we checked its biological effect. First of all, we studied the effect of nasal formulation based on Z acid in PTZ-induced seizures as recorded through EEG. And we found that 100% control of Z acid nasal formulation was observed on PTZ-induced epileptiform activity in rats, and it was further found that it was 6 times more effective than when administered through nasal route. Then we studied the effect of Z acid nasal formulation in stroke model. Stroke is represented as an acute attack of partial dysfunction of brain and spinal cord or retina. Stroke is classified as ischemic or hemorrhagic, while 85% cases are ischemic, while remaining 15% are hemorrhagic. Stroke is debilitating illness, rendering thousands disabled and leading a significant proportion of people to death worldwide. In industrialized countries, stroke is considered as second leading cause of death and a major cause of acquired adult disability. There is no effective treatment available for stroke. Thrombolysis is currently the only successful treatment, but it also has some limitations. So we observed that Z acid is non-toxic to all primary cell cultures of rat cortical cells, but it also differentiated the cortical neurons. So then we studied the effect. We developed a model, two vessel occlusion model of ischemic stroke. And after induction of this model, we daily dosing of Z-acid formulation was carried out for 7 days, and then we studied the effect of on the treatment. Z-acid significantly protected rats from two vessel occlusion ischemic injury, and we did not find any sign of infarction in treated sham control and control growth. And Z-acid was found useful for the prevention and treatment of ischemic injury and other neurodegenerative diseases. So immunohistochemistry was performed after 7 days of 7 days post-stroke, and we observed that markers like NOTCH1 and neurogenin, they were expressed in Z-acid treated animals. Then we further continued the toxicity studies of Z-acid nasal formulation in mice, rats, rabbits by using nasal route of administration, and repeated dose toxicity of Z-acid nasal formulation was carried out for 3 months and then for 6 months in rats, and the serum samples were processed, and we further found that all biochemical parameters were found in normal range. And test animals showed normal pigmented nostrils like control animal. No sign of redness were observed after 6 months of administration. And then we also studied single dose toxicity of formulation in intranasal experiment in rabbits. We did not see any toxicity here also. We also established the safety of Z-acid nasal formulation used in pregnancy, since antiepileptic drugs are reported to have cytotoxicity or genotoxicity in embryonic fetus cells and have DNA damaging effect. And antiepileptic drug use in pregnancy is associated with increased risk of spontaneous abortion and causes serious harm and teratogenic effects on the fetus. We studied the antiepileptic drug product Z-acid nasal formulation. We found that it has no teratogenic effect on newly born pups, and it showed no toxic effect on female reproductive system. Genotoxicity of Z-acid was also studied in micronucleic acid, and we found no genotoxic effect of Z-acid. And flow cytometry analysis also established that Z-acid has no genotoxicity, and we use a dose 300 milligrams per kg in this experiment. So from these studies, it was established that Z-acid is a non-carcinogenic, non-mutagenic, and non-teratogenic, and genotoxicity and in vitro and in vivo toxicological studies of Z-acid nasal formulation in mice, rats, rabbits, and primate models proved its safety in animals. Then we conducted this pharmacokinetic of Z-acid, and in monkeys we used 3 different doses, and we found that plasma half-life through nasal route of administration was found to be 30 to 40 minutes. In rabbits, we were able to see comparative pharmacokinetic data of Z-acid after IP and nasal administration, and it was found that Z-acid in the IP administration, Z-acid appeared in plasma peak concentration, was achieved within 15 minutes, and it persisted in the plasma for more than 3 hours, while in intranasal experiment, it appeared within 15 minutes and it disappeared from plasma in 2 hours. And in rats, in experiments with rats, we observed that through IP administration of Z-acid, Z-acid rapidly appeared in plasma, and the peak concentration was achieved within 5 minutes in plasma, and it disappeared within 2 to 2.5 hours. While in brain samples, Z-acid appeared within 15 minutes, and then it disappeared from the brain within 1 hour. While in intranasal experiments, Z-acid rapidly appeared in the plasma concentration, and peak concentration was achieved within 50 minutes, and it disappeared in more than 3 hours. And the Z-acid rapidly in the brain samples, that it appeared peak concentration was achieved within 5 minutes, and it then disappeared from the brain within 2 hours. So from these studies, we discovered a new class of antiepileptic drug candidates. There is some data for new analog of Z-acid also, so we have these 3 compounds which represent new class of anti-epileptic drug candidates, and they were identified as potent neuromodulating agents, and it can be used to treat CNS disorders including stroke, is more efficacy and safety than existing drugs. And we have filed patent in Pakistan, USA, China, and European countries through EPO. We also applied for phase 1 clinical trials, and application is now filed to draft for phase 1 clinical trials. So in the end, I would like to acknowledge all in Professor Dr. Rahman, Professor Dr. Iqbal Chaudhary, and all inventors, Professor Dr. Ishbana Sindhi, Dr. Zahra Fatur, and all students who have worked on the synthesis and biological studies of these compound and drug development. And I would like to acknowledge the funding received from Higher Education Commission, especially for the funds received from Technology Development Funds from AGC. Thank you very much. Question?
Sorry. Huh? I have one question.
Yes, please.
You have to do the agreement between SAL and between ICCPS. Did that agreement has been signed or not?
Yes, it's now already discussed, and we are going to sign it very soon.
No, it's 6 months before it was not signed. 3 months before it was not signed. Still, it is not signed. The status is there.
Actually, it's not so simple because we have already completed the drug development stages and did so many things. So there were so many things which have to be finalized before we finalize agreement with any company. So we have done it, and it's now going to be final very soon, inshallah.
Dr. Fazana, do you recommend that I should come for 2 days in Karachi for signing of this agreement? Which is the problem you are facing, or any difficulty at the part of SAL? Because
difficulty, it's already been discussed with the sir. There's no issue at all now.
When till today it is not signed, so nothing has been done, because this is, this is 1 year before project, 6 months before project, 3 months before project, still it is not signed. When I went to last time in Karachi, I met with you, Dr. Raza, Professor Raza Shah. He offered you that, can I help you and go with you and have a meeting with them, with the sir? It should be done. This is no more issue. That's
well, sir, we have 134 participants in this session, so maybe we should limit our discussion to topic, because this is kind of a private
Dr.
talk.
Fazana, I will come inshallah Karachi in this month. Thank you.
Thank you, doctor.
The question answer is the Z acid. Professor Farzana, there's just one question in the chat, if you can answer. Is the Z acid is used in treatment of all types of seizures and epilepsies?
Actually, we have seen that it's effective in PTZ-induced seizures, and in PTZ-induced seizures are not all kind of, that does not include all kind of seizures, because some seizures which are, because we have not studied it in humans, we have not yet studied it, so we cannot say anything for sure.
Right.
It has actually controlled the seizures induced in which were induced in the PTZ test.
Thank you, ma'am. I think that was the only question in the chat.
So our next speaker is Professor Dr. Shabana Usman Simji. Dr. Simji is a professor of pharmacology at HEJ Research Institute of Chemistry, ICCBS. Her current research focus is in the area of neurological disorders, including Alzheimer's disease, epilepsy, stroke, and CNS tumors. She shares international US patent with her collaborators. Dr. Simji has published several papers in peer-reviewed international journals. She is also an editorial board member of 3 international peer-reviewed journals. Dr. Cindy, please.
I'm pleased to be here on this platform to share part of the research data from our work in the field of the neurogenesis. I'm particularly interested in this field because as a neuropharmacologist myself, I believe that it is one of the way of giving a hope to the patients who are suffering from the devastating and debilitating neurological and neurodegenerative diseases. Okay. As we all know that both the acute and the chronic neurodegenerative diseases, they are the most prevalent type of the neurological disorders, which in the human, which affects almost around millions of individuals worldwide. And despite the advancement in this field of neuroscience, still the people who are suffering from these diseases, they are waiting to have an appropriate treatment which can help them out to fight with these neurodegenerations going on in various diseases. For example, like we can take the example of Alzheimer's disease, Parkinson's disease, as well as the stroke or the conditions which are associated with the strokes as well. Now, before I go into the nitty-gritty of the results that we have gathered while studying the neurogenesis, I'm just very quickly going to give you a brief background of what neurogenesis is and how important role it plays in fighting back with the neurological or neurodegenerative generations going on in different disorders in the human. Basically, neurogenesis is a phenomena that refers to the generations of the new neurons, which are functional as well, from the precursor cells which are present in the brain. And these precursor cells are referred as the neural progenitor cells or neural stem cells. There are several complex, it includes several complex processes, including proliferation, which leads into the differentiation and fate determinations of the neural stem cells or progenitor cells, and the maturation, migration, survival, and functional integration of the neurons are also the different stages of the neurogenesis. There's a big question that does neurogenesis occur in the human adult brain or not? Back in like 3 to 4 decades back, it was a common belief that neurogenesis in the adult brain is not possible and it is only restricted to the embryonic stage. However, now it has been widely studied even in the adult human brain, and it is believed that now the new neurons can be generated in the adult brain as well. And with the, you can see over here in the slide, a brief history of neurogenesis. And you can see that although it has been shown in 1950s that markers of the new cells are present in the adult human brain as well. But it took around more than 30 years to take it as a documented belief that now the neurons, functional neurons, can be generated in the adult human and which can participate in rectifying the neurodegenerations associated with the different neurological disorders. So at this stage, a question arises that what are there specific regions in the brain which participate actively in the process of neurogenesis, or does it occur discretely in the whole brain? To answer this question, basically, the neurogenesis is very active phenomena in two of the brain regions, i.e. subgranular zone of the hippocampus, as well as the subventricular zone, which is found along the wall of the lateral ventricle. And these are the two very active region of the adult brain where neural precursor cells are abundant. And with the passage of the time, when the need arises, for example, in case of any trauma or injury, if the needs arise, then these precursor cells, they are destined for the proliferation and differentiation into the different lineage of the nerve cells, and then they integrate in the specific region which are undergoing the degeneration. There are various regulators of the adult neurogenesis in the body. Some of them are endogenous and some of them are exogenous. Anyway, the regulation of this neurogenesis are also affected by the various environmental factors, including the physical activity, and there are certain neurotransmitters and neurotrophic growth factors which are well documented to increase the neurogenesis, and especially in the hippocampus, which is involved in the development of the learning and memory as well. Whereas there are certain negative regulators such as stress, aging, inflammation, and trauma, inflammation associated with the trauma, they are documented as the negative regulator of the neurogenesis. So basically in the adult neurogenesis, we have the positive regulators and the negative regulators, which tends to regulate the process of neurogenesis in adult human brain. As far as the function of the adult neurogenesis is concerned, it plays a very important role in the neural plasticity, and the phenomena of the neural plasticity, it is very important in the development of the memory, new memory, and in learning process as well. Apart from this neuroplasticity, the neurogenesis, it is also involved in maintenance of the homeostasis within the brain and CNS. Crucial factors which are involved in the cognitive functions and repair of the damaged cells, they also affect the brain disorders. They are also associated with the adult neurogenesis. The clinical conditions which are affected by the neurogenesis, affecting neurogenesis, includes stress, depression, inflammation, infections which leads to the meningitis, or chronic alcoholism. These are the factors, some of the clinical conditions which are negative regulator of the neurogenesis, whereas the ischemia, seizures, trauma, they tend to increase the neurogenesis up to a certain level, but from that stage up to a certain stage, and then the neurogenesis start declining until and unless there are positive regulators giving either they are present endogenously or given exogenously to further maintenance of this neurogenesis. The clinical applications of the neural progenitor cells have the widespread clinical applications, including the cerebral ischemic injury, in multiple sclerosis, in brain tumors, as well as they also have the clinical applications in the diseases like Alzheimer's and Parkinson. In order to study the neurogenesis, there are stage-specific markers which plays a very important role in order to track that which type of the cells are present in this process and at what stages they are present, because they specifically determine the stages of the neurogenesis. Because in earlier slide, I've already shown you that the stages of neurogenesis is not only the just the sprouting of the new neurons, but they go through a complex process like proliferation, migration, and then in differentiation into the specific lineage of the cell where it is required. And over here in this slide, you can see that these are the specific markers which determine the stages of the neurogenesis. This slide basically also showing you the different markers which are used as a technique or to track down the different stages of the cells or neural progenitor cells, which are destined to go either into the neuronal lineage or the glial lineage of the cells. Apart from that, this stage-specific markers, in order to track down the neurogenesis, there are various signaling pathways which are very specific for the neurogenesis, and this signaling pathways also help in tracking down the stages of the neurogenesis. Now, as far as the treatment is concerned, despite the advancement in the understanding of the neural cell and neural cell death and the regeneration, still up until now, to date, a specific treatment or which can revert back the neurodegeneration is still not progressed to the limit where it should be. And people are working on different aspects of it. Well, in our group, we have focused on the use of the natural product for the neurogenesis, basically because the plant-derived natural compounds are reported to be efficacious in treating various human diseases, including the neurological disorder, neurodegenerative diseases as well. And natural compounds and the potential effect on neuroprotection and neuroplasticity are of great interest to both the scientists as well as to the general public. While studying in this area, the methodology that we have used is to culture the primary, we have made the primary cultures from the neonatal brain. Basically, they are dissected out from the 2 or 3 days born pups, and then we have dissected out the cortex and hippocampus, and then we have grown it in the specific cell culture media, provided with the nutrients which are required to maintain these populations of the cell. Once we get a specific, appropriate concentration or population of the cells in vitro, then we screen the various compounds isolated from the natural products, and we tested them using the MTT assay, LMR Blue and BRDU assays. MTT assay was the very initial screening test that we have used. It is just to see whether the compounds that we are using in this neurogenesis study, they are toxic or not, or also whether they support the proliferation of the cell population that we are interested in or not. And then after that, once the proliferation capacity or potential of the compounds are determined, then we move on to the morphological determination, to see which population of the cells is prominent in our culture, and then we have moved on to the analysis of the specific genes which are fate specific for the neurogenesis, and we have also done the immunocytochemistry of the protein markers of the same gene expressions. And you can see over here some of the markers that we have used in the study of our compounds. Moving on to the results, like I said, that we have started with the initial screening, in vitro screening of the compound for the cell proliferation activity. We have used several compounds, and out of that, we have seen that 4 of the compounds that we have tested, including isoxyletones, Z-acid, which is basically a derivative of the isoxyletone, DTA, it is one of the peptide, natural peptide, and quinic acid, which is very abundantly found in the plant. These 4 compounds have shown us a maximum proliferative activity both in the hippocampal cells and cortical cells. Now, however, we have the data that I'm going to present over here that will going to only restrict myself to the use of the easy isoxyletones. Basically because we have already tested this compound in our anti-epileptic assays as well, and it has given a very good results over there. So we thought of using this compound first to see whether they also support the neurogenesis or not. And this work has also been patented in US recently. This is showing you just the morphological picture of the cells which are cultured after the treatment with the isoxylitone. So you can see over here that after 24-hour treatment, the isoxylitone treatment started to not only proliferate the cells, but it is also inducting the differentiation of the cells into the neuronal-like cells. This is the picture of the hippocampus, culture of the hippocampal cells. And over here, you can again see that as compared to the control cells, again, the isoxylitone treatment, it is inducting the, not only the proliferation, but also the specific differentiation of the cells into the neuronal-like cells. Then we cultured the same population for further 48 hours to see whether after 48 hours this compound becomes toxic to the cells or whether it is also supporting the further maturation of the cells as well. And to our surprise, we have seen that the treatment of the isoxylitone, it further destined these differentiated cells towards the maturations into the neuronal-like cells. This is again the hippocampal cells after the 48 hours treatment, and you can see a clear difference between the cells which are not given any treatment of the compound and the cells which are treated with the isoxylitone. Then we move on to the BRDU and LMR blue test just to see after MTTSA to see whether it is also supporting the actively metabolizing cells or not. And what we have found that both the BRDU incorporation assay and in LMR blue assay, we have found that the isoxylitone treatment increases the population of the cells which are neuronal-like in hippocampus as well as in the cortex. So after seeing this effect of the isoxylitone on the cultures, hippocampal and cortical cells, then we move on to another query that we wanted to see that whether this compound is also active enough to revert back the effects induced on the cells after the hypoxia. So we have given the 2-hour hypoxia to the cultured cells and then given the treatment of the isoxylitone, and to our surprise that we again have seen that the isoxylitone treatment given for 24 hours as well as for the 48 hours, it revert back the hypoxic injury and revert back the cells towards the proliferation and differentiation stages. And same observation were made in case of the hippocampal cells. And in the hippocampal cells, we have also seen that after 24 and 48 hours treatment, isoxylitone was active enough to revert back the damages caused by the hypoxia. After saying this, that we then move on to the another aspect of the study that now we know that the isoxylitone is supporting the proliferation and differentiation and differentiation of the cells. They are also active enough to revert back the hypoxia-induced damages in the cells, then we questioned ourselves that is it also active enough to mature the differentiating cells into a mature neuronal-like cells or not. So for that, we have used different fate-specific markers in immuno studies. For neuronal lineage marker, we have used Nastin, which is basically shows the presence of the neural progenitor cells. Then we have used the glial progenitor markers as well to see what population of these cells after the treatment with isozalitone end up into the glial progenitor lineage. Then we have used the markers of the immature neuron, which is TOUCH1 or beta tubulin 3. And then we have used the markers of the mature neurons as well to see if the what population of the cells are now differentiated and matured into the neurons. So for that, we have used the calbindin or calvitinin. Okay, this slide shows you the hippocampal cultures after 24 and 48 hours treatment with the isozalitone, and you can see over there here in the slide that the with the treatment of the isozalitone, the Nastin markers is expressed highly in case of the hippocampus treated cells treated with the isozalitone, and both at 24 and 48 hours, you can see the expression of the Nastin, which shows that it is activating the neural progenitor cells. In the cortex, we have seen almost the same result, but however, the expression of the Nastin was slightly less in case of the cortex compared to the hippocampus. This is just the graphical illustration of the immunocytochemistry that I have shown you in the earlier slides. Then we have, like I said, that we have also done the immunocytochemistry for the glial lineage markers, which is GFAP, and we have seen that the GFAP was much more prominent in the cortical cultures as compared to the hippocampal cells, which is according to the studies, it also shows that in hippocampus, the neuronal lineage markers are much more in abundance. Okay, then we have done the tubulin, which is basically a marker of the immature neurons. And over here, you can see that in 48-hour treatment, the concentration of the tubulin increases. But in case of the hippocampus, you can see the expression of the tubulin is much more as compared to the cortical cells. Then we have also used calvitinin or calbindin, which is basically a marker of the mature neurons. And we have seen that in case of the cortex, although it is also increased, but in case of the hippocampus, you can see a prominent expression of this calvitinin or calbindin marker in both 24 and 48 hours culture, which are treated with the isozalitone. Then after finding the effects of the isozalitone on the fate-specific marker, we also wanted to see that what effect this isozalitone have on the transcription factors, which are specific for the neurogenesis. And for that, we have selected NeuroD1 and Neurogenin 2. And to our surprise, we found that along with the fate-specific markers, the isozalitone treatment, it also increases the transcription factor, both NeuroD1 and Neurogenin 2 in hippocampus as well as cortex. But over here, you can see in the hippocampus, the expression level is more as compared to the cortex. This is Neurogenin 2, which is another neurotranscription factor. And you can see over here that in the hippocampus, it is also expressed highly after treating with the isozalitone. So basically, wrapping up these results, what we found that the isoxazolone, it has the growth supporting potential, both in case of the hippocampus as well as the cortex, and it activate the progenitor cells lying in this region of the brain. And they also destine them to the proliferation as well as the differentiation. The activity of the isoxazolone might be modulating the expression of the underlying molecular markers associated with the neurogenesis, and specifically those markers which I have already included in this study. Isoxazolone, it also increases the differentiation of cells into neurons by modulating the expression of the factors related to the transcription factors related with the neurogenesis. Specifically in case of our study, it is NeuroD1 and neurogenin. Some novelty in our research work was analyzed using the culture cells with the bone marrow stromal cells as well, but I have not shown the data of those experiments over here. The future goal of our research is to determine the mechanism underlying the action of the isoxazolone on survival and maturation of the neurons. So basically, we are going to chase the signaling pathways which are involved in this survival and maturations of the neurons after the treatment of the isoxazolone. Apart from that, we are also looking forward to make a in vivo model of the neurodegenerative diseases, and to see how this neurodegeneration can be reverted back after treating the animals with the isoxazolones and its derivatives as well. And we also are going to work on some specific signaling cascades, which are very important in case of the adult hippocampal and cortical neurogenesis. So we are going to move on to the adult hippocampal and cortical neurogenesis as well. Further, we also want to explore its mechanism on the GABA and glutamatergic receptors, as well as the markers involved in the recovery of the hypoxic cells. And this is basically our work so far. For this work, I'm going to acknowledge Professor Dr. Taur Rahman, Professor Dr. Iqbal Chaudhry, Professor Dr. Fazana Shaheen, and the students who have participated in the study, Dr. Sabah Majid, Kawal Iftikhar, Dr. Nadimul Haq, and Ms. Anila Bashir. Thank you. If you have any questions, you can ask.
Thank you, Professor Shabana. I think we have a few questions in the chat. I can read them out. There is one: is it possible to induce neurogenesis process? If possible, then it is helpful in neurodevelopment disorder treatment.
This is what I've shown over here in our study, that at least at the level of the animals, we have shown that the neurogenesis can be induced. Well, the literature now, extensively reports that even in the adult human, neurogenesis is possible, but there are certain endogenous factors as well as the exogenous environmental factors, which together participate to facilitate and maintenance of this neurogenesis.
There's another question: are there some natural foods or supplements that can enhance neurogenesis in the brain?
Yeah, in this case, most of the literature reports that the use of the flavonoids, which are very abundant in the green vegetables as well as in the fruits, they also play a role in supporting the neurogenesis at the time of the need. And we have already seen, even in the case like commenting on the first question as well, we have already seen that in the adult human, neurogenesis is ongoing process, because in case of the learning and memory, this neurogenesis is already involved over there.
There's another one: are there some natural products that may inhibit negative regulators of neurogenesis?
Negative regulators of the neurogenesis. Like I said, there are natural products, specifically coming from the plants, and there are certain marine products are also reported in the literature. I haven't checked it yet, but while going to the literature, I have seen that there are certain marine products as well which are reported to facilitate the neurogenesis.
Can't neurogenesis be negatively associated with glioma generation?
Okay, yeah, that's a very good question, because even in our study, we are right now working on different signaling pathways, both positive regulating pathways as well as the negative regulating pathway. Because if we are talking about the neurogenesis not only required for the reverting the neurodegenerative aberrations, but it also is involved in certain tumors as well, like in glioblastoma. There you have a lineage of the markers. So we are right now in our studies, we are also focusing on these signaling pathways, which are the regulator, positive regulator, and the negative regulator, because we have to keep in our mind that in our body, now, in our body or living body, there are two pathways which are always working in harmony: a negative regulator and the positive regulator, which usually we refer as the feedback mechanism, because there's always two switches. One is for positive and one is for negative. If anything increases, for example, let's say, take an example of the epilepsy, because there's a disbalance in the excitatory and inhibitory neurotransmitters, but not all the people are suffering from the epilepsy, basically because you have the homeostasis mechanism to balance one over the other. But if this balance is disorganized, then the disorders appears. So even in the signaling pathways, you have these specific pathways which are controlling the neurogenesis, negatively controlling the neurogenesis, and you have the pathways, endogenous pathways, which are positive regulator of the pathway. So balance between, or homeostasis between these two pathway or mechanism is very important to regulate. And in our lab, we are also working on this negative regulating pathways as well as the positive regulating pathways, because only answering that whether neurogenesis is occurring or not, whether this compound is inducing neurogenesis or not, it is not enough until and unless you are able to show that at what stage it is going to pull down the switch over the facilitated proliferation. Because it might end up, if you don't have a negative switch over it, then it might end up into a tumor-like condition.
Okay, we'll take just one more question. The rest, what I'll do is I'll email them to you. There are a lot of questions,
sure.
And then you can answer those. This is from Dr. Asma. She said, what type of neuronal cell lines are available in Pakistan?
Well, we have in Pakistan, we have few neuronal cell cultures in the cell lines in our institute. We have, as far as the tumors are concerned, we have the glioblastoma cell lines, we have the neuroblastoma cell lines, and then we have the normal neuronal cell lines as well. But in our work, in our group, we are using the primary cultures.
Sure. So the rest of the questions, they can be emailed to me and I'll send them to you. And once you answer them, I'll send them back to the participants. So we'll move on to our next speaker.
Our next speaker is Dr. Zehra Batul. Her recent research work is focused on the effects of pharmacological interventions on brain activity in disease as well as in normal state in animal models of Alzheimer's disease, dementia, aging, metal toxicity, and depression. The prime interest is to investigate the preventive and therapeutic strategies to cure, delay, or prevent the life-threatening neurodegenerative diseases. So, Dr. Zehra Batul, please.
Thank you, madam, for the kind introduction. And I'm thankful to the organizing committee for giving me a chance to represent my piece of research work, which we have done recently in our lab. In this research work, I'm going to present the work related to the plant targets. And in this research work, we targeted the psychiatric disorders. The psychiatric disorders, because this is the most prevalent, one of the most prevalent diseases which significantly induces global burden in all over the world. The common disorders such as depression, anxiety, post-traumatic disorder, all these disorders accounting around 42% of the global burden. Globally, the prevalence of these psychiatric disorders for the 12-month prevalence is about 17.6%, and whereas the lifetime prevalence of these diseases is about the 30%. Recently, a group of scientists has analyzed a systemic review meta-analysis, and they found the prevalence of mental disorders in WHO Western Mediterranean region, the region which consists of the majority of the Muslim countries. According to them, most of the psychiatric disorders which occur in this region include depression, anxiety disorder, post-traumatic disorder, substance use of OCD, phobic disorder, panic disorder, bipolar disorder, and psychosis. The prevalence of the depression is about the 14%, whereas the prevalence of anxiety in this region is 10%, and PTSD is about 7.2%. So research on psychiatric disorder is one of the important field to find out the disease, find out the treatment which can reduce the prevalence so that the global burden can be reduced. Plant provide important source of the active component which may have protection against neuropsychiatric disorders. Moreover, the preclinical studies provide an essential platform for the screening and identification of potential antipsychotic drugs. In this part of the research work, we have targeted the anxiety disorders. In general, the essential features of the anxiety disorders are excessive and enduring fear, avoidance of the perceived threats, and can also induce panic attacks. Why anxiety is very important to treat? Because anxiety disorders are often followed by depression and several other conditions, meaning that they can also be a risk marker for disease burden. So therefore, the preclinical studies provide a very important platform for the identification of potential targets with less harmful effects. This is because the animal and human beings share similar characteristics in the expression of emotion, which raise the possibility of studying the mechanism of the psychiatric disorder in other mammals, mainly the rodents. In these studies, the development of the animal models of anxiety and stress has helped to identify the pharmacological mechanisms and potential clinical effects of several drugs. So, but the important point is also that the animal model of other diseases and anxiety as well do not intend to replicate all features of the symptoms of a specific anxiety, but rather they generate a state of the anxiety that could be related to these disorders which have been seen in the human condition. So in preclinical studies in pharmacological labs, the models, there are different models which can be used to screen the new drugs, to screen the anti-anxiety drugs. For the anxiety condition, we have behavior models and we have stress models. For the behavior models, we can use elevated plus maze, light dark transition box, social interaction box, social interaction test, open field test, and pole board test. Whereas for the stress model, we can use restraint stress, immobilization stress, temperature variation stress, and electrical foot shock stress. The most important, or you can say the mostly used behavioral model in the pharmacological labs include the elevated plus maze. In the elevated plus maze, they use the phenomena of the rat that they prefer to stay in the closed and closed areas. So elevated plus space is designed in such a manner that this kind of apparatus has two open arm and two closed arm. And animal, because they are a nocturnal animal, they prefer to stay in the closed arm. So if rat is already anxious, they prefer to stay in the closed arm. Similarly, the light dark transition tests provide the same phenomena, and they work on the same phenomena that the rat in the dark box as well, more stay in the dark box. And if rat is more anxious, then the time spent in the dark box will be more as compared to the normal or healthy rats. Another different test which can be used to analyze the anxiety is the social interaction test. In this test, the targeted animal or the test animal is introduced with a new cage mate, and their behavior of interaction is monitored. Means how they are interacting with the new animal, how what is the duration of the interaction, because in the anxiety, as we see in the humans, the interaction with the new people is decreased. The duration of the interaction is decreased. Similar in this in the rodents, the targeted animal or the test animal, if it is conscious, it will be the rat will not interact with the new animal with the with high time, with the high duration. Open field tests provide exploratory activity, and in this test, animal is introduced in a new and open area. And as animals are the nocturnal animal, they will avoid the open area. So they will, if the rat is anxious, they will spend more time in the periphery. They will spend less time in the center, and animal will also express some freezing behavior or stretch and position if the animal is anxious. Whole board test is another behavior which can be used for the exploratory activity, and this behavior is routinely used in the pharmacological lab for the screening of anxiolytic drugs. Now, if we talk about the stress model, then restraint stress provide a physiological. This is actually the physiological stress. They provide a stress, and due to these, different kind of stress, animal experience anxiety-like behavior. Restraint stress in this stress, animal is closed in the cylindrical or semi-cylindrical tube with ventilated holes for a particular time, and due to this stress, animal shows some anxiety-like behavior. Similarly, immobilization stress, the forelimb and hind limbs are confined with a gentle wrapping, with a gentle tape, and for a particular time, and this again, the immobilization induces some anxiety-like behavior. A sudden change in the temperature also induce stress-like condition. Like for example, if you put the rat in a extremely cold water, like in a water with the temperature of the 15 to 18 degrees centigrade, or if you place the animal, the cage of the animal in the cold or isolated environment, like in the 4 degrees centigrade, then this change, sudden change in the temperature will also stimulate the HP axis, will stimulate the stress-like condition, and animal will show some anxiety-like behavior. And another important stress is the electric foot shock. And with the help of a single electric foot shock, animal can show anxiety-like behavior. So in this kind of the stress, animals receive mild, like for example, 0.5 to 2 milliampere for a brief period of time, like for 2 to 2 seconds. And due to this mild shock, animal can show anxiety-like behavior. So in our part of the research work, we used the combination of the behavioral model and the stress model. We use the electric foot shock. We expose the rat to a single electric foot shock, and then we monitor the anxiety using behavioral models, using the Lidak transition test, open field test, and social interaction test. To confirm the anxiety, we use the diazepam as a positive control. You can say as a clinically used drug, as an anxiolytic drug, a standard anxiolytic drug, whether our model has been developed or not. By using the behavioral model, we observed that the rats which were exposed to the single electric shock, they showed reduced latency to enter in the dark box, and they spent less time in the light box as compared to the control. Whereas the diazepam, which is the standard anxiolytic, They showed normal activity, like for example, they showed normal latency to be moved in the dark box, and they showed normal time spent in the light box as compared to the animal model. The social interaction test and the anxious rats which were exposed to electric shock, they showed reduced duration of the interaction and reduced number of interaction within novel rat, whereas the diazepam injection normalized this behavior. In open field, we monitor various kind of the behaviors, like for example, freezing, central square crossing, grooming, stretch and posture, and defecation. All these behaviors were become abnormal in the stress rats. Like for example, freezing time was significantly increased, central square was decreased, grooming was increased, stretch and posture was increased, and defecation was also increased due to the exposure of electric shock, means the rats become anxious. All these behavior was normalized due to the injection of diazepam. Now, moving towards the plant targets, which can be used as an anxiolytic, existing drugs, therapies are limited because of their potential abuse, tolerance, and then dependence. So there are some plants which can provide, can be considered as an alternative source of the drugs, like for example, essential oil. Essential oil have been used for centuries as traditional medicine, and their long history of use suggested that they may indeed be effective for the treatment of various diseases. For example, lavender, jasmine, orange blossom, and lemon have been used for their calming effects in aromatherapy since ancient time. Lavender has been shown to improve the mood, reduce anxiety, stress. It has also been used it has also been shown to alleviate the stress marker, like for example, cortisol and serotonin. And this behavior is suggested because of the presence of terpenoids like linalool, linaloyl acetate, and phenol. Rose oil, the essential oil for the rose, is also has also shown to reduce the induce the sedative, antidepressant, and anticonvulsive effect. It also induces psychological relaxation and anti-anxiety effects, and these effects are due to the presence of linalool, citrol, carbon, limonene. And these the rose oil primarily has geraniol and citronol, which are reported to reduce the anxiety. So bergamot is another plant. The essential oil of this fruit is known to relieve the symptoms of the anxiety in patient and decrease the stress marker. The terpenoids which are present in this plant contain the limonene, linalool, linaloyl acetate, and beta-PDE. So because of these evidences, we suggested that we hypothesized that the terpenoid, particularly the monoterpenoid, can be helpful to alleviate the anxiety-like condition. So we applied this drug in our stress model. So in this condition, in this protocol, we administered the geraniol and diazepam. Diazepam was taken as the positive control, and we observed that the animal exposed to the single electric shock showed reduced interaction and reduced number of interaction in the social interaction test, whereas this behavior was alleviated by the geraniol and diazepam. Light drug transition, time spent in the light box was significantly reduced in the anxiety, whereas this behavior was dose dependently alleviated by the geraniol and diazepam also. The freezing, stretch and posture, and defecation was significantly increased in the anxiety model, whereas this was dose dependently reduced in the geraniol and also by the diazepam as well. So now, if we talk about the biomarker of the stress, then stress has been defined by various physiological changes inducing activation of the pituitary gland, which leads to the activation of sympathetic nervous system and HP axis, which results in the increased secretion of cortisol in humans and corticosterone in rodents. The increased glucocorticoid produces various stress responses such as increased heart rate, palpitation, and anxiety. As well as there's also an interplay between the corticosterone and the neurotransmitters such as noradrenaline, serotonin in various brain regions, including the hippocampus. Like for example, acute stress has been shown to increase the noradrenaline level, which also produce a stress and anxiety-like response. Moreover, serotonin level is also suggested to be increased following the acute stress. So in our experiment, we also analyzed the plasma corticosterone level, which was significantly increased in the stress rats, and which was normalized by the rose dependently by the geraniol and diazepam as well. The hippocampal serotonin and 5-HI level were significantly increased, which was decreased by the geraniol and the diazepam. We also find the increased noradrenaline level in the stress rats, which was normalized by the geraniol and diazepam treatment, whereas other monoamine like dopamine and their metabolite DOPAC and HPA were significantly increased in the stress rats, and they were normalized by the geraniol and diazepam treatment. Besides these biomarkers, EEG recording also provide an important aspect to study the neurological disorders. This is used as a marker for determining the presence and dynamic of various neuropsychiatric disorders. For example, alteration in EEG oscillation have been reported in anxiety disorders, such as an elevated theta rhythm have been identified in students with anxiety disorder recently. This study was reported very recently. Moreover, increased power of low beta and high beta waves have also associated with fear, anxiety, and hypervigilance. Fortunately, a similar frequency power profile between human and rodent cortical EEG records is observed that allows rodent modeling to study EEG profile of human neuropsychiatric disorders. So because of this reason, we also analyzed EEG recording. For this purpose, we perform another set of experiment in which we followed the same protocol, and after treatment, we analyzed the anxiety-like condition using elevated plasmase, and then we recorded the cortical EEG. The stress animal showed the anxiety-like condition, which was alleviated by the treatment, which showed the confirmation of the induction of the anxiety and alleviation of the anxiety by the treatment. Moreover, the EEG oscillation was quantified, and it was observed that stress rats showed high power of the low beta, high beta, and gamma. The theta was also increased in these rats. And the treatment, geraniol dose dependently reduces normalize the low beta, high beta, and gamma, and diazepam also showed these similar effects. While studying the anxiety using EEG oscillation, an important data is drawn, which is the delta beta wave coupling. The increased delta beta wave coupling represent enhanced cortical and subcortical crosstalk, which is the consequence of anxiety response. In our data, a strong delta beta coupling was also observed when the correlation was drawn between the power of the delta and beta waves for the control and anxiety groups, while this correlation was not observed for the control and all three treatment groups. So this can be suggested that the crosstalk in between the cortical and subcortical region in the treatment rats was reduced, and this crosstalk may be reduced because of the decreased neurotransmission, as we seen by the neurotransmitter data. So in conclusion, electric foot shock is a useful rodent model to screen and explore the anxiolytic effects of the compound. And moreover, the plant-derived compound like the terpenoids, more specifically the monoterpenoids, have a great potential to combat the stress and anxiety. In our study, geraniol was found to reduce anxiety-like condition by normalizing the stress hormone and neurotransmitter, leading to normalized cortical oscillatory activity. Future research is needed to identify the mechanism. There are some research which have reported the activity of geraniol towards the GABA A receptors. So we are working on it in our lab, and we are trying to identify more specific mechanism of geraniol, how this geraniol is producing anti-anxiety effect. And we are also working on some formulation which can be useful for the human population in future studies. At the end, I would like to acknowledge International Center for Chemical and Biological Sciences for providing the funds and facilities to complete this project. I must acknowledge Reza Desai, my MPhil student who worked on this project with full determination and dedication. I would also like to acknowledge Ayman and Asad for their help and support in the lab work. I would like to acknowledge Professor Dr. Saida Haider, my PhD supervisor, for her guidance and motivation, who is always there whenever I need it. I would also like to acknowledge Professor Dr. Daraksha Halim to giving access to her lab facilities. My acknowledgement is also extended to Professor Dr. Shabana and Professor Dr. Farzana and all the members of the ICCBS who helped us and guide us in different aspects. At the end, I would like to thank you for your patience. Is there any questions, please, you may please ask.
Thank you, Dr. Zara. I'm looking at the chat if there are any questions. There is one, but I don't know. It says, can you share any video links to perform open field tests in rodents?
Please repeat it, video link.
She's asking, are there any video links? 1 second. To perform open field tests on rodents.
Yeah, they are very, video links are available on the internet. You can go to the Jove website and they have uploaded very important protocols related to the pharmacological lab. You can identify those links there. But if you still need some links, then I can find those links and I can send them.
Okay, I think. Okay, there are a few questions from Ms. Lubna. Over 18 years. How much time there be between two behavioral tests?
Please repeat it again.
How much time difference must there be between two behavioral tests?
Two behavioral tests.
Yes.
There must be a very specific time so that the rat can be rest between the behavior. The rat should not be undergo repeatedly in the behavioral test. Almost a rat should undergo for the rest of the 2 to 3 hours for going from one behavior to another behavior. So between this time, you can perform one behavior, and then when you start the second behavior, the time of the first rat will be approximately 2 to 3 hours.
The other question is, for how long we can give restrained stress?
It depends upon your protocol. There are various publications which is reporting the different time. The minimum time is the 2 hours, and it can exceed to the 6 hours. So what kind of anxiety or how much severe anxiety you want to induce in your animal, you can select the time and you can optimize. You have to first optimize in your lab and then you can follow the protocol from 2 hours to 6 hours.
Okay, those were all the questions in the chat. Thank you, Dr. Zara. And I think we can move to our final speaker, if Professor Daraksha can introduce him. It's a recorded lecture by Dr. Farooq, and then we can play the video.
Our next speaker is Dr. Farooq Azam Rathore, FCPS, OJT from USA, MSc in Pain Medicine, Consultant and Associate Professor, Armed Forces Institute of Rehabilitation Medicine, Executive Board Member and National Representative, Asia Oceanian Society of Physical and Rehabilitation Medicine. So, Dr. Farooq Azam Rathore, please.
Assalamu alaikum and good afternoon. I'm Dr. Farooq Rathore, consultant in rehabilitation medicine from Pakistan. I represent Pakistan at a number of international organizations, and I'm also involved with Cochrane Rehabilitation. And today I'm going to talk about neurorehabilitation services in the OIC countries. Before I formally start my presentation, I feel it is important to know what neurorehabilitation is all about. Because in public and even in healthcare professionals, there are a lot of confusion that what is neurorehabilitation. For many, it only means some form of physiotherapy or advanced exercises. But this concept is not holistic and incorrect. Neurorehabilitation is defined as a dynamic process which helps patients with neurological disabilities to optimize their physical, cognitive, emotional, and social functions for maximum independence and social integration. This process must involve a rehabilitation medicine physician or what we call a physiatrist as a team leader. As you can see, that neurorehabilitation is not a static process. It's a two-way dynamic process which involves not only the rehabilitation team but also the patient and the family and the caregivers. In addition, this is not something that sometimes can cure the patient, but we know that many of the neurological disabilities are not curative. They cannot be cured by the current medical treatment. And some of the neurological disabilities, specifically the neurodegenerative, are going to progress as the time goes on. So what do we need to do in these kind of patients? We have to maximize their independence and social integration by focusing on their physical, cognitive, emotional, and social potentials and function. And this is what neurorehabilitation is all about. Neurorehabilitation can be offered in a multitude of conditions, ranging from stroke, different kind of brain injuries could be traumatic and non-traumatic, CNS demyelinating disorders like multiple sclerosis or acute demyelinating lesions, spinal cord injury which could be both traumatic and non-traumatic, and by the way, non-traumatic spinal cord injuries in form of spinal infections and transverse myelitis are pretty common in the developing world. Neurodegenerative disorders, pediatric disabilities like cerebral palsy or different form of spinal dystrophism, peripheral nerve injuries and polyneuropathies including GBS, and neuromuscular disorders like myopathies and neuromuscular disorders like myasthenia gravis. This is a classical paradigm that how neurorehabilitation team is built and how do they provide service. So as I just told you, neurorehabilitation is a teamwork. It's not a job of an individual physician who sits in the office and gives prescription. It's a job of a teamwork. Every team member brings in a certain skill set, and that skill set is used to assess the disability of the patient and then to optimize their health condition depending on their potential. This neurorehabilitation team classically must include a rehabilitation medicine physician or a qualified physiatrist, then a neurologist, a colleague who helps us, occupational therapist, a physical therapist, prosthetist who makes splints and supports, psychologist who takes care of the mental health of the patient with disability, a speech therapist who would evaluate dysphagia and communication disorder, and at the center of this team is patient. And this is what a neurorehabilitation team looks like. The first comprehensive report on disability was the World Report on Disability by the WHO and the World Bank, which came in 2011. It's an excellent report, and the salient feature of the reports are that disability prevalence is high and growing. They estimated that around 15% of the world population was having some form of disability, and at that time they estimated it to be 1 billion people around the world. And the current estimates are around more than 1.5 billion people around the globe. And disability disproportionately affects the vulnerable population. And one of the vulnerable population is the people who are placed in developing world because of low access to healthcare resources. And in addition, people with disabilities have worse health and socioeconomic outcome. Now, if we correlate this with the situation in the OIC countries, so we would note that majority of the OIC countries at present are classified as low income countries or low middle income countries, which means that they are sharing a huge burden of disabilities, which is neither documented or does not get services that they require in form of an adequate early multidisciplinary neurorehabilitation. In addition, for most of the OIC countries, because they are developing countries, their healthcare systems are not well developed. In case where healthcare systems are developed, they are more geared toward management of infectious disease and acute medical management. And rehabilitation services and structure are either non-existent at all, or they are not very well developed, or they are not prioritized. As a result, many people with neurological disabilities and illnesses, and I told you the whole list: stroke, multiple sclerosis, ADAM, childhood disabilities, PNS disorder, and all these people, they get neglected, thus adding to a huge global burden of disability. So with this background in mind, I decided to conduct an online survey and a cross-sectional survey on the neurorehabilitation services in the OIC countries. So what I did was that I made a Google form because free, it's accessible and can be shared with anyone. The main components of the form were the demographic data of the person who responded to my survey, the kind of rehabilitation services available in the country. Specifically, I talked about the neurorehabilitation services and broke down into different components, then the type of services, the training available in neurorehabilitation and for whom, then the local guidelines on local diseases if available. I also inquired about the membership of World Federation of Neurorehabilitation, and I asked them to give different kind of comments on the neurorehabilitation services in their countries. Identification of resource person was a big challenge for me because honestly speaking, as I just told you, neurorehabilitation services are not that well developed and we are not well connected, at least in the OIC region. So what I did was I went online on ISPRM, which is International Society of Physical and Rehabilitation Medicine, and I tried to get the email and contact address of key resource person for rehabilitation in that country. I also explored the website of World Federation of Neurorehabilitation, National Society's web pages, and then snowballing technique. Because I have a large group of people working in different parts of the world, I collaborate with them and I asked them and requested them to identify the right person from different countries, OIC countries, whom I could approach and ask to fill in this questionnaire. So this questionnaire was distributed in the first week of January, and then I sent another reminder in the third week of January. So this is a bit unfortunate, but despite my best effort and snowballing and asking my colleagues, out of the current 57 countries which are members of OIC, I was able to locate the valid contact and emails of only 20 countries. So it actually represents less than 50% of the OIC countries. And out of those 20 countries and 20 emails that I generated, my response rate was 60%. So only 12 colleagues from these countries responded to my email survey. It includes Afghanistan, Albania, Bangladesh, Brunei, Benin, Cameroon, Indonesia, Iran, Morocco, Saudi Arabia, Pakistan, and probably Turkey. Yeah, I filled a survey from Pakistan myself. So these are the results. So as you can see that most of the people who responded to the survey were actually in the senior hierarchy. Some of them were professors or attending consultants or head of department, and at least one of them was actually the president of their own local PMR society. Again, I'm only going to share the results without giving any comments, but this was a bit surprising for me because I know that these kind of services are not freely available in most of the OIC countries, but whatever I saw, I'm going to share with my colleagues. So the first question was, are rehabilitation services available in your country? And almost all of them said yes, in some form these services are available. That was great. Then I asked, are specialized neurorehabilitation services available in your country? And majority said yes. But again, some there are two countries that one located in Africa and one in Afghanistan said there are no specific neurorehabilitation services available in their country. So I then inquired what kind of neurorehabilitation services are actually available. And as you can see that most of the countries had a good stroke rehabilitation service system in place, followed by spinal cord injury and pediatric neurorehabilitation, because these three constitute the majority of the disorders in neurorehabilitation group. Then some countries had neurorehabilitation for multiple sclerosis, traumatic brain injury, and neurodegenerative disorders. Some countries also offered neurorehab for neuromuscular disorders. Then I inquired about the training programs, and here it's sort of like divided equally between different countries. So in some countries it was available only for physician. In some countries it was available only for rehabilitation professionals like physical therapists, occupational therapists, and speech and language pathologists. And few of the countries had a training program both for the physician and team members of a neuro rehab team. Unfortunately, in quarter of the countries that I surveyed had no training program, indigenous local training program in neurorehabilitation, either for the physicians or for the rehabilitation professionals. So what is the estimated percentage of population which has access to neurorehabilitation services? And again, as you can see, so very few countries said that around 100% of their population has access to neurorehabilitation services. And these were the countries which are actually located in the higher income zone. For majority of the countries located in Asia and Africa, the access to neurorehabilitation services was less than 25%. And this is a matter of concern actually. Imagine a country having a population of more than 100 million and a huge disability burden, and less than 25% of the population has access to neurorehabilitation services. Then I inquired that is there a professional organization or a society of neurorehabilitation in the country? And the good news was around 70% of the respondents, that around 9 out of 12 said, yes, there was a specific neurorehabilitation organization available in the country. 2 said no, and 1 said, I don't know. And then, this is we have to network with the global world. So one of the networking in neurorehabilitation is to become a member of World Federation of Neurorehabilitation. As you can see that, most of these organizations in neurorehabilitation were not the member of World Federation of Neurorehabilitation, and only a quarter, that is only 4 out of 12, were member of World Federation of Neurorehabilitation, which is at present the largest global consortium representing neurorehabilitation professionals based in different countries, including developing countries and OIC countries. Then there's depending on the system, ideally a neurorehabilitation service or a rehabilitation service should be maintained, managed, and delivered in under the supervision of a qualified rehabilitation medicine physician. But sometimes it's not possible. So I asked this question to my colleagues, and most of them, like around half, said yes. Primarily, it is the rehabilitation medicine physician who delivers rehabilitation services in form of a team network. But in many cases, since we know where rehabilitation medicine physicians are not available, our colleagues in physiotherapy and occupational therapy, they are providing services. So around 1.5 quarter of the countries, around 5 out of 12, they said that around the neurorehabilitation services are primarily provided by the physical therapist. So these are the different models of neurorehabilitation services that are being provided in the OIC countries. So as you can see, unfortunately, it is a global reality that most of the expenses for rehabilitation are borne by the patient from their own pockets. And that's why it becomes a huge financial burden for a person who is undergoing disability. And but in some countries, 8 out of these 12, there was a publicly funded or government sponsorship available for neurorehabilitation services. And then most of them had to pay it off pocket by the patient. Private insurance was available to some, and in some cases it was also available through philanthropic support. And probably here comes the concept of that Islamic concept of philanthropy, which we can actually use in order to provide good quality services to patients who are in need of neurorehabilitation services in OIC countries. So these are the different models of neurorehabilitation services. So majority of the countries where neurorehab is available, they provided this service in both in inpatient or indoor and outpatient. Some also provided day service, and some countries, specifically Indonesia and Malaysia, also had community-based neurorehabilitation network available, which is very important, by the way. And again, asking the question, which members of a standard neurorehabilitation team are available? So as you can see that physical therapists are available almost in every part of the world, including OIC countries. And then you have rehab medicine physician in around 11 out of 13 countries, and then speech language pathologist, orthotist, prosthetist, and clinical psychologist. Social workers and the vocational counselor was unfortunately available only in one country, and that should be a matter of concern. Because medical management is good, it's great, but you need to reintegrate the person socially back into the society. And for that, you need to have a social worker or a vocational counselor. Nowadays, we all know that different diseases present differently in different parts of the world. So it's better to have your own local guidelines on different diseases instead of just like following the guidelines issued by a European country or Northern American country or Australian or Australia, because sometimes those guidelines are not contextual and they don't apply in the lower middle income country context in which we are living and working. So I asked the question, are local disease specific neurorehabilitation guidelines available? And around 40% said yes, but again equal number said no. So and some said we don't know. So I honestly, on ground, very few countries have specific neurorehabilitation guidelines which cater for their own population. Teleconsultation is a rapidly emerging thing, and it has gained a lot of scope in the aftermath of COVID-19. So in response to the question that is teleconsultation for neurorehabilitation available in your country, so majority said it is not available. There could be multiple reasons for that. Maybe they are developing countries, the internet network is not that strong, IT is not well developed, but it is something that we need to think on. So this is very interesting and gives you a first-hand perspective of my colleagues working in their own respective countries in the field of neurorehabilitation. So the last question of the questionnaire was, do you have any other comments and insights on neurorehabilitation in the OIC countries? and there were excellent and very diverse kind of guideline insights. So my colleague from Bangladesh said neurorehabilitation in the region is a new concept. SAR countries, that is countries located in Southeast Asia, have good potential to build up physiatrist-led rehabilitation teams. My colleague from Brunei said it would be great to collaborate and learn from different countries about practice of neurorehabilitation. Another colleague from Afghanistan said that most of the neurorehabilitation services were not being provided by indigenous local people. They were being provided by the International Committee of Red Cross and Red Crescent, the Swedish community, and the Handicap or HI International. Again, it is a food for thought for OIC countries that we need to support other OIC countries in establishing healthcare services and particularly neurorehabilitation services. Then my colleague from Cameroon, Africa, a developing country, said that some human resources are available, but there are no global policy regarding neurorehab in their country. And some private associations are also training their rehab healthcare professionals. So colleague from Indonesia informed us that neurorehabilitation society in our country is not well established, but we do have subspecialist neurorehabilitation physician in the country. And as is the case in many countries, insurance does not cover orthotic, walking aids, wheelchair, and botulinum toxin for spasticity, at least in Indonesia. Then colleague from Turkey revealed that the patient in the need of neurorehabilitation, they receive both inpatient and outpatient neurorehabilitation services, but within the general rehab department. And in addition, the Turkish Society of PMR, which is by the way very active and doing a lot of work in their own country, they have developed specific neurorehabilitation working groups and guidelines, specific and contextual to Turkey. And colleague from Morocco revealed some really good enlightening things. So they have a module on rehabilitation in undergraduate medical education. They have practice guidelines for home care for stroke and spinal cord injury. And they have recently in 2020 started a one-year university diploma program in adult neurorehabilitation. So I end my talk on a call for action, or what I call a work plan. These kind of presentations and these kind of workshop are excellent because they bring together expertise and people with knowledge from all around the globe. But it would be very important to actually consolidate this knowledge and come up with a genuine action plan, a work plan on which we can work instead of simply going back to our lives. So this is what I propose to my colleagues in OIC and comstech in particular. So probably I started with a very small survey, but I feel there's a need for a large survey to determine the burden of neurological diseases in the OIC region. And probably we can also work toward establishing an OIC neurological disease registry in the long term. Then we need to know the current status of neurorehabilitation services in all of the OIC countries. This was a very small survey which was representative of less than a quarter of these countries. So probably this does not capture the whole picture. Then we need to develop neurorehabilitation services, and we can do that by sharing of knowledge, experience. We can do exchange programs in countries who have well-established neurorehab programs, and then we can actually do online courses. This is a virtual conference, which means that people don't have to travel, but they can share their knowledge from their own offices and from their homes. Then probably we might want to create country or OIC specific neurorehabilitation guidelines, because OIC countries are Muslim majority countries. We have a different perspective. We have some certain different issues, and maybe we can somehow sort of like create Sharia compliant kind of guidelines which integrate the Islamic principles along with the medical principles. Will be a unique things, but will be doable. In addition, many people, researchers, students, faculty members based in developing countries, and especially OIC countries, are doing a lot of good work. But unfortunately, that work does not get published because of lack of resources. So probably comstech and OIC Secretariat can work on this, developing grants and giving them support for publication in high-ranking international journals so that their voice and their good quality data reaches a global audience. So thank you all for your patient listening. If there are any questions, comments, and additions, feel free to email me at farooqrathor@gmail.com. So thank you again and have a great day. Assalamu alaikum.
Thank you. Dr. Dalakshan, I have a comment and a question to Farooq.
Oh, yes, please. Go ahead.
Okay. For Colonel Farooq, thank you very much. I think that was a very interesting data. I haven't seen such kind of data before. So I must congratulate you for taking time to do this research. I think you should publish this research and extend this research.
And we need the same kind of research even in Pakistan among physicians to learn that what kind of information they have. But how difficult was this to conduct this study? Like how much time did it take, or how much energy did it take, or do you think how much could we extend this across all the OIC countries if we make a good effort?
Sir, thank you very much for your question and for the appreciation. It means a lot. And thank you for your support for rehabilitation services throughout the years. Sir, again, because of the access to internet, I would rather say if I was asked to do this survey 10 years back, it would have been nearly impossible. But since, like I know people, I was able to go online and locate their email addresses. I could do a snowballing. I could ask my friends to locate people. So yes, it was a bit tedious job because difficulty of locating people. But then making an email and sending them was a pretty easier part. And then I was actually able to resend a reminder, and that actually made my life easier. But as you can see, out of 57, I was able to reach out only to 20 countries because I did not have any sort of their contact. So probably if I get more time and if we can collaborate with OIC Comstech, we should actually do this survey on a larger scale, not only in the OIC countries, but probably in the larger developing regions of the world. And that would actually give us a snapshot of what's happening on ground regarding neurorehabilitation services and different kinds of disabilities that are adding to the global burden of disease. So it's a good idea and I'm all for it. Thank you very much.
Thank you.
Thank you very much, Dr. Azam Farooq Rathod. In conclusion, I would like to say that there were 5 very competitive talks given here. The first talk which I gave was on targeting shared serotonergic mechanism for improving treatment outcome in depression, chronic pain, and the comorbidity. The second talk presented by Dr. Farzana Shaheen was on the work on preclinical development of novel drug candidates for preventing epilepsy and stroke. Shabana Simji, the next speaker, she talked on precursors for regulating neurogenesis for reducing neurodegenerative disease burden. And Dr. Zahra Batul, our fourth speaker, she described animal models of for drug screening, particularly for potential anti-anxiety drugs. Dr. Farooq Azam Rathod, he presented work, actually he targeted neurohabilitation, requirement of neurohabilitation services in OIC countries and the necessity of these services to reduce disease burden. So symposia like this, I'll say, the host, Dr. Wase, the co-host, Comstech and everything, that these types of symposia are actually required to promote neuroscience understanding our students and also at professional levels by the doctors. Thank you very much.
Hasib?
Yes, sir. So that marks the end of session 5. I would like to thank once again Professor Dr. Darshan Halim and Professor Dr. Farzana Shaheen for being the chair and co-chair for the session, and all the speakers for their great presentations. I would now hand over the floor to Professor Dr. Mohammad Wase for his concluding remarks to summarize this whole conference and how we are going to take this forward. Over to you, sir.
Thank you, Hasib and Haris and all the Comstech and IEC-CBS staff. I think this was one of the most inspiring conference for me. I have organized so many conferences over the year, but OIC is so close to heart, and these countries, I think we have been able to generate a lot of connections. More than 20 countries participated at this conference. We had more than 300 participants. And this was a great learning experience for myself and for the whole team, all the participants from Malaysia, Indonesia, even Africa, different parts of the world. They were very inspired and excited to be a part of this conference. And this is the start, as we discussed, that hopefully this will become an annual event. So we start doing annual OIC conference. This was the first conference. So hopefully in the next years, we will be able to do hybrid or in-person conferences. And I not only thank all the speakers and participants or the organizers, especially Professor Dr. Iqbal Chaudhry, who basically had this vision to make this conference happen during even COVID, and all the speakers from different parts of the world. Now, from in future, what we plan to put all this all together, this as proceedings, and we like to publish like a paper or a book, abstract book or something like that, so people will be able to have it for long period of time. All the talks which were delivered, they are recorded as YouTube lectures. So all these lectures will be available to all the participants. So you could always look at it. And if you need any contacts, or if you need to contact any speakers, we will be able to connect you to these speakers. All of you who have filled the evaluations form, you will be able to get a certificate. And now I think once we are now going to move in the direction of OIC Neurology Academy or OIC Neurology activities, we need all of your support and volunteership. So if I invite all the participants that if you want to work with us with the comstech for future conferences, organization, and collaboration in research and advocacy and awareness, please work with us. We need a lot of volunteers across the globe. I have seen a lot of participants from Azerbaijan and Central Asia. We wanted to include Central Asia in this conference, but we were not able to connect to them. So hopefully in the next conference, we will be able to connect with them. And we want to organize conferences in Central Asia and Africa, especially for the neurology training and education. So this has been a great event. I again like to thank Haris and Hasib. They have done a great job, and all the speakers and participants. Hopefully we'll meet again and we'll get together. And our aim is to promote and improve neurological care, not only through some of these countries who have participated, but all across the OIC countries. And hopefully we will be able to achieve this goal over next few period of time. So in the end, I would like to thank all of you again, and we'll see you again soon. Thank you.
Thank you so much, Professor Vasai.